Good morning. Uh, Very warm welcome to you all to this conference, which is, you all would agree that it is so popular that it is very rare to see such a nice gathering so early in the morning. So even before, even before the conference has started, we have a good number of delegates. So welcome you all. So let's start the proceedings. Uh, the first session is on medical ethics. Medical ethics in pediatric pulmonology. I would request the first speaker, Dr. Arun Manglik, to please start his deliberation, and our sincere request to all the speakers and the panelists and the moderators and all faculties to please stick to their allotted time. We have such a busy schedule that even 1 or 2 minutes of delay encroaching upon the next session could make the entire session haywire. So please stick to your time. And Dr. Manglik, I would invite Dr. Shomik Basu also. Though both of them, aren't there any introductory slides to be shown? Though they don't need an introduction, at least in the academic field, Dr. Manglik is a very senior pediatrician and is one of the few of those who is actively involved in ethical issues in different branches of medicine. And Dr. Shomik Basu is also same, though not as senior as Dr. Manglik, but his on is. So please, Dr. Manglik, you start.
So, a very warm welcome to all of you. Good morning. No response, so everybody sleeping? So, thank you very much. So, we will be talking about medical ethics in pediatric pulmonology, and the audience is free to talk also wherever they feel they need have some input from your side. So, we're going straight to the session. This is what ethics is. Basically, ethics means trying to do something right, okay, and making sure that you don't do anything wrong. It comes from the Greek word ethos, and now you will be seeing certain other terms over there: morals, law, empathy and sympathy, conscience. We have heard all these terms. They are not part of any dictionary, but they don't all mean the same. Morals means my own morals. We used to have moral science classes in our schools. Conscience again means related to my own conscience. Whatever I am doing is right or wrong. At all times we may not be able to do everything right, but still if it hurts my conscience, that means there is something wrong which I have done. And all this, when it is a jargon, it ends up in confusion, or we need to have some clarity on it. One 3-letter word is over there, which is law. All said and done, if ethics and law are at loggerheads, please follow the law. In those situations, unfortunately, we have to forget ethics, because law still remains prime, because you got to follow the law of the land. So ethics basically is yeah, so I got to use both my hands. So ethics is now, benefit means we ensure that we give the max benefit to the patient. It stands on these 4 pillars: benefit, doing no harm, which is non-maleficence; justice and veracity, being truth; and finally autonomy. Autonomy means that we allow the patient to decide on his own after giving all the inputs, the pros and cons of whatever modality of treatment or investigations we are doing. They take their own decision, an informed decision, and that is a very important aspect nowadays. And justice means trying to be in entire society, trying to have an equivalent or services to all. Now, in society like ours, a semi-socialist or a democratic society, everybody may not get every benefit. That's true. So it's difficult to get. Veracity means being trying to be truthful, and confidentiality is definitely, we all know. So an overview focuses on pediatric pulmonology, the common respiratory issues. We'll skip this slide because we have some cases which we will try to discuss. And important ethical dilemmas which come up when patients refuse treatment. How do we go about them? For whatever reason, when they refuse treatment, that means the patient's benefit is not being catered to in the proper sense. And at the same time, we must remember the patient. In our situation, patients don't take decisions. It is their parents who take decisions. So the children are not in a fit, or as we say, frame of mind to take decisions on their own. The consent is there. We need to take consent for everything. Confidentiality concerns and resource allocation, and this is what pertains to what we talked about in the previous slide about justice. Okay. Finally, upholding children's rights is the ethical decision making. We ensure that the rights of children are protected. We may have a lot of laws, but do we all implement them? That comes an important aspect. And again, to build trust both with the patient and the guardians, because that is an important aspect. So we'll come to cases which Dr. Shomik Basu will discuss. The floor is yours.
Good morning to you. I hope we will not be boring you, because this is the first time Odunda and I am playing the role of a night watchman. Our session was the last session of the day, but we are now promoted to play as role of night watchman. Hope we don't run ourselves out. So we go to the cases. These cases are made up cases, maybe based on a real scenario. You are free to answer as an audience, because there is no black and white in ethics and law. There are large shades of grey, not 36, maybe more. So at 30 weeks, 1.5 kg baby was born in a taxi, the yellow taxi of Kolkata, while travelling from the district to the government tertiary hospital. On reaching the tertiary hospital, there was no beds vacant as usual. Over 4 hours from running pillar to post from one hospital to another, the baby started having respiratory distress. Fortunately, they got admitted via a known person with a political connection to a corporate hospital, because government hospital beds were not available, and was duly attended by a renowned neonatologist who promptly admitted the baby and started high flow nasal oxygen. After a few hours, the X-ray showed severe RDS, and the neonatologist now wants to give surfactant. Now the parents now reveal, because they had prepared themselves to be admitted in a government hospital, they don't have financial resources to buy the surfactant and give to the baby. Now in this ethical dilemma, what should you do as a pulmonologist?
So an important dilemma, and this again caters to the previous slides which we were talking about, having justice. You can't, equitable allotment of resources is not possible. This child has come to a tertiary care hospital, and surfactant is probably only part of the cost. The other costs will be quite high. That means including the bed rents, the doctor's fee, the tests, all investigations have to be paid for, all medications have to be paid for. So the overall cumulative amount is quite high. And the father, if he is unable to pay, he is very justified in saying that I don't have any money. So from the four pillars, beneficence goes for a toss, because if we are not able to do anything, the child doesn't benefit. Okay, suppose I am the hospital in charge, or I am the treating physician over there, I may just say, okay, fine, if you can't do it, go away to a government hospital and just shrug my shoulders off. Again, that doesn't end my story. I can't do that. So what are the options available to me? I can try to arrange for a transfer to a low-cost place or to a free place like a government setup. And if that is possible, and if I have the relevant contacts, and if I can arrange for a bed, that would be the best possible option, because I have done the initial management of this patient. Suppose that is not possible, then whatever options I have, whatever limited options, because sometimes these tertiary corporate hospitals do have resources by way of having some NGOs coming up and pulling in their own funds. So that this is an important area where we are not able to do whatever we would like to do as physicians. So the ethical dilemma would still remain if we are not able to do anything for the patient. So beneficence goes for a toss. Not harming the patient, do no harm. Again, if I'm not treating the patient, I'm doing enough harm. Justice is not, we just can't do it because equitable availability of resources is not there. And the autonomy, well, the patient has decided that I don't want any treatment. He wants the treatment, but he can't afford it. So all the 4 pillars, we can't take them all together. So the option would be to try to get the child admitted to a lower cost place, or to fund the cost from our own pockets or from the hospital pockets, which quite often it is not impossible. Sir. Somebody give him a mic, please.
I agree with you that in pediatric practice we face this problem quite commonly. And as you go in your seniority, what I do in my practice is that I've got a lot of my businessmen friends, and I always keep some amount handy, so that whenever I face a situation, I can always bank upon those people and they can fund the cost. So this really works well. So normally when you are quite senior off, you have got non-medical friends, your businessman friends, so you can always arrange for a fund, you can keep some money ready, and usually that comes very handy. So I found that this is very useful.
Thank you,
sir.
Thank you, sir.
Only thing for the juniors, please remember, if you want to transfer the patient, make all the arrangements, and you have to accompany the patient to the next hospital until you hand over the patient to the next consultant. That is a medical legal must. If something happens on the road, you will be liable.
Excuse me. In such a scenario, what does the law say?
Well, law doesn't say anything.
As
here.
per law, what will we do?
Law is very quiet on this. There are certain options, like most corporate hospitals have got their land at a very low cost from the government. So they have that option of so many percentage of beds to be kept free or at minimal cost. Okay, that is also there. Whether that is implemented in real life is a different story. But as he said, over here, the physician has got nothing to do. It is the hospital management who has to take the final call on it. Okay.
But
and,
we as physicians become vulnerable to
yes,
the patients.
Unfortunately, that is the biggest problem. When the patient pays 10 lakhs to the hospital, they feel that 10 lakhs has gone to Dr. So-and-so's pocket, whereas the doctor has probably got only 50K. The rest 9.5 lakhs has gone to the hospital.
Thank you.
For various costs.
Thank you, Urundar. We'll get to the next case very fast. During the antenatal USG, it was revealed that the fetus had a complex congenital cyanotic heart disease. The parents were duly informed and were asked their decision regarding post-delivery resuscitation if the child went bad, upon which the patients duly signed a DNR. The baby was born and was transferred to the NICU for observation, and prostaglandin infusion was started by their neonatologist, and the baby was doing very well for the first 48 hours. After the 48 hours, the child started to worsen, and the echo revealed severe pulmonary stenosis and tricuspid atresia. The pediatric cardiologist now wants to ventilate the child and prepare for cardiac surgery. But when the parents were then again counseled, they refused to escalate the treatment. Now you're in a dilemma whether to ventilate or not to ventilate. They had taken back their DNR, which they signed, because the baby was good for first 2 days, because it was a duct-dependent lesion as usual. Now they don't want to escalate the treatment for the baby, and if you don't escalate, the baby is going to die in next 6 hours. What are you going to do?
Well, again, a very similar situation, but the reasons are different. The reasons were commercial or unable to bear the cost. Here, possibly, they have been explained while the child was, or the mother was pregnant. They have possibly been explained about the possible poor long-term outcome of this patient. Now, once this child has come out and the pediatric cardiologist feels that this patient is amenable to future treatment and possibly the quality of life may be good enough in later, maybe several years down the line, it is the job of the peds cardiologist to sit down with the parents and discuss with them, because unless they give a definite consent, whatever ethics may say, by law I am not able to continue the treatment. The patient's relatives have been in a sort of a zigzag situation. They have said, don't resuscitate. Now they are happy with patient coming up and prostaglandin being given, the patent ductus being kept open. All that was blah, 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 fine. But once they realize that possibly this may entail, maybe cost is also at the back of their minds. But in any case, here they have not mentioned that. They are probably still worried that even after the surgery, even after the whatever management we do now, what will be the long-term outcome. That is one thing probably playing in the back of their minds. So it is the job of the treating team to sit down with them, counsel them thoroughly, and ensure that they understand the situation. At the end of the day, because that treating team would mean both the neonatologist, the peds cardiologist, and a social worker from the hospital, and possibly somebody from the hospital management also. So that not only the father should be there, other decision makers who could be involved in the family, they should also be involved, so that they can come and sit down and realize, after due counseling, which may extend into several minutes or maybe half an hour or an hour also, if they still say, then they have to give it in writing. Fine, if whatever they give in writing has to be honored, and we cannot overrule that.
So first, for all juniors, try to make a medical board if you have that facility in the hospital. Second, document everything that occurs by the time, by the minute. So we go into the third case. So a 6-year-old boy, now this is very common, not very common, but pretty common. 6-year-old boy had recurrent episodes of cough and cold over last 1 year. Every time he was treated with some syrups and omnacotyl or steroid tablets, and the child recovered in due time. But the child was never cough-free for a very long time. The patients then consulted another doctor because the child was not getting well, who told them that this could be asthma, so very good, and advised nebulization at home with SABA only, and this continued for 2 years. Now this rainy season, the child had a serious attack, admitted to the PICU, given intensive treatment, and finally recovered after 7 to 10 days. At discharge, they were told that he had a severe attack of asthma and were properly explained the use of ICH, SABA, wire spacer, everything was done, and the child parents were educated. Now the parents had only one question: why wasn't this medications prescribed earlier, spacers taught, role of inhaled corticosteroids explained, and why had they had to go through such trouble and their child faced a life-threatening situation? Why couldn't the doctors decide and treat as if he was treated right now?
Well, thank you. This sort of a history brings me to another aspect. Ethics, as we say, medical ethics, we are responsible to the patient. But isn't the parents responsible for the child? What does this history tell us? That they were given some sort of medication and they continued at home with Levolin respules, nebulizations for 2 years. And I'm not sure whether they at all consulted anybody during that period of time. So the follow-up was practically horribly, this was a zero follow-up. So how can you make the doctor responsible for all these things? He has a question, that's perfectly fine. But I have a counter question. Where were you during these last 2 to 3 years? You were managing things on your own. So had you come for follow-up, things might have been different. Yes, ethically, from the ethical point of view, it is our job to ensure that the child gets the maximum benefit and we do no harm. But maybe the child did not get that benefit because they did not follow up. And I'm sure that the person concerned who gave that treatment initially must have written down in the notes, come to so-and-so date in your follow-up. And that is very important when we say, because otherwise we can be charged from the legal point that you didn't even ask them to come for follow-up at all. So there's no fault of theirs. So here, that question that can only be answered in one line, that you did not come for follow-up, so it's your responsibility also. It's a shared responsibility. For the patient, it just cannot be one-way traffic.
So beneficence and non-maleficence. Today we have gathered here so you can learn about GINA 2025 guidelines, learn to diagnose asthma better, and learn to treat asthma as per guidelines. Sir, case खत्म कर लें, time है, case और 2 cases बोल के खत्म कर लें. Now this is a common problem of nowadays. A 17-year-old child from a very conservative, strict family from Lucknow studies in Kolkata, living as a paying guest. He has developed a chronic cough some months some months and today was brought to the emergency building with a bout of severe hemoptysis. Admitted him in the emergency, resuscitated him. Upon doing an X-ray, found a round ball-like shadow in the X-ray peripheries of the lung. On detailed history, he was a regular smoker. Further tests were needed, invasive tests were needed, and he had to be admitted for further treatment. Now the child now refuses to be admitted and refuses to inform the parents because he does not want his family to know about his smoking habits which were not known to his parents.
Thank you. Another important issue here. Now this child is coming from a family probably who would just not allow the child to smoke. Here in this situation, obviously we have, from the benefit point of view, we just cannot leave the things go. I could have an option, fine, you can bring your parents, we can talk to them. That's perfectly fine. At the same time, we must realize that if we don't give any treatment, obviously the child is suffering. Probably in the background something very serious is lurking. It says a round shadow and something very serious may be going on. So the best option would be for us, from all aspects, would be to ensure, talk to the child and make sure that he realizes that getting the parents involved, because he is still a minor. Legally he cannot take decisions on his own. So being a minor, he has to get his parents involved, and once we talk to the parents, you have to ensure that just because he had developed a smoking habit, that won't play against him too much in the family. We can talk to the family that after all he is going to be an adult in a year, so we have to allow him some leeway. And at the same time, once the family comes, first part would be to convince the child that we must have the parents involved. And once the family comes down, then we can sit down as a group, both the child and the family. Probably at that point of time, the child will be sitting with his head down and looking to the floor and not talking anything. Probably he may be ashamed of himself. That's a different story. But we have to get things done on the proper track. We got to get the parents involved, talk to the child, get the parents involved, and then counsel them that this treatment is. Once the parents understand that his development of a smoking habit was beyond their hands, they will probably accept treatment subsequently, because otherwise we do all this, unless we do all this, we are allowing the child to go into a soup.
So thank you. So remember, now we have role of adolescent counselors, and in this case try to video document or audio document the files. Okay, he might change his statements later, documentation. So last case, and then we'll have questions. Now these are common situations. A single mother brings her 10-year-old child to the clinic with severe wheezing and respiratory distress. The child was later diagnosed as asthma and was prescribed inhalers judiciously with spacer. Proper counseling was done by the pulmonologist or the pediatrician. Now she returned back with similar symptoms, and upon taking history it was revealed her mother stopped inhalers and started homeopathy. And she was again taught, again counseled, and again written proper medications by the doctor. After 6 months, she comes back again with the same distress and wheeze. This time her mother tried fish therapy. She was advised again with advice of additional vaccines too. She refused the vaccine due to financial reasons. Today, after again 6 months, she comes to my chamber again with the same symptoms, and her mother cries out that this is an emergency. So remember, you can always refuse a patient. Only caveat is that you cannot refuse a patient who comes in an emergency.
Thank you, Dr. Basu. You put me into a trap. No? I can't refuse him because it's an emergency, but the fact is the mother cries out it's an emergency. It may be an emergency. For a mother, even a 103 fever may be an emergency. But we get these calls quite often. So it may not be a real emergency. In any case, she has been doing the treatment on her own. Somewhere probably the fault may lie with us also. We have not been able to make her understand that the proper treatment would be the way we tell them. Now there are several modes of therapy like Ayurveda and homeopathy and what you said about fish therapy, and with lot of social media and publicity in the press, etc. People may be lured into those things also. But it's our job to make them understand that there is enough treatment for the asthma the child is suffering from, and if the child follows up and if the mother does the treatment which she has not been doing, which is quite evident from the history which you have told us, she has been repeatedly faulting on it. So her defaults has added to the problem. So now probably since the child has come as per her as an emergency and is probably a real emergency, then probably now she will realize her fault, and if we can sit down and counsel them, as we say nowadays, 20 or 30 years ago, it would be 80% treatment, 10% of counseling and 10% writing down your notes. Now it's probably the other way around. Your treatment for maybe 40%, your counseling another 30%, and you're writing down the notes in proper fashion so that you don't get stuck up later on is another 30%. So these reversals have occurred. Our time management has to go accordingly so that we are able to tell the parents, because it is no longer a paternalistic world where whatever the doctor says was gospel truth. I would say something and the parents accept that true. ठीक है, डॉक्टर साहब बोल दिया, that's fine. But nowadays they expect us to give us reasons. They have questions to ask, and it's our job to fulfill or satisfy all their questions. So here probably the mother will probably now understand that what she has been doing all these maybe few years or months was absolutely wrong, and she has exhausted her other options, and she will probably now come into the right track.
So the dictum for medical legal advice to pediatricians is doctor save thyself first. So always in the left side of the prescription keep a column where you write negative histories. Patient did not take this medicine. Patient did not bring the prescription pad. Prescription does not follow up in time, and always keep a column there. Now it is a mandatory thing, follow up. You have to write follow up. When does the patient has to follow up? And if the patient misses the follow up, then if the case any time goes to the court, you have a reason there. So keep two things. One is history of allergies, history of drug allergies, that is a must in the prescription right now. And another thing is follow up, and try to maintain some negative history. If there is a negative history, please document this. Sir Rawat sir, we have concluded
Actually,
our
that
session.
is what they call contributory negligence. Okay, because that saves us. Yes, sir.
So thank you so much. Now we'll have questions. Sir, on कर दीजिए ना.
Hello. So in your second case of asthma where the child was treated and the child didn't respond, I think the most important thing is that we should not blame the previous physician, because normally it has a tendency that we tell that the doctor did a wrong treatment or you would have come to us earlier. So the first thing the junior should understand is that not to blame the other physician telling that he did a wrong thing. Always try to protect him that, okay, he did whatever the best he thought and at that particular situation. I cannot comment because I didn't see the child at that particular time. So I think not giving any negative comments about our colleagues while doing consultation, that is the most important thing. And yes, we should not put blame on the patient that you did, because then it will create a negative impact. So we can always tell them that it would have been better that if the child was followed properly, then child would have responded better. Instead of trying to put the blame on the patient, either trying to tell me in a different, better manner, and secondly, most important, not trying to put blame on the colleagues. That's very important.
Thank you very much. We must avoid, as they say, medical jousting. We must definitely avoid medical jousting.
I also support his view, because today what it is correct, few years later that will be wrong. Medicine is not absolute.
Yes, but the law states that there will be no retrospective action due to the change in medicine. The present law will take its place. So if you had done a mistake 5 years ago, the norms will be taken, that the treatment norms at 5 years ago will be taken for your
কাকের মাংস কাকে খায় না, কারণ আমাদের সংখ্যালঘু আমাদেরকে বাঁচানোর জন্য কেউ আসবে না, তার নলেজেবল ব্যাপারে সে যতটা পেরেছে করেছে.
So be very careful, don't be like Nero or somebody we know very careful.
What about the revival of the 20% free bed? $1 জায়গা নিয়েছে.
Well, that's a different story. Now we can't discuss all that because that is part of the hospital management, whether the government does that, because we can't discuss all that.
Hello.
This last comment please, because we are I think short of enough of time. Yeah.
I am
please carry on.
শ্রীকৃষ্ণ দুটো মা ছিল, কিন্তু সিঙ্গেল মাদার লেখা ছিল, সিঙ্গেল মাদার। সিঙ্গেল মাদার বলতে কি বোঝায়?
Please go ahead.
সিঙ্গেল মাদার বলে শ্রীকৃষ্ণ দুটো মা ছিল।
Single mother simply means either she is widowed or she is separated divorced, whatever, the father is absolutely missing. He may be living or not living. So she is alone taking care of a child.
Thank you so much for giving
What's
us
the-
an audience
excuse me,
here.
excuse me.
Hope we have
What's-
played a good role as...
What's the role of video recording during this interview with the parents and all that? Video recording.
That
Thank
is
you.
possible in some places, definitely, particularly in big corporate hospitals, they have that system, but it's not possible in your clinic. If you can do it, make sure that you don't have that video in your examination area.
Dr. Manocha, there is a rule now in Ayushman Bharat. For every surgical case, you have to do a mandatory video recording. But always remember, when you start the video recording, take a written consent from them, and in the start of the recording, you tell that I am taking your consent. Do you give your consent for video recording? That is all that is needed.
Thank you.
so much.
Thank you.
Thank you. Thank you so much, Dr. Manglik and Dr. Basu. I request you to go to the memento section to receive Dr. Subhashish Roy. Subhashish, please accompany them. Thank you for sticking to time. The first session is on time. Next we have a panel discussion on a very important topic, rational use of antibiotics in respiratory infections. And I would invite Dr. Chetan Trivedi as the moderator, and as panelists we have Dr. Amitava Pahari. Dr. Amitava Pahari, of course, doesn't need any introduction. I would request the organizers, where are the introductory slides yes. So, Dr. Amitava Pahari, Dr. Krishan Chugh, and Dr. Ritabrato Kundu, none of them require any, they are all stalwarts in their own field. So, straight away I would request them to start. Dr. Trivedi, please. And please stick to time.
Good morning, friends. At the outset, I am thankful to PULMOCON team, Dr. Pallab Da, Dr. Subhash Da, for this wonderful opportunity. Why I am telling you wonderful opportunity is because, as you know, Kolkata is full of academic-oriented people, and that's why you see the hall is almost nearly full when the first session is going on. And secondly, I have a stalwart as my panelist. I think if I, introduce them, it will be showing Diya to Sun, like that. We have Dr. Kishan Chugh, the man from Gurgaon Fortis Hospital. We all know him. We have Dr. Amitava Pahari. He is teacher par excellence from Apollo Hospital, Kolkata. And Kundu sir, who doesn't know him, he is a Bhishma Pitama of ID chapter or ID infectious diseases. So good to have all three of them on board. And why this my talk of this rational antibiotic has been kept by organizers. I think I wanted to justify it. Yes, every time we are talking rational antibiotic, rational. But just 2 days back I came across this prescription. Are you able to read this? No? Okay, highlight it. This is a patient of acute dysentery dehydration. This is from a hospital with a proper pediatrician. Look at antibiotics. Maxon Plus, Metro, Amikacin, go down ofloxacillin, ciprofloxacillin. Anything left? You want to add anything? So this is what rationality we are talking. This is not from Jola sir type, some pediatrician, medical officer or a person. Anyway, so let us start with that. Respiratory infection, we know that can be upper respiratory, lower respiratory, can be OPD setting and IPD setting. First caveat is I am a common pediatrician doing a practice as a general pediatrician. So what I am supposed to know, I am going to discuss with the expert's opinion. So let us go to the first case. No high-fi cases will be there. A 2-year-old boy, fever high grade, 1 to 2 days, throat pain, irritability, decreased oral intake. Patient was brought to you, no vomiting, no cough, cold, and no rash. On examination, what I found is 100.5 fever, no lymph node, Rest was normal except for throat, which I am going to show you the picture. This is the picture. And we know that this, as soon as we see something like this, we have a habit of prescribing something, and that something is always azithromycin, unfortunately. So I will go to the panelist, Dr. Amidava sir, because you are teacher, so let us try to understand what is this diagnosis, differential diagnosis, and what is the rational treatment for this particular patient.
I think, most important thing here is to describe these lesions first. So this is actually, kind of enanthem, mucous ulcers involving the palate mostly, and as well as some in the, on the anterior aspect of the tonsillar fossa or something like that, anterior pillars. So any rash on that side, enanthem, which is ulcerative, small, vesicular type, you should immediately thinking about herpangina, because that's the most important diagnosis that is going to come to your mind.
Okay, so I think this is a spot diagnosis. So no need for antibiotics?
No need for antibiotics, no need for any further investigation either.
So what will be your treatment? Prescription?
Treatment is make sure the child is adequately hydrated, you are giving pain relief to the child, and that should be actually strongly reassuring the parents that this is a self-limiting illness, it's going to get over by 3 to 5 days time. And hardly is actually going to be any serious complications that we often read in the anecdotes in our textbooks.
So the message is, whenever you something, don't be happy that I got something to prescribe the antibiotics, justification to put antibiotics. Put a diagnosis as herpangina, be confident, don't do anything, just a supportive line of treatment, and you are done. Okay, next case.
I want to add one thing.
Yes, sir.
Herpangina is caused by two important viruses. One is Coxsackie and Entero. They are notorious to cause two important complications. One is myocarditis, another is encephalitis. In fact, in China, in Xi'an, many of the children died following herpangina due to pulmonary edema because they infect the brain stem, and it was neurogenic pulmonary edema. So whenever you get a case of herpangina, you should follow the patients and ask the parents to be careful about these two things. Very rarely they might develop, but they do develop.
Correct. So we know that this can be the part of HFMD. It starts with this ulcers in the mouth, and then you see the other hands and feet and buttocks. Okay, so that's a different thing, but it doesn't require the antibiotics. That's the message.
Chetan,
okay.
Just one thing, that suppose there were similar lesions on hands and feet.
That's what I told. Okay, you may wait. Initially it may be simply drooling or throat pain, and then the lesions will appear in hands and mouth. Anyways, let us go to next case. 8-year-old child presented with fever which was high grade for 3 to 4 days. Throat pain was there, cold was there with some running nose, vomiting 3 to 4 times a day, abdominal pain somewhat, and headache. On examination, temperature was normal, toxic look, bilateral cervical lymph nodes, left more than right, throat examination, and the node I will show you. So this is a throat examination, and you can see that node. Okay, so differential diagnosis. Kundu sir.
So if you see such a patches over the tonsils which does not cross over to the other places, and you see the uvula which is just looking like a red chili hanging, the first diagnosis is streptococcal sore throat. But there are two other very important differential diagnoses. One is you should think of diphtheria in our country, and also at times it can be Epstein-Barr virus, which resembles streptococcal sore throat in all the way excepting skin rashes. Another important thing is herpetic gingivostomatitis, particularly in adolescent in the late phase. The gingivitis or the ulcers, they usually are very short lasting, and by the time when the child seeks medical attention, that means after 5-6 days, you don't find any ulcers. You only find red tonsils and at times patches also that. So these are the most three important.
So clinically, sir, can you differentiate between the diphtheria and the group A beta hemorrhagic streptococci?
Diphtheria has certain things. Number one, the membrane might extend beyond the tonsillar fossa. It might go to the soft palate. And number two, in diphtheria, the membrane is certainly dirty looking. And it is written in the textbook, if you try to remove the membrane, it will bleed. But never try to do such things. This is a very, the child won't allow it at all. And the third important thing in diphtheria, you have bilateral lymphadenitis, so it gives rise to a bull's neck. And 50% of the cases of diphtheria will have fever, 50% won't. So it might so happen the child might not have fever. And the toxicity in diphtheria is much higher as compared to streptococcal sore throat. So toxicity, lack of fever, extension of the membrane beyond the fauces, and bull's neck. These are the 4 important diagnostic points, even if the child has been given diphtheria vaccine, because it is it is common that sometimes the vaccines do fail even after giving.
Sir, Kishan sir, do we need to investigate this particular child? What particular, when I see the membrane like this, do I need to go for some investigation, if at all?
Not really. No investigation is required. It's a clinical diagnosis, treat. And if by chance something develops like what Dr. Kundu has described, suppose the membrane starts going beyond or something, at this time you might think of a differential diagnosis and a investigation or a different treatment plan. Okay. Otherwise, it is a clear diagnosis.
So clinically, if you want to differentiate like group A beta, something like this score. So do we usually use this?
There, yes.
So here it has been said that if the score is still 0 or 1, do not do anything. If you have a score of 2, treat it. If the rapid test is positive. And if it is score 3, then either you can treat it if rapid test is positive. So what is that rapid test, sir?
So rapid tests, unfortunately we don't have rapid tests in Calcutta, but there are rapid tests in summer in India, particularly in Chennai, they talk of rapid tests. So it's an antigen test where you detect a streptococcal antigen by doing a throat swab. Unlike culture, which takes at least 24 hours time, rapid test can be had within few hours. If your clinical signs and symptoms matches and the rapid test is positive, then it is a very high chance you are dealing with a case of streptococcal sore throat. Start with amoxicillin.
So suppose I am going for this throat swab. So what I should order? Suppose if I am in dilemma, there may be a diphtheria or a...
One point, Dr.
Yes,
Chetan, I think what is very important in this is actually no cough. We actually see so many patients with viral tonsillopharyngitis, which is much more common than group A beta hemolytic streptococcus, and the no cough or coryzal symptom, absence of coryzal symptom is often the most important clue for a clinician to actually accept.
You don't have to do
in
anything.
this patient, there was some cold. So
Yes.
many a times it is not that crystal clear, but
Yes.
there was no cough. You are right. Absolutely.
No cough
Absence
is
of
very
cough.
important.
So
Yes.
if your clinical features matches, I don't think there's any
Need for going for any
rapid test
any
and
investigation.
go
Yes,
and give a course of
because
10
this
days
patient is
amoxicillin.
very clearly fitting into all this. Okay, fine. So, sir, role of ASO.
No, A also has no role in acute streptococcal
So what is the
infection.
worry, sir? Group A beta hemolytic streptococci. Why we are worried so much?
Because they develop non-pyogenic complications. Of the non-pyogenic complications, they might develop acute post-streptococcal glomerulonephritis, they can develop rheumatic fever, they can develop arthritis, and even they can develop central nervous system like pandas. So there is a host of diseases which are not directly pyogenic disease, but they are somewhat mediated with autoimmunity or some antigen antibody reaction of the streptococcus.
So this is the only
it needs
condition.
treatment.
So group A beta hemolytic streptococci is the only condition which we are worried in our OPD where we are supposed to give antibiotics. So you have to find out which particular patient falls into this particular, then you are justified in giving antibiotic, and which antibiotic and how long, that is important.
Amoxicillin is the drug of choice, and you should give it in the 40 to 50 milligram per kg with a ceiling dose, of 1 gram. But the most important thing, you should continue it for 10 full days.
Okay, fine. So this basic investigation.
Just to
is done.
actually add, on behalf of the pediatrician sitting here, I have not come across any pediatrician writing ASO titer investigations during acute stage, but believe me, I see a lot of ENT doctors actually writing down ASO titer during actually, acute tonsillopharyngitis.
So that's why I could put that question. So choice of antibiotic, sir, anybody will take A, B, C, D. For A, how many? For B? Why not B? So what we are targeting, which organism? Group A beta hemolytic. That is narrow spectrum. Amoxicillin amoxicillin. You don't require amoxicillin because this is 100% sensitive to amoxicillin. So this is a condition where we would like to give amoxicillin. So this patient, as I said, this was the throat swab was done. We were worried for some C. diphtheria, so we did that particular Albert stain. It was negative, and this was the case of group A beta streptococcus. As the sir said, amoxicillin, here the dose for 10 days is compulsory. We have to finish the course in 40 to 50 milligram per kilogram. No need for high dose amoxicillin. Okay. So in the case number 3, 18-month-old came with a cold cough since 2 to 3 days. It started developing fever, high-grade irritability since yesterday, so 1 day before. Fever was 101, irritability was there, throat was mildly congested, there was no lymph node, no rash. Sir, what will you do, sir, in this patient? Kishan, sir.
Well, we have an 18-month-old who has a little bit of cough cold for 2-3 days and now developed fever, right? And is irritable. That is mildly congested throat, no lymph node, no rash. Still, it is most likely to be a viral infection of the upper respiratory tract.
Any other examination I have missed in this?
Yes, examination of course, and history also. I'm just sticking to what you have provided. Whenever such a case scenario is given, limited points are given to us, and it's just because we are trying to send a message. Otherwise, we will always go into complete history and look at what all has been happening till now. So, ear pain was not even asked for. And irritability can be a cause, and 18 months is not going to tell us that he's having a ear pain. Sometimes, since he's touching the ear again and again, and parents may have noticed it. And so, otitis media as a complication of upper respiratory tract infections, causing a lot of irritability is one, and a nose block the second.
Right. So my examination is never over in this case without otoscopy. What am I expecting in otoscopy? We need to diagnose AOM, acute otitis media.
Dr. Chetan.
Yes, sir.
Can I ask the audience, to be honest, how many of you use otoscope in your daily practice?
No, in this particular, see, you may not use it in
all the suspected cases. Whenever you are seeing a child with fever, cough and cold, on those kind of things, I think it's still very heartening to see at least around 50% is actually raising their hand.
I'll tell you my story. I was amongst those who have not raised the hands, maybe 10 years down the line. Once I started attending the CMEs properly, and then I understood what is the value. I got this, digital scope, and these are all images from my patient in my otoscope. So I got this particular thing, and we know that otoscopic finding is due into not only redness, it should be bulging. You can be seeing the fluid behind it. And immobility or the partial mobility, it is difficult for us because we need a pneumatic otoscope, which we do not want to use it. But normal routine otoscope, we can at least see the erythema and bulging. Bulging is very important. Only erythema, if the 1-year-old child excessive cry, you might feel a yellow, red ear, tempering membrane. So, and suppose there is a otorrhea, that gives you diagnosis acute otitis media. You need not to see anything else. So now the question is, how will you proceed? Which are the antibodies you will choose, and how will you decide about the antibody, whether to treat or not? Forget about antibodies. Whether this child will require treatment or not, how will you decide?
So, treatment requirement decides on 4 factors. Number 1 is the severity. More severe it is, more treatment is needed. Whether it is unilateral or bilateral, number 2. And number 3, if the child is less than 2 years, and if the child is particularly less than 1 year or newborn, then the treatment is must. And number 4, which he has not written over here, is whether it is a persistent or recurrent acute otitis media. By persistent acute otitis media, you have given treatment, but still the pain persists for more than 48 hours. Then you call it persistent. And recurrent, if you have more than 2 attacks in 6 months or more than 3 in last 1 year with the last attack within 6 months. So these are the 4 very important points we take.
One point I would like to add, Dr. the 5th point. You have to ensure follow-up and adherence before you actually, follow these guidelines.
Okay, now so this, you decide on this. So if you have severe otitis, if you have less than 6 months, if you have bilateral, if you have otorrhea, you will treat with antibodies. Now the question is, which antibodies and which organism we are targeting? Dr. Amitabh.
I think the most important organism is still going to be streptococcal pneumonia here because our vaccination coverage is possibly not as much. But next two organisms, you are always going to think about the non-typeable hemophilus influenza B and Moraxella catarrhalis.
So what is choice of antibiotic?
My choice of antibiotic is always going to be coamoxiclav if the child has already been vaccinated against pneumococcus, because irrespective of what we have actually read in our textbook, non-typeable Haemophilus influenza B and Moraxella catarrhalis is actually coming up because of wider vaccination coverage. So if you get a good vaccination history in this child has been immunized with pneumococcal vaccine, I will prefer to give amoxicillin clavulanic acid.
Kundu sir.
I want to add one thing. Whenever you get a case of otitis media, don't forget to examine the eyes. If the eyes shows purulent conjunctivitis, then the chances of non-typeable Haemophilus influenzae is very high. And those non-typeable Haemophilus influenzae with simultaneous infection of the eyes and the ears, they are usually resistant. In those cases, you have to give co-amoxiclav.
So in general, when we talk about acute otitis media, it's amoxicillin, ideally it is penicillin, but amoxicillin is the first line of treatment because it will take care of streptococcus pneumoniae very well. Only thing is, when you prefer amoxiclav, where you suspect it is H influenza, like what sir said, there is a conjunctivitis, purulent conjunctivitis there, or you have given antibiotic amoxicillin 2 days and not responded, or there is a history of amoxicillin given just within last 30 days. In that case, you will start with amoxiclav. Otherwise, amoxicillin is very good drug and we should use it. Now, high dose amoxicillin, sir, any role of high dose?
Yes, because most of the pneumococcus in our country has an MIC level of say 1 at the most 2 microgram per milliliter. So they will be responsible to 40 milligram per kg of amoxicillin. But less than 10% of the pneumococcus reported from India has a MIC level of more than 2. In more than 2 till 4, they require 90 milligram per kg of amoxicillin. But if the child is very small, say a newborn coming with otitis media, or an infant who is less than 3 months of age, in those cases your target attainment should be more than 90%. That means not only you would like to cover pneumococcus with an MIC of less than 2, you will also like to cover pneumococcus with MIC level more than 2. Because here the limit of the period of chance of not developing very serious complications in the form of meningitis, brain abscess, is very small. So in those cases, you always, I would prefer to start with high dose of amoxicillin. Rest of the cases, I will start with as 40 to 50 milligram, wait for 48 hours, no improvement, then I'll go over to high dose amoxicillin, and I'll like to combine also this.
So there is very select situation where you can go for high dose amoxicillin. Otherwise, amoxiclav is fair enough in most of the situations. There is no role of ear drops. Let us go to that. This patient I followed after 4 days. It was showing this. Can you see this?
Yes.
Okay. Even on day 12 after finish completing antibiotic, I saw this. Can you see this? There is a fluid. Yes. So what will you do about this, sir?
I think
watchful
observation, because most of them will be having some dissipated secretion and that will last even after 1 month or so, even longer.
So a message is, when you see the patient after completion of antibiotic, can you appreciate there is no erythema. It's a pale sort of. And only there is a fluid.
There you can see some air fluid level. This is a middle ear effusion you can see. You don't have to do anything. It will settle in time.
So this is middle ear effusion. So fluid might persist for up to 3 months. Okay. So you don't keep on giving antibiotics. That's a message. Anyways, this thing, less than 2 years, more than 2 years, severe, non-severe, unilateral, bilateral, you decide to whether to go for antibiotic or not.
Just one point.
Yes, sir.
Let's go back to the pictures. This fluid is there. Child is somewhat older. Cannot hear from that side. Do we change our treatment plan?
Sir,
do we involve our ENT colleague here? That is my point.
So if it lasts longer, and of course this we have to keep in mind, the hearing assessment has to be done in these kind of cases. We send it to ENT surgeon for that. Okay,
actually what they do, they place a tympanoplasty tube to drain it out. But usually they do it after 3 months.
Exactly.
Not
3 months.
That.
No, sir. I think even if there is some amount of hearing loss, don't do anything because you have to wait till at least 12 weeks. That might absorb on its own.
Yes, 3 months
so
you
try to
can
give him
wait.
some exercises,
all cases of otitis media will have some hearing loss to start with, but that does not, it is not an indication to put a tube.
Yes, sir.
For a tube to be
I think
placed, you at least have
Let
to
us
give
go
3
fast
months.
because I have to cover one case I want to discuss with Dr. Kishan Chak.
Very less. If you treat them with proper antibiotics, the chance of developing deafness is very less.
Okay.
It is an ill managed, then there is a chance.
So this next case, 5-year-old girl has a high grade fever, which is 5 days. Thick purulent nasal discharge, which is foul smelling. She also complains of frontal headache. So my question is, when will you suspect sinusitis, sir? And what are the points which will favor of diagnosis of sinusitis?
Well, this patient is clearly showing whatever
Purulent
it is,
discharge.
it is likely to be sinusitis. There is a thick nasal discharge with a headache, and if it is acute illness, there may or may not be fever, but if fever is there, that also goes in favor of it. So as we have put here PSP, the nasal congestion, rhinorrhea or daytime cough of more than 10 days duration. This daytime cough, I am not very convinced if this is an important criteria, but nasal congestion and rhinorrhea, yes. Severe onset, concurrent fever, purulent rhinorrhea. This purulent rhinorrhea is also something which has to be taken with a little careful history. Many a times if the secretions dry up and then they come out, they look purulent. But if it is a free flowing and still looking purulent, that is a clear way of recognizing it by history and over your clinical examination. And if worsening of the course is there, worsening or new onset nasal discharge. Many children have already, say, recurrent viral infections or nasal discharge because of allergies. And now on the top of that, they have a new nasal discharge which is thick and purulent looking, and especially if it is foul smelling, we have a clear diagnosis of
So
sinusitis.
this PSW is important, persistent. So if you have a discharge continuous more than 10 days, if it is severe means there is a fever which is very high grade and there is purulent rhinorrhea. So purulent rhinorrhea more than 3 days makes a sinusitis. And worsening, of course. Patient is improving and again it is getting that infection or sort of discharge or fever and again it's a symptom. Then
I
you
think
suspect-
this biphasic course, what you just now mentioned, is possibly one of the most important clue. A person developing cold, fever and those kind of things and niggling there for quite some time and then suddenly developing high grade fever and might or might not having any other symptoms should be suspected of having a sinusitis.
So sir, sinusitis, again the bugs are going to be the same. So exactly what is the difference between treatment of otitis and sinusitis?
Chetan, I want to add one thing. If you have a nasal diphtheria, though these nasal diphtherias these days are uncommon, that is one of the condition where you have a purulent discharge lasting more than 7 days. So whenever you get such a case, look for membranes inside the nose, and if you have them, that's a nasal diphtheria, and that should be managed somewhat differently. Regarding antibiotics, again the antibiotic, most of the cases antibiotic of the choice, as you have written, amoxicillin, that too in 40 milligram per kg per day, but I'd like to give. And one more important point in this a child develops frontal sinuses around about the 7 or 8 years.
Yes.
So most of the cases of sinusitis is maxillary sinusitis, not frontal sinusitis.
Right. Okay.
Just a little
Sir,
point
you have
that
4
So
minutes on
this is a 5-year-old child you mentioned.
Yes.
So in 5 years, even the maxillary sinus is not going to be totally pneumonized. So only ethmoid sinus is going to be there. And I will be worried. If a ethmoid sinusitis in a child is there, of course there is CNS and orbital complication rates are going to be very high. So your question whether you are at all going to treat or you are going to do an expectant observation in this particular patient, I will possibly be preferring to treat.
Right, sir.
one little point that if the discharge is from one side only, then our diagnosis should be something like a foreign body
Foreign
stuck in
body.
the nose and that kind of thought
Right.
process.
Okay, case number 5. 4-year-old male, fever high grade 5 to 6 days, responding to paracetamol, interfebrile period is normal, child is playful, cough mild 4 to 5 days, dry, started on amoxicillin 3 days, vaccinated as per ACVIP. On examination, temperature was high grade, respiratory rate was more, maybe 36. There were few crepitations on left side, rest examination normal, refusal of feeds, apprehensive patients. This was the basic investigation where we found that we had count of 10,000, neutrophilic predominance, CRP was 79, Culture growth, no growth. X-ray was this. Now, question is, what is it and what will be your choice of treatment? Anyone, sir?
So this is a case, we can see it's a case of opacification in the left upper lobe. It's a lobar pneumonia, and majority of the pneumonias, though it is due to virus, but it is virtually impossible to distinguish between bacterial and viral pneumonia. As the child has fever, respiratory rate little bit higher as compared to age, high CRP, I'll take this case as a pneumococcus pneumonia, and as the child is admitted in the hospital, so whether it is admitted or if the child has respiratory distress, unable to maintain saturation, unable to feed,
So we have admitted this
then
patient.
we will admit the child. If the child is admitted, our first line of choice of drug will be ceftriaxone, and we will give ceftriaxone in the dose of 100 milligram per
So,
kg.
sir, this patient was given amoxicillin OPD before coming to me. So, should I continue with amoxicillin
Yeah.
or amoxiclav, or should I go for ceftriaxone?
Then you have to give IV amoxiclav. But
Amoxiclav.
if the child shows improvement with amoxicillin in the outpatient department, there is no question
No, there is
of
no- it has not
admitting.
improved.
So as the child didn't show improvement, so my choice of drug in this case is, what I would like to do, I would like to give ceftriaxone.
Sir, in which situation, Krishnan sir, you will give oseltamivir in this patient upfront?
Oseltamivir.
Well, this is, we already have an X-ray which is showing a large consolidation, a well-defined shadow. It is likely to be a bacterial infection. So unless it's a very high season going on where we expect that it was initially a viral infection, child was playing around in spite of fever, he was responding to paracetamol, on the 4th and 5th day his fever gets worse, he starts looking toxic. So you can assume that probably now he's developed a superadded bacterial infection.
So, do you think of mycoplasma and add a microred empirically in this patient?
I will, because what I am seeing nowadays, the various patients in our hospital that is coming to the front door, 20 to 25% presenting even with lower kind of symptoms are actually mycoplasma, rather than what we were being taught and we are teaching for last few years.
So usually we suspect mycoplasma in cases where it is more than 5 years, maybe 3 years and more, or you have cough which is predominant, maybe a walking pneumonia, but it is no more walking pneumonia. You can see cases which are complicated by that. So mycoplasma should be kept in mind in that particular group. Now suppose I think of mycoplasma. Which will be the investigation that will give me a diagnosis of mycoplasma?
No,
Is
no.
there any investigation will give confirmed diagnosis of mycoplasma?
There, it's a very dicey situation, Chetan, because everywhere we are doing the multiplex PCR to detect all the viruses, including mycoplasma. A lot of time mycoplasma is coming positive, but not necessarily that means the child is having an acute mycoplasma pneumonia. It might be just sitting there from previous mycoplasma infection. But with a consistent clinical history, findings, X-ray,
please wrap
if
up.
you get a multiplex PCR positive, of course you are going to continue with your mycoplasma antibiotics.
So this mycoplasma pneumonia diagnosis, there is no specific one test which gives you diagnosis. You will go for PCR, maybe throat PCR in the conditions where patients where you are admitted, and then you just confirm whether it is a mycoplasma positive in PCR throat swab, nasopharyngeal swab. At the same time, you need to see serology if it is mycoplasma IgM positive. So both positive with the particular clinical situation which is favoring mycoplasma, you are justified to
But
give
Chetan,
that.
in mycoplasma serology, the IgM might be positive for more than 3 months.
Yes, so once it is positive, it may last
so
for-
mycoplasma investigation wise, both the tests are not good enough.
Yes, but in situation where we need to confirm it, we have to go for both the things together. Anyways, the treatment of choice, what you use?
We don't give a macrolide in our hospital for mycoplasma. We give doxycycline these days. But macrolide has lost all its ages. So
I agree, fluoroquinolones can be definitely used.
So I think azithromycin is now gradually been getting resistant to mycoplasma, and that's why we are using this more of doxy or a levoflox, and that's what we have done. And done. Last case for just 2 minutes, can I take or done? Okay, fine. Thank you so much. Sorry, Kishan sir.
Thank you.
Thank you, Dr. Chetan, and thank you to the organizers for giving us this opportunity, and thank you, Dr. Chetan, for preparing the slides, conceiving this, and allowing us to take part in this discussion. You could have done this presentation all by yourself, we all know for sure.
Thank you so much.
starting, is it mandatory to do PCR before starting this, treatment for oseltamivir or yes?
Oseltamivir.
Thank you for the wonderful session. We'll request the participants to
we'll
please
discuss,
go
maybe
and
I'll
collect
come
the
and discuss,
memento from the
because
memento corner.
you're doing-
Question answers can be asked on the sidelines. We will now proceed for the next session, which is update on aero allergens in the light of GINA 2025. Will be presented by Dr. S.S. Rawat, who is the president of the IAP Respiratory chapter. For this, I invite the chairpersons, Dr. Shabash Haji Ray and Dr. Prabhavati Banerjee, please.
So, thank you very much. Good morning, all. I bring greetings from IAP National Respiratory Chapter. Thanks to organizers, Dr. Pallab, Dr. Subhashish Roy, and West Bengal Academy of Pediatrics for giving this important opportunity to discuss. This is a very, very prestigious meeting every year which you organize, and it's really an honor to take part. So the topic given to me and 15 minutes discuss what is new in aero allergens as per GINA guideline 2025. Now there are not much changes, there are not much new things in GINA 2025 regarding aero allergens. So I just like to review what is there at present in GINA. So the flow of information would be, I'll discuss what GINA has discussed is that they have discussed regarding how to avoid aero allergens in these 2025 guidelines, and that they have given some information regarding allergen immunotherapy. So what they have discussed on avoidance of aero allergens. What exactly are aero allergens? They are airborne antigens. They can be proteins, they can be glycoproteins that causes allergy. They can, as you all know, they are classified as indoor and outdoor allergens. Major outdoor allergens are pollens from grass, weeds and trees, and indoor allergens, they are dust mites, fungal spores, cockroaches and elephant dander. I think we all know all these things. Dust mites are the most important aero allergens because they are present across the world. They are ubiquitous and they are the commonest cause of aero allergen. So all the discussion will be basically centered on dust mites. Then GINA have given some important guidelines, some clear statement regarding how to avoid indoor allergens. As you all know that as per patient they react to multiple factors which are almost ubiquitous. They are present almost everywhere in home and in your workplace. So avoiding these factors completely is usually impractical and very burdensome. So if you try to give them some very, very broad guidelines how to avoid allergens, sometimes it doesn't work and they are not also practical. Again, there are also conflicting evidence regarding whether these effects are useful in reducing symptoms. So there are not much evidence which support that a general advice regarding avoidance it is going to be useful. And majority, again there is evidence that majority of single intervention they have failed to decrease allergen load or have any clinical improvement. So these are the basic tenet on which the things we would discuss. Now first we'll discuss what is evidence in favor of house dust mites. A systematic review of multi-component intervention to reduce allergens including HDM showed no benefit of asthma in adults and there was a very small benefit in children. So they did a study where they tried to do multiple components. What they found that in adults it is not working, in children there was some benefit. Again in one study they saw that rigorously applied integrated approach to HDM control led to a significant decrease in symptoms, medication use, improvement in pulmonary symptoms. But this approach was very complicated, expensive, and it is not possible practically. So for practical purposes, if you are doing very intensive therapy, intensive methods in house dust mite, it might not be very effective. So similarly for pets, complete avoidance of pet allergens is almost impossible because they are present everywhere. They may be present in the road, garden, everywhere. It is very difficult. And if they are present in your home, of course, removal of such pets can be effective, but again, those antigens, they are present in the home for a very long time, so immediately removing a pet, it is usually not possible. So again, with pets, we don't have much evidence, much thing to do. Then for cockroaches, doing pest control methods and avoidance methods, they are partly effective, but again, the clinical evidence is lacking. Fungi, yes, there are some evidence that if you have a scrupulous cleaning of homes where you avoid damp walls and everything, they are going to be effective. AC, they are effective because because fungals, they grow very well in humidity above 50%. So if you keep a humidity below 50%, your fungal load will get low. But again, doing air conditioning and sealing of windows have been associated with increasing fungus. So again, things are not very clear cut that if you are trying to do something, it is going to be very effective. So again, the evidence is not very clear. So if you see this chart, in which they have listed the allergen avoidance measure, they have seen the degree of effectiveness of and evidence, reduction in allergen level and clinical benefit. Highest benefit you get, the evidence is A, and the lowest is D. If you see, like for example, house dust mite, only encasing beds in impermeable coma, that has got some evidence, that A evidence. In adults, there is almost none, and in children, it has some evidence. So only one particular intervention of encasing bed in impermeable covers, that's going to have some evidence, which has got evidence level A, and that too, it works in children, it doesn't work well in adults. Rest all, if you see, like washing beds, replacing carpets and minimize objects, they all have very poor effect, either benefit or all you see a lot of C and D's, and almost none in all the bed. Similarly, in pets, if you see, again, if you see the reduction is minimal and the clinical benefit, again, it is very less. Even for cockroaches, rodents, for fungi, again, there are some evidence, like level of A evidence, where trying to have less dampness and keeping the wall clean, they've got some evidence. But in all rest, if you see, single particular intervention might not have a good evidence for benefit. If you see, this chart is very clear. So what does GINA 205 say? Allergen avoidance is not recommended as a general strategy. Like you don't just tell your child with asthma, just avoid allergens, do everything to it'll fail. It'll not be effective. So GINA says that don't do any general strategy. For patient who are sensitized, where you have done sensitivity tests and you are clear that child is sensitive to house dust mite or is sensitive to pollen or some pet, in that case, it is logical to avoid allergen exposure. But again, there is less evidence that a single strategy would work. So multi-component strategy, if you are using, like for example, child is sensitive to house dust mite, trying to use multiple strategies, it might have some effect, particularly in children. But again, adults, the evidence is not too much. Then again, if you try to do something very heroic, something very expensive, something patient may not accept that, and again, there are no ways to find out which patient will benefit with those methods. So again, if you see, the evidence is not very strong, and it's very important that in case the child is not responding to your medical therapy, do the allergy testing, find out which allergen is there. Try to use multi-component therapy, and it might have benefit in some children, but it is no way to find out which children will be effective. Then we discuss what is the guidelines on allergen immunotherapy in GINA 2000 guideline. This AIT is an add-on therapy. Remember, it is not the only sole therapy. First, you try with your medical management. In case medical management is not working or child is having sincere sensitization, then in case you can consider what of AIT, and consider in both adults and children who have got clinically significant sensitivity to allergen, including allergen rhinitis. So the children who are having asthma, allergen rhinitis, they respond to your AIT in a much better manner. And remember, currently there are a lot of papers indicating that it is a very effective therapy, particularly in adults. There are a lot of studies indicating that it is an immune modifying effect, like it can halt your allergic march and it can have a long-term efficacy, and you can sometimes claim this is like allergen rhinitis, claim even cure. So this is lot of papers have come even in adults where it has got a disease modifying effect. So remember, we cannot just brush it under the carpet. It is a very effective therapy. Now, there are not much studies which have compared immunotherapy with pharmacotherapy. And particularly most studies have been done in patients with mild asthma. So still, although in adults there are a lot of evidence, but in children still, a good comparison between pharmacotherapy and AIT, they are not there. Most studies have been done for dust mite and pollens, and with as regard to fungus, again there are not much evidence. So we have got a lot of evidence in terms of therapy for dust mites and for pollen. So we require more evidence, more studies where we can use this therapy more confidently in children. So we can do it in two manners. We have got SCIT where it is subcutaneous, or we can do it SLIT. So what is the evidence of SCIT? Systematic reviews and meta-analysis. There are some studies where they have done very good systematic reviews, and they have shown that addition of SCIT leads to reduction in dose of ICS in patients who are put on SLIT, and there is a moderate strength of evidence. It also may improve the quality of life, lung function. It decreases the liver use and need of systemic OCs. Again, the strength is, evidence is not very strong. Again, a very recent 2020 systematic review indicated that children with asthma below 18 years, where they use AIT and SCIT, there is a reduction in the use of ICS and improved quality of life and lung function. So there is an evidence of use of SCIT in children, where in appropriate setting, where you've got strong sensitization, where you are very sure and where you have proved what is the allergen, child has been put on a good medical therapy and the response is not adequate, definitely you can use SCIT where it's going to work. But again, the bottom line, we require more evidence. Safety of SCIT therapy, you get severe reactions in about 0.5 to 0.7% of patients treated with SCIT, and serious side effects are less, but sometimes you can get life-threatening reactions. So again, don't try to do it if you are not trained in this therapy. Please leave it to your allergic colleagues who are more trained. Or in case if you are trying to do it in a hospital where you are ready to take care of severe reaction. And risk factor, particularly if the asthma is not controlled. So before you attempt SCIT in a child, asthma should be well controlled, because a child who is not having good control, or if he even is below 70, that is a child who can get severe reaction with SCIT, or he is allergic to food. In that case, definitely the risk of reaction is very high. So be very sure that it is not food allergy and your child is well controlled before you try SCIT, and I think you should be well trained to do this thing. Then what is the GINA advice regarding SCIT? It can be considered for patients with severe asthma. Potential risk and benefit should be explained to the patient. Again, don't try to do it without discussing with the patient. Try to explain him that what you're going to do, what are the benefits, what are the risks, and then only you attempt it. And it should not be done if the patient is not having good control of asthma. Please don't do it. First control your asthma well and then try to do it. And most important, limited to practitioners who are trained in allergy testing and therapy. Because if you are not trained, please don't do it. Do it in only a good healthcare setting where our facilities to distribute the child are there. People are there to help you out. And very important, don't do it with crude extract. Do it with high quality extract or standardized, because nowadays you get both. You get crude extract as well as highly purified or standard extract. So always try to use standardized extract where the results are more predictable and then they are more better. Then there is evidence for SLIT also in children. Again, the evidence is very limited, where they have not compared SLIT with pharmacotherapy, and they have not compared with important outcomes like exacerbation of quality of life, but there are few RCTs which have done. If you see this Cochrane review in 2020, where they reviewed 66 trials of SLIT for allergic rhinitis, where 80% of them they had asthma also, and they had concluded that SLIT would slightly decrease the risk of asthma exacerbation and the use of OCs. But there was only one study in child where they had reported on healthcare visits. So again, it was mainly in the adults, and the evidence in children is very less. Evidence are there more in form of house dust mite SLIT, and And European Academy of Allergy and Clinical Immunology, they recommended HDM slit as an add-on treatment in adults with controlled or partially controlled HDM-driven asthma. So this evidence is in adults. And then in subsequent systematic review, standardized HDM slit, it did decrease the ICS dose in one RCT and improve asthma control in two RCTs. But there was no effect on exacerbation. And since these studies are done only in adults, but they say that this you can juxtapolate even in adolescents. So in children there is no evidence, but in adolescent and adults definitely adults evidence is good for HDM slit, and you can extrapolate for adolescent because there are some studies indicating that slit is also useful in adolescent for HDM allergy. Again, for safety, the risk is about minus less than 1%, and anaphylaxis is absolutely rare. Slit is more safe than skid. Skid, their side effects are more. Slit is relatively safe, and again the symptoms are mild, limited to oral or gastrointestinal. So if you compare both, the slit is more safe than skid, but again the evidence is less in children. So what does the Gina say? For adult or adolescents who are sensitized to HDM with persistent asthma symptoms despite low to medium dose ICS, you can add HDM slit provided your FEV1 is more than 70%. So you should have a well controlled asthma, and then only you can try adult or adolescent, not in children, and you can try therapy for slit for children who are sensitized to HDM. You can do it from step 1 to step 4. As you know the steps in management of asthma. In other steps where the child is not responding to your medical therapy and there is a strong, you confirm that there is an HDM saturation, you can try with slit. And again, in children there is no evidence, so we cannot try to advocate in small children, but again, adolescents, you can try. So, to sum up the take-home messages, general awareness measures are not recommended as a blanket therapy for asthma. Always be specific. Try to find out which is the specific inciting allergen and try to give specific advice. Multi-component specific allergen measures, they have got a limited efficacy in children. Adults, they might fail, but in children there are some evidence it can work in children, but it should be multi-component, not a single advice. Try to combine various advices and try to give it to the children. Immunotherapy is an accepted therapeutic intervention with immune modifying effect and a lasting impact on asthma control. Though it is a therapy which is coming up very quickly. Lot of evidence in adults, but children, the evidence is still coming. But I'm sure in coming years we'll have strong evidence in children also. And it is a disease modifying way, and I think it will come up in a big way. Very important and last important point is that it should be done by trained individuals in a hospital setting where you are got facility for taking care of adverse effects are there, and it should be done by qualified people using standardized extract so that the results are predictable. Thank you very much. Thank you for your attention.
Thank you, Dr. Rawat, for finishing in time, and a very, very important topic which is now in the new guidelines. Dr. Rawat, can you come for the memento? Thank you very much. Thank you, moderators. So, yeah, he'll be in the panel. Yeah. So for the next session, allergy testing. Allergy testing, which and when? Who else than Dr. Sanjukta De? So Dr. De, please, the floor is yours. And we would ask Dr. Rawat to continue as a panelist. Dr. Madhumita Nandi, Dr. Amita Sina Mandal, and Dr. Shayantan Bhaumik. So all of you please come to the stage as panelists for the next session.
Shall I start? Good morning, everyone. I thank the organizers for giving me this opportunity. And this is a very extensive topic. So to cover it within 30 minutes is tough. But I have an august gathering of panelists. So I expect that we will have a very stimulating discussion, and we will touch on the different types of allergy tests, but obviously we won't have time for very much details. So the main questions that we are trying to address here, whether allergy tests are needed at all, and do testing create more problems, because most of the pediatricians have come across say that by testing we are having more problems. We cannot interpret the test, the child is off all the food that they can possibly think of. What are the types of tests available, which are the tests you will recommend, and which are the tests you will avoid? So we know it is mediated by type 1 hypersensitivity, amongst which in pediatrics I think the most commonly we see as pediatricians is allergic rhinitis and asthma. And the allergens involved are airborne allergens, foods, drugs, and insect stings. So allergy tests, we are testing for specific food or pollen that might be causing the problem. And it is documenting a presence of an allergic state. But it is important to realize that the presence of an allergic state does not equate to allergy. It might be just sensitization. So that is what we are trying to decode here today, that maybe allergy testing always does not give you the exact things that you are hoping to look for. So we have types of tests, and I won't go into that. We are going to go for the in vivo, in vitro tests, and we will take case histories to go through the questions. So first question for Dr. Amita Sinamondol, that we plan to do a skin prick test. So we know that we have multiple indications for skin prick tests, of which asthma is one of the commonest. Drug allergy could be another, and we also have allergic rhinitis in pediatric practice. So we also have less common disorders. We have a very extensive list here. But when you're planning to do a skin prick test, what are the drugs you must ensure are stopped, and what are the precautions you take?
So we should ensure that the drugs which interfere with the histamine release from the dermal mast cells should be stopped, and the general guideline is that the H1 antihistaminics should be stopped within for 4 to 5 days at least, and ideally for 1 week before doing the test, and especially loratadine should be stopped for at least 10 days. And to remember that LTRAs need not be stopped. For LTRAs, the skin test may not be deferred. For steroids, if you are using a dermal steroid on the skin, if you are planning to do a test on that area, the high dose, the high potency steroid should be avoided. If you are using that, you better defer it for at least 7 to 10 days. But for low dose oral steroids, the test need not be deferred. For high dose steroids, the test has to be deferred for at least 2 weeks. If you are using some biologics like omalizumab, then at least 6 weeks the test should be deferred. And to remember that the test result may be even false negative for at least 1 year after using the omalizumab. And some H2 blockers like ranitidine, you need to stop at least 24 hours before doing the test, and some tricyclic antidepressants with some antihistaminic factors. So for that, it has to be stopped for at least 1 week before doing the test.
I think for topical steroid, it should be 3 weeks, because topical steroid, they take that because these children, they are having atopic dermatitis, and commonly they are on topical steroid. So the gap should be at least 3 weeks before you do any SPT.
Thank you, sir. And for us general pediatricians, when we are practicing, I think ranitidine is something to be kept in mind, and the anti-allergics, and also cough syrups, because they always have a cocktail of antihistaminics in them. So careful about that.
Then, madam, some children, they are on biologics. So again, for biologics, it's important because now they are used more and often. Like for somebody you are using omalizumab. Sometimes even for 1 year, the test can be false negative. But that thing should be kept in mind.
Absolutely. So I won't go into the how it's done. So that is out of scope for this talk. But for next question to Dr. Madhumita Nandi, what may be the adverse reactions? Maybe we'll come to that later. First, how do you interpret a skin prick test? And what may be the adverse reactions? And what are the safety measures you will put in place?
First, let me thank the organizers for including me. I don't know why they have included me in this panel. Maybe because I have special interest in rheumatology and immunology are related, that's
Absolutely,
why.
I think.
But let me be very frank. My experience with skin prick test is very, very limited. But still, to answer your question, how to interpret that? First, we should be knowing it has to be done by, anyone cannot do that. It has to be done by expert, because the exact amount and the exact thing, the distance between the two things. Ma'am, you were showing one picture. And then, so those things have to be kept in mind. Then comes interpretation. Interpretation is, obviously we will have both positive and negative controls, and we take the size of the wheel, not the erythema or the flare, the size of the wheel as positive if it is 3 millimeters more than the negative control. And to answer your next question is, what are the possible side effects or the safety measures in place? So obviously we are introducing an allergen intentionally into the body. So that may have reactions, even systemic reactions, even anaphylaxis. So everything, it has to be obviously done in a setting where everything is there to take care of possible anaphylaxis. And the other things is sensitization versus true allergy. Sensitization, actually, in very simple terms, allergen is an antigen capable of producing IgE antibodies in the body. So, something which is capable of producing IgE antibodies is not necessarily be associated with relevant clinical manifestations. So, just produced IgE antibodies are produced is sensitization, and relevant when it is associated with relevant clinical manifestations or clinical features, then probably that is allergic disorder.
I think what is very important to understand is in allergy, before doing any test, it's history, history and history again. So what does not match with history will not actually hold true. So I would just want a few comments from all the panelists here, especially Dr. Rawat. What do you think would be, when we interpret a skin prick test, sensitization versus true allergy, what are the things to look out for?
Sensitization was actually you have to correlate with the history. Like if your SPT is positive and the child is having no symptoms, is absolutely normal, and there is no, you have taken the history and there is no history of any symptom related to that particular antigen, I think that thing is false. That thing is false positive. So trying to correlate between a positive test and history is very important before you try to give any advice regarding allergen avoidance or any therapy. I think that thing is most important.
I think very important for everyone to realize is a skin prick test has a very good negative predictive value. So if it is negative, then you are sure that the child does not have allergy to it. But the positive predictive value is not very high. So sometimes when it's positive, it can be a false positive. So that's something to keep in mind. So sometimes when you're doing a skin prick test and the child is negative to a certain number of foods, you can say go ahead and feed the child with the food, the child will not have the reaction. But if it's positive, it's not necessarily true. So we have more advanced tests now, we'll come to that later. So that's how you interpret in the light of sensitization, history, everything else. And also very important to realize a bad technique will give you bad results, and it's very important to do it in a place where you can deal with anaphylaxis, because you have the possibility of anaphylactic shock. So trying to do it in a chamber where you don't have the backup might be a problem. So we talked about adverse reaction. Other than adverse reactions is anaphylaxis that we are worried about. And so the next problem I'll pass on to Shantanu. So Kaushik is a 9-year-old child. He is having egg allergy, and she avoids eggs for him. Sorry. Yeah, she avoids eggs for him at all times. This is a mother who has come to you. And he has coughs and colds frequently. His lips start itching and swell up whenever he eats anything containing egg inadvertently. He recently was at a birthday party and swelling of lips was there after party food. The mother is worried about anaphylaxis. What allergy tests you will advise, if at all? And this question has few parts. Which often happens to us in a real life setting. They walk in with a total serum IgE test and also a panel already done. So in Kaushik's case, the total serum IgE was more than 2,500, and she also shows you a report of a serum specific IgE test which shows that he's positive to dust mite, egg, milk, prawns, cockroach, everything. So what is the role of total serum IgE in allergy, and what are the advantages or disadvantages of serum specific IgE tests?
Yeah, sure. Thank you. First of all, a big thank you to the organizer for including me in this talk. So, as you can see, the total serum IgE is sort of elevated in all atopic individuals, and the IgE concentrations basically fluctuate. So around 100, 125 to 150, and it doesn't actually tell us whether this person is allergic or atopic or. So it's sort of, it's only helpful in two conditions. One is allergic bronchopulmonary aspergillosis, and the other one is atopic dermatitis. So that's why we just, we don't really want to see the total serum IgE from that perspective, that this can have different interpretations. The other one is allergen specific IgE. So again, so the important things to understand is we keep this test reserved because of a few reasons. One is it's very expensive and it's not readily available, and the other thing is that the interpretation is quite difficult. And at the same time, it can be markedly elevated in patients even when they have the total IgE is either normal or mildly elevated. So it's sort of a reserve test that we keep because of all these reasons, and we keep it for severe systemic reactions like asthma, or when we can't do the skin prick test, which is when the drugs are interfering, or you have a severe dermographism or extensive skin problem.
So basically, when we are, all of us must have come across patients walking in with serum-specific IgE reports, and you are faced with a report where the child is positive to every food that you can think of. But basically, the interpretation has to be done against the levels that you expect a food to be. So automated responses does not work here. You have to know what exactly you're looking for in keeping with history. Again, this is a better test for aeroallergens. When we come to food, there is a huge mix-up, and many children that have come to us in practice have stopped all kinds of food altogether, thinking they're allergic to it, leading to nutritional failure. So the next question would be to Dr. Rawat, please. What are the points to note when ordering or interpreting a serum-specific IgE test?
Yes, so specific IgE tests, they are very sensitive. They are less specific, but they are very sensitive tests. So there is no point in trying to order a blanket that do serum IgE to all the allergens. Like normally we see patient walking in our clinics with a big bundle of report where there are about 300, 400 antigens they have done serum IgE to almost all foods, all items, and you see almost 50 they are having IgE antibodies. It's absolutely wrong. So a proper history of that patient, which particular condition he is symptomatic, whether they are seasonal, they are perennial, their symptoms they occur in outdoor, they occur indoor, his environment, like does he have any pets, the walls damp, whether they are damp, whether there is any mold, any history of drug, and any occupation. So what I mean to say is that a very good history will tell you that what panel of antigen probably you'll like to advise, because trying to advise a limited panel, whether you are suspecting food or you are suspecting aeroallergen or you're suspecting some drugs. So be very specific and advise specific panel so that you get specific tests. And then when you are contributing them, again it's very important because you might get false false positive. So just trying to give a blanket advice that, they, like for example, they get some report and they say that they are subject to, say for example, prawn, and mother say that the child has never eaten prawns and we are vegetarian. How can it be possible? So again, trying to interpret that child who is having positive test, it could be false positive. So before you interpret, take the proper history, and it could be false positive, and try to give advice according to these points.
Thank you, Dr. Rawat. So I just took you back a few slides just to show that this child came in with a serum-specific IgE report showing he is allergic to prawn. The mother insists that he has had prawn multiple times and he had no reaction whatsoever. So is this report believable at all? She also wants to know whether this child will ever be able to have egg in any form. So can we do a more precise allergy test? That's her question to you. Can you decipher this for me? Is my child going to be off things that I'm not sure she's allergic to? So what is a more precise allergy test? And Dr. Madhumita Nandi will tell us what is component resolved diagnostics.
Yes, as Rawat sir also told that there may not be a direct clinical correlation with particular reaction on an allergy test and the clinical manifestation, because a particular, whatever it is, a prawn or egg is a collection of different antigens. It's not entire thing is that a particular person may not be reactive to all the antigenic components of a particular allergen. So finding out specifically to which component of an antigen a particular person is, in very simple terms, probably that is component resolved diagnostics. So if we can find out to which specific, as you said, the mother is saying that child doesn't have any, has never reacted to prawns or egg. So, and she is worried ki, from now on,
he has reacted to egg, yes, but he has never reacted to prawn. So she wants to know two answers. One, whether she can never have eggs at all, and second question is how this is possible.
So here in such scenarios, component resolved diagnostics could help. That might help us to know to which specific component of a particular allergen a person is reactive to.
Exactly.
Like for example, she is telling for the prawns. So DP10 it cross react with prawn. So the child could be cross-reactive, and that's why.
That's why, yeah. The thing is that when we are talking of, just for the audience who are not so familiar with all the allergy testings, when we are talking of skin prick test, if you look at this, if you look at this, there is an allergen source from where we use a homogenizer and get a whole extract, a crude whole extract. And with better labs, you can have purified protein extract. But still, it is after fractionization, you cannot characterize the protein. And you go down further and you go into a recombinant DNA where you get the exact protein part of the molecule the child is allergic to. So that gives you a precise understanding of the situation. So from skin prick test to blood serum IgE test to migrating to component resolved diagnostics, not that all the children will need it and not that all the time it is required, but it might be required, and in certain situations we will just touch on that. So we are coming to the characterized protein to the recombinant DNA. So CRD is done, as Dr. Rawat was saying, and the question is for you. Sorry, it's Kaushik's results show he is positive to GALD1 component of egg, that is the protein component, and DERP 1 to 10 of house dust mite. Does it explain his symptoms to shrimps and eggs? So if the first question, sir, if you tell the mother whether he can have egg or not, depending on the fact that he is GALD1 positive.
Yes, so in egg, normally you get a report that child is sensitive to egg white. And mother will tell that the child has been taking boiled egg and there is absolutely no symptom at all. So egg white has got two important protein, ovomucoid and ovoalbumin. Ovomucoid is a smaller component, but it is main allergen. So GALD1 that comes in the part of ovomucoid, and rest GAL 2, 3, 4, 5, they come in over albumin, which are minor antigenic. So if a child is GALD1 positive, that GALD1 is heat resistant. So it will not be denatured and child will have permanent egg allergy. So if a child is positive to GALD1, he is going to develop reaction to even raw cooked egg and it will be lifelong. Whereas if he is allergic to GAL 2, 3, 4, probably he is allergic to ovo albumin. That is heat labile. Whenever the egg is heated or baked, that thing gets denatured. Child can tolerate. So doing a component testing for egg, where it is GAL D1 or 2 to 5, it will tell you. If it is GAL D1, there is a permanent allergy and child cannot tolerate egg in any form. 2 to 5, probably he can not tolerate boiled egg. And then similarly for HDM, 1, 2 and 21, they are the major allergens, and apart from that 10 it's a minor allergen. So 10 it cross react with shrimps or prawns. So if child is positive to 10, he can also show positivity to shrimps. But again, very important, major reactions 1 and 2, it will have a very severe reaction. Cross reaction, they are mild. So even if child is having cross reaction, you can tell the parent that even if it takes some amount of shrimps, there will not be a problem because it is a cross reaction, because it is a minor allergen. So he could be positive, not eaten shrimp in his life, but since derm 10 and shrimp allergen, they are of same family, so they will have cross reaction.
Yes, that question also clarified by Dr. Rawat, also for Dr. Madhumita, is that whether you will advise prawn or not. So
Rawat sir has already explained that what's the reason behind that thing. So I think that question
so
is
you
answered.
can have a complete vegetarian who has never had any prawn or shrimp react to that because of the cross-reactive allergen, and the child is positive to dust mite and cockroach. So basically, this pan-allergen sensitization is what comes out in skin prick test. Next, when we do serum-specific IG test also, as Dr. Rawat said, we are confused between egg white, egg yellow, and we don't know whether or not this child ever will have or not. So when you go into the next part, want to decipher it for the parents, so for Kaushik's case, he can never have egg because he has allergy to something that is heat stable, and that cannot be removed by cooking or baking. So this is very important. You are giving a lifetime advice to the patient. So if this wanted, the next question to Dr. Shantan is, we have discussed, Dr. Rawat has already told you in his previous presentation, how desensitization, sublingual immunotherapy, subcutaneous immunotherapy has crept into the GINA guidelines. So when we started doing immunotherapy years back, there was a lot of backlash saying, does it work? Is it necessary? Whether or not it's important. So now that GINA has accepted this, do you think house mite diet, in this case, the mother wants house mite dust desensitization, will it work for them?
Yes. It should work for them because, as Dr. Raut has rightly said, that the CRD is quite helpful in regards to getting the type of proteins the child is allergic to. So DARP1, if someone from the house, if someone is allergic to DARP1 and DARF1 antigens of house dust mites, then definitely he or she is a candidate for Kaushik. In our case, is a candidate for allergen immunotherapy. Whereas, as again Raucher has said, that DARP10, then he would show cross-reactivity with prawns or other fish, especially shellfish. And then DARP5 and DARP23, if he is allergic to, then he is at risk of developing asthma and allergic rhinitis as well.
So when we are planning immunotherapy, having a chart like this tells us whether or not immunotherapy will work for the patient. So previously, when we didn't have this breakup and we didn't know about this cross-reactive carbohydrate determinants and these components, sometimes we went ahead with immunotherapy and it didn't work. Maybe it was DARP23 immunotherapy will not work with house dust mite extract. Sir, you wanted to say
So
something?
you must remember for house mites, these antigens, they are classified basically into 3 groups. Major antigen, it is DERP P1 and 23, intermediate 5, 7 and 21, minor 10, 12, 20 and 33. You have got good results for major allergen. Basically DERP 1 and 2, they are going to cover 98% of your mites. So all your extracts, all your therapy will contain DERP 1 and 2. So if it is isolated DERP 23, probably you don't have any way to do it. So very few places you will get places where you can desensitize for DERP 23. And for remaining, like for intermediate or for minor, there is absolutely no need to treat. So treat only DERP 1, 2 or 23.
We have only 4 minutes and time for a very last case, very quickly. So this is a 7-year-old recurrent visa. This is a true case actually. Poor exercise tolerance, responding well to bronchodilators, regular ICS for 1 year, but exacerbations every week. He lives in a semi-urban congested area, does not have pets, airy, plenty of sunshine. Weekends are worse, and he starts improving by Monday. So you can't blame the weather, the school, or the pollution. He visits his grandmother who lives in the farm most weekends. There are plenty of possible allergens. You don't know what to test for because there is no definite history. You go for a CRD. And when you go for a CRD, we are going to, as we said, this is what I will only focus on one, that he is positive to the apple, the MALD3 portion of the apple, and he is highly positive to that. And as we have already talked about severity analysis, proteins are stable that are stable to heat and digestion. They have higher chance of severe reactions. Systemic reactions like anaphylaxis happen to proteins which are stable to heat and digestion, and which is not stable, they can be broken down on application of heat or digestion. They can lead to itching, stinging and other low-grade reactions, but not the severe reactions. So this MALD3 positive, as Dr. Rawat has talked about GALD1, GALD2, he is response to egg also, milk also, peanut also, apple also. I will take the apple very quickly because of short time, because he is positive to MALD3, which is actually there in the skin of the apple. So this child, if the apple is peeled, he can have it. So the grandmother had an apple tree and he used to have apples the moment he went on weekends and have it all through Saturday, Sunday and have bad reaction. So, but this child also had features of oral allergy as well on questioning. So important to know, in this case, if you peel the apple and feed it to him, he still can tolerate it. So Dr. Rawat, can you, sir, give us a few pointers on peanut allergy when we have high probability of severe reactions?
Yes, so component diagnostic makes life much easier for peanut allergy, where for ERA 2 and ERA 1, 2 and 9, the risk is very high. So if the child is positive to ERA 1, 2 and 9, the risk of anaphylaxis and severe reactions are very high and the child can develop life-threatening reactions. So again, trying to do a component dissolved diagnostic and trying to find out which specific allergy, and in food allergy particularly, it is very useful to plan the risk and avoidance and immunotherapy.
Dr. Amita Sinha Mandal, can you please sum up with the advantages of CRT? There.
So that is how it is going to help in the precision-based medicine, like where you're going to start the immunotherapy, if at all it is needed, whether it will work or not, and so which of the allergens should be avoided. Avoidance and immunotherapy both are going to be guided by CRD. And for a general pediatrician, we should know when not to advise the allergy tests, actually the skin prick test or the in vitro tests. In general, for the food allergy in our country is very much overhyped. So parents, whenever they go for an allergy test, the first thing that is there in their mind is to avoid some foods. So that should not be the idea. A general food intolerance should not lead you to do an allergy test unless there are pointers to certain foods which he is always having symptoms to against, and of course for uncontrolled asthma and other like clinical features where there is a necessity for doing allergy tests, we should go for specific skin prick tests which are more specific and easy to do and should be done by an expert, and of course specific serum IgE tests as has been told.
So I think that's about, we finished exactly on time. If there's any other time for questions or later?
Later. Thank you very much.
Thank you.
So thank you for being exactly spot on time. And thank you, Dr. Sanjukta. Thank you all the panelists for a wonderful discussion on allergy testing, which and when. And after this, I would request Dr. Madhusmita Sengupta and Dr. Shutapa Ganguly to please come to the stage. And now we have none other than Dr. Gautam Ghosh. Dr. Gautam Ghosh is the Bhishma Pitama of Respiratory, and he is going to talk about parasomnias in children. Gautam da, please.
A very good morning to all, and thanks to the organizers for inviting me to chair a session on sleep disorders in children, that is parasomnias. And speaker is none other than Dr. Gautam Ghosh, who is a stalwart in the field of pediatric respiratory medicine. He is an ace clinician, a renowned teacher, and famous for his mnemonics, which helps the students to remember.
I look a bit younger.
And sleep is very close to his heart, sleep disorders. So please enlighten us.
Okay. Shall I start?
Yes.
Okay. Kunta. So this, I think I am audible. This, I do not know why the respirology people has put me here. There's nothing respiration here. And the word parasomnia is very scary. Lady Macbeth and the killer. What parasomnia knows mostly as somnambulism, and that's why I put there's the old belief that people walk, kill, they don't know what they're doing. I think this picture is not scary. This is what I received before I went for it. Only a small glimpse. These brick red are the wake up life activities, and the blue are sleep. When the child goes to sleep, slowly they coordinate. What happens in parasomnia, they don't coordinate. They don't coordinate, they go reflex, and they, up to 2 years, the small interconnecting reflexes are expunged. But after that, it takes 11 years. So in children, this is where this communication or what they call disorganization between them. The problem is on motor system. They can work autonomic system, flushing, terror, and of course arousal. In non-REM sleep, they are usually in the N3, the last part of when he's going to deep sleep, and in REM sleep. It can be mixed, it can happen in nap also. Only a small chart. When the child goes just to sleep, he can have these attacks. Hypnic starts, some myoclonus like. When he is in non-REM, first part of sleep, he has 3. Confusion, arousal, sleep terror, sleepwalking. We don't want to make jungle of words, but these 3 are just like episodic viral wheeze and multi-trigger wheeze. They intertrigger. They can go from here to there. Then the REM sleep, the nightmares. And finally, sleep-related enuresis. Nocturnal enuresis is a subject of nephrology, neurology, but this is parasomnia. Bruxism is another topic. We always relate it to giving deworming. We'll talk only on these few. If it works, I think. Yes. Sound. Okay. Okay. So these two, this is an early stage, this is a of sleep, this is last part. Okay. So this looks basically like a seizure disorder. This is very common practice in day-to-day practice. What is this? And okay, sir, you are right. They don't do all in sleep. So what exactly comes with this? You just need a video clipping. You don't need to do anything to get the diagnosis, right? So we'll have a clinical differentiation between a early sleep parasomnia and late sleep parasomnia. The basic issue in early sleep, they will always be drowsy. They can't remember. It's difficult to wake up. They close their eyes and fight before, say, 2 a.m. in the night. But in the late night sleep, REM sleep, they are all aroused. How to differentiate basically is a single line. They will remember the late sleep nightmares. They will remember, ऐसा ऐसा हुआ था, डरा दिया, मार दिया, रेल से गिर गया. But the early arousal group, they will not remember. That's a basic clinical diagnosis. These are the three parts. Why should we differentiate between these? Because they are the same, what you call panel of diseases. It can interchange. In first part, they are all in the early sleep. In the first part, they are only arousal, CNS activity, cortical. In the second part, they are autonomic, flushing. They are very horrifying, scary. And the third part, you see the somnambulism, the work down. The only ambulation is here, agitation is more in this part. But they all interchange, and the most important, they can be diagnosed clinically and to be managed clinically. The management of early sleep parasomnias are, of course, safety and all points on better sleep. These are all known: good food, good sleep hygiene, good activities, minimum trauma, no TV, horrifying film. Very rarely you may need some benzodiazepine. I only stress drugs at all if needed and in early sleep or non-REM parasomnia. In nightmares, you rarely need drugs because that won't work. Nocturnal seizure, I think Indu is there. He is a master of this. It can arousal parasomnia is the early NREM. It can usually appear in slow wave SWS NREM stage 3, rhythmic delta and theta wave. Only the EEG will be abnormal in nocturnal seizures. It can happen in any time. Early sleep, not like 5 to 10 minutes. It would have been a status, only 1 to 2 minutes. And the most differentiating point in the daytime. In daytime, these parasomnias will have sleep disturbed breathing or other sleep issues, but they may have seizures. So in this particular differentiation, you need an EEG. If you want to do a polysomnograph, do a 16-channel EEG. With the polysomnogram, we can differentiate these two, but very rarely needed. And these are again sleep terror and night early versus late. They are confused and disoriented. They are functioning well, and they spontaneously goes to sleep. The early one, the nightmares will get up. They don't want to sleep. These are only basic issues and clinical help in diagnosing clues for this, because parents will ask most of the cases at night, sir, this is happening, this is happening, this is happening, and they are very common. Sometimes they don't ask. And management of late REM parasomnias are usually reassurance by parents, rehearsal, relaxation, mostly by psychologists, clinical supply. The commonest reason are bullying in school. emotional outburst and parental fights. These are more important in late REM parasomnia. These are all clinical. We can do it at home in our OPD setting. Hardly you need a polysomnograph or MSLT. This is again very common topic. The incidence is 18-year-old only 1 to 2%, by 10-year-old only 5%. The primary enuresis we all know are usually never continent for 6 months. There can be genetic issues, other issues. And the secondary you all know there are a lot of issues, more urine, less control. But what the question is, why in sleep? Does it appear in nap? The most important, the vasopressin secretion, time to maintain control, and OSAs. If the child is suffering from obstructive sleep apnea, the chance of enuresis is high. So this is more parasomnia than a neurological disorder. And treatment we all know, behavioral, control, maintenance, age. There are small, this is not available, that part in Calcutta, but alarm systems in the bed, and finally drugs. And maintenance is at least 2 weeks of continuous. This is very important issue if the child, adolescence goes to a group activities outside school for 14 days. Now, in a newborn, this is early onset. Looks like myoclonus, but these are sleep onset myoclonus. Sleep talking, adolescents, these are the common issues people will ask. And this I only kept to bruxism, just a part of slow. These are groaning and benign sleep myoclonus. Rhythmic movements, even in a small child. Under the bed. These do happen, don't laugh. These are all practical problems as in clinical, these are all parasomnias or sleep disorders. And finally, if the child has night wakings, we should always exclude, is it inadequate sleep hygiene or there are chronic cerebral palsy, congenital issues, medical issues. This is the basic. And there are 3 groups. Khali ratri ute puchche, they comes and ask for basic OPD. How do you proceed? Group 1, they have sleep, disturbed sleep, snoring, fragmentation of sleep. We will always try to exclude snoring because OAC is associated with night wakings and parasomnia. And if there is no snoring, there are 2 issues very rare: narcolepsy, sleeping at day, and moving and kicking at night. There are specific MLT and PSG, and of course PLMD is a small issues. Kicking is narcolepsy is a really complex problem. There are a lot of criteria, 4 criteria, and PLMD is leg kicking at night, difficulty waking. Again, PSG will help, and it's only episodic, small. You said up to 8 to 9 years. First part we have discussed. First part is mostly sleep terror, that group, and the last part is nightmare. That's the Lady Macbeth group. And finally, there are variable seizures. And finally, if it is frequent and prolonged, there can be younger group and older group. BIC is a term that we already discussed in the last, behavioral insomnia of childhood. In the children, kichutei shute jabe na. That's limit setting. Shutche, kintu uti baje ma kotai. That's association. This is something very different chapter we are learning. We don't need a polysomnograph. We need some separate issue. And if it is older one, commonest is anxiety, adolescence, substance abuse, and classical insomnia, which is the main part of frequent. I think I am in time. I pay my tribute to Dr. Michael in 2016 from Singapore. They were my teachers, basically, and who never knows. We must pay condolences, of course, already that this great man Mohesh Babu has taught us a lot of things, and of course, especially pulmonology. Thank you very much. I think I have completed in time. Jia. Answer is very simple. If the child is in the first part, non-REM sleep, usko mat jagao, because they will be all never interfere. And but the child in the last part, nightmare, they will always be arousal. So in the first part, kabhi nahi jagao. Am I clear? Thank you. You can choose anything. Any benzoate, nitrazepam, alprazolam, anything, but only if you needed it. Anxiolytic will be more useful. Yes, sorry. Yes, why not? Clobazam is, yes.
Thank you. Thank you, organizers.
Usually, that's why we want to avoid.
For keeping me in this position. And Gautam, I always enjoy because he's my batchmate and I cannot forget that.
Thank you, Dr. Gautam Ghosh. If there are no further questions, because we had time for discussion this time, so we will then move on to the next session. I would request Dr. Arup Roy and Dr. B.K. Manocha, please. Dr. Arup Roy and Dr. B.K. Manocha. So, please come onto the stage to welcome none other than Dr. Sushil Kumar Kabra, and he is going to give us the recent updates in pediatric tuberculosis.
Thank you, organizing committee. Today's topic and the presenter is none other than Dr. S.K. Kabra. He is known to everybody and he is coming regularly at our PULMOCON, and PULMOCON and Dr. S.K. Kabra is synonymous, and she will tell us the recent updates in pediatric TB. Sir, the podium is yours. Thank you.
Respected chairpersons and friends, as he said, I come very frequently to Kolkata, so I feel that this is my second house, and I become nostalgic because 40 years ago my parents stayed in Bada Bazaar for 10 years, and I used to come here very frequently and in this area in the morning hours. So now I'll take you through some updates in TB, including epidemiology, our targets, diagnosis and treatment. Diagnosis I'll be brief because we'll have a discussion following this. So this is the overview. So if you see the epidemiology, you can see very clearly we are on the top. We are leading, that we are having a 27% of the total burden of tuberculosis in the world. But that is not a good thing. Second thing is that out of 10.8 million people, around 1.3 million were children. And it can happen in all age group and anywhere in the world, but we are having a significant number. Second thing is, some of you may be very optimistic, some of us may not be so optimistic about the call given by our Prime Minister that we will eliminate TB by 2025. And this is the UN high-level meeting for TB in 2023, and as we all are aware that we are not going to achieve those targets. Initially it was given 2030, now 2035, and we have to revise our targets. And where we have to work very hard. These are the things. TPT, I'll be discussing about TPT in the end, treatment therapy for prevention of TB, and where we have to work very hard because we are just 21%. Then funding, this is universal problem, and I'll be discussing that what we can do, what is our responsibility. Funding research and new TB vaccine. So these are the targets where we have to work hard. So these are our reports from our TB report from Government of India and TEP, and you can see that we are very happy to say that from 237 per lakh, we have reduced it to 195. And you may be aware that our target was that we should be having less than 10 per 100,000. So we are not discussing it that we have not reached to the target, but we are very happy that we have reduced it by 17%. Second thing is that there is an improvement in the treatment that is good, that from 68% it is 75%. We are making progress, but there is enough scope, and I am very optimistic. And there are definitely some positives of giving a call that will eliminate before 2025. So, what policymakers have to do? They should find reasons for not achieving the target. They should have said that this was our target, but we have achieved only this, and what is the reason? And then, whether this target, we accepted it, whether it was unrealistic, then we revise it, or we find the problems in the program. And most important thing is that we have to take a corrective action. And how we can take a corrective action? I hope some policymaker may be here. He should not get annoyed with me. But our problem is that we have accepted the call given by the highest person in our country, but we have not followed his advice that we have to learn what are the problems, listen and keep our eyes and ears open, listen rather than speak. So this is the problem with our policymakers. Then only if we know that what a pediatrician is facing when he is seeing a child, he is sending the sample, whether he is getting the report, whether there is a availability of the medication, where is the problem in follow-up, all these things are missing. Just we say that we are to do this thing. Okay, so that is very important. But what we are, how we can contribute. So one is identify the children. That is our primary responsibility. Treat them, start on TPT. So it is a reverse. That if someone in the household is having a tuberculosis and we have identified a child, then we should be screening the whole family for starting TPT, so that the pool of TB patients infection may go down. And we have to speak to our policymakers if they are willing to listen. So now, this I have changed my lecture. Instead of speaking about the TB, I have taken some cases and changed it yesterday only. That the 6-year-old girl from Delhi, fever, cough and weight loss for 3 months, TST or Mantoux test is 22 millimeter using 2 TU. So it is important why I have highlighted it, because you have to use a 2 TU, not the this thing, 10 TU, 5 TU. Gene expert was positive, RIF resistance was not detected, pulmonary TB and treated with for appropriate regime, that is 6 months treatment, and CXR was done at the end of 6 months. If child is responding, do not do it before that. Another similar child, 8-year-old, history of fever, cough, not gaining weight, 4 weeks, no contact with the TB patient, not specific in X-ray showing a non-specific infiltrates, and gene expert was tried by doing a gastric aspirate and child was not cooperative. Sample was sent and it was reported as negative. Given amoxicillin, diagnosis of pulmonary TB was made and treatment was started. So out of these 2 questions, one is microbiologically confirmed and another is radiologically confirmed. Reasons for not able to having a microbiologically confirmed TB in the second child. Then we had a sample frequently, we send a sample frequently, say 10, and we get only 1 positive. Then if the diagnosis of TB based on clinical radiology in more than 50% of the patients, then why I should be doing all these things, doing a gastric aspirate? And reasons for not able to have microbiologically confirmed TB in second case, what are the alternative samples? So questions are valid and answers are: pediatric TB is possibacillary, sensitive sensitivity of investigations are likely to be lower as compared to adult patients, 30 to 50%. Results of lab test will depend on type of TB, like small node, consolidation, cavity, and it may be that the sample was not taken properly. If not appropriate sample was taken, in that case we are going to get a false negative results. So what can we do to improve this thing? So till now everyone is aware that we do a sputum sample, we do induced sputum, gastric aspirate, gastric lavage, bronchoscopy, broncholar lavage. The other tests, other samples which are in the pipeline include stool, urine, tongue swab and blood. And what are the tests? You do a test on the biological sample including these Gene Expert or CB0, Expert Ultra, TrueNAT. These CB0 is available and TrueNAT is available in our national program. Ultra has not yet been included and their sensitivity is 45 to 70%, and this is against the culture, NDIT culture. So it is not something like if I send 100 children, then 70 will be positive by Gene Expert. It would be just a 30 to 40. And MGIT is still the gold standard, and another test is sequencing, which is not being used very frequently. Tests in pipeline are biomarkers, urine for LAM, I'll be discussing in detail, circulating RNAs and exome sequencing. So one is that when a pediatrician is seeing a child, try to do a gastric aspirate or induced sputum or both, then it will increase the yield. And it can be done on ambulatory basis. Call the child 6 hours, empty stomach in the morning, and then put a tube and take out the sample and do a induction of the sputum. So how we can improve the taking a good sample? When you are putting a tube, if it is less than 10 milliliter, put the child in lateral positions. Then if you have access to bronchoscopy, if your gastric aspirate is negative, if you have your clinical diagnosis is very clear that it is TB, then X-ray is abnormal, you can go for a bronchoscopy to see the endobronchial tuberculosis, you can go for a biopsy, you can go for a IBUS. So all these things can be by stepwise. It is not something like everyone will go through all these things. It is gastric aspirate, induced sputum, if that is negative, if possibility is there, do a bronchoscopy and other things. So this is just to show that when we did a study of 41 children who were negative by gastric aspirate, we did a bronchoscopy and you can see that 58% of them were positive by Gene Expert. So it definitely improves your yield. X-ray, these are non-specific, and if there is evidence of lymphadenopathy, miliary shadows in cavities, then these are suggestive of tuberculosis, but not confirmatory. You can do a CT, and if you find this type of conglomerate nodes, and they will improve after giving treatment. In small proportion of patients, you can go for a CT, and this helps in ultrasound guided aspiration also. So after going through these are the tests available. If you do a gastric aspirate, and you have done it on 100 children, almost 30 to 34% may be positive by Gene Expert. If you do if this is negative and you subject the child to the bronchoscopy, then another 35 patients will be added, so it becomes a 54%, 69% of the cumulative total. And if you have a IBUS, then it will become a 75. So it is, if you are using your available resources, you can decide. But this is just to show that if you do all the investigations, it is possible that in significant proportion, you may be able to do identify a microbiologically confirmed TB. So this is all you are aware about it, that if a child is having any of these, not gaining weight, poor weight, fever, unremitting cough, do X-ray, then do a sputum. If that is positive, then if it is sensitive, then you will treat it as a sensitive TB. If it is resistant, then you will treat, investigate and identify the resistant TB. If this Gene Expert or NAT is negative, X-ray is highly suggestive, look for other site, repeat the test, and if test is positive, again the same thing. But if no other cause is found, in that case you are justified in making a diagnosis of, clinical diagnosis of TB. So this is very clear, though it will remain 50 to 60% will remain probable TB, but at least you are 40 to 50% you are able to make a diagnosis, microbiology and confirm TB. Other test, stool examination, and you can see sensitivity is 61% against the reference standard. Specificity of all these tests is good. Another is a urinary arabinomenon, which is part of the Mycobacterium tuberculosis. That has a good sensitivity and specificity. Tongue swab, that is just taking a swab, and then blood for MGIT for mycobacteriemia. So all these investigations are in pipeline, not available in your NT-EP, available is Gene Expert and TrueNAT. So these are good tests that if stool tests can be incorporated, where we have to put it, and the same thing is where we have to put this urinary lamp. Another one is that you do a cytokine, and this was the data generated at AIMS almost 15 years ago, that you can, some of the combination of these transcripts may discriminate between whether the child is symptomatic, asymptomatic, household, and non-TB. So this is just the upcoming biomarker. Similarly, there is another this thing that you do small molecular biosignature, and these are the upcoming biomarkers. Another Make in India tests are upcoming. One is that MolBio is likely to give us INH and fluoroquinolone resistance, and another one is this biosensor, SD biosensor, that will also give the same thing, because our main problem is whether it is a fluoroquinolone sensitive, whether it is a INH resistant. That is very important in deciding about the regime. Other diagnostic test, ultra is not yet included in NT-EP, though it is more sensitive, slightly less specific than Gene Expert. CTB is another test which is similar to that of a Mantoux test, but it includes, instead of a crude extract of PPD, it includes 2 specific antigens, and that's why it is more specific, possibly not affected by the atypical or NTMs. LPA is done as of now only on samples where the bacilli are more than 10 raised to power 4, but it can be applied once the MGIT is showing positivity. So case 3 is this 11-year-old presented with fever, cough, 3 months chest pain, no contact with TB appetite, and appetite is variable, no weight loss. Examination, bronchial breath sound on the left side, with X-ray and CT, X-ray showing the left upper lobe consolidation. Sputum Gene Expert was negative. Probable TB, started on treatment, and after 3 months there is no significant improvement. That's why he came to me. And what are the possible causes? Poor radiological response. It may be wrong diagnosis. I reviewed the history. It looks like it is less likely to be alternative diagnosis. Regimen and adherence, it was good. Airway problems, like there may be a caseous material which is causing obstruction, and that's why it is preventing expansion. Healing with fibrosis, and that's why there is a loss of lung volume. And lastly, DRT, drug resistant TB. As I said, only 30 to 34% will be positive by gastric aspirate or induced sputum. Remaining will remain your probable diagnosis. Okay. So approach is review CT with radiologist, whether the airways are narrowed, and if possible go for a bronchoscopy and see if there is a stricture or other problem, and take BAL for DRTB. So similarly, this girl from Gwalior, and diagnosed a TB, clinico-radiological, started on treatment, but at the end of therapy, child has improved, but end of therapy there is a complete collapse of the left lung, and CT is also showing the same thing. So here is that bronchoscopic finding that there is a significant narrowing of left main bronchus secondary to healing with fibrosis. And in that case, you need to do a some intervention. Since it is a respirology, you have to do a bronchoscopy and then balloon dilatation, and the child improved, of course. So evidence suggests that endobronchial spread of TB is more than thought and may be associated with post-TB sequelae, and need to systematically study the problem so that we can prevent it and protect the lung. We are least bothered about these things sequelae and problem later on. So what is the treatment regime? For drug-sensitive TB, it is 6 months, 2-HRZE, 4 drugs, followed by 3 drugs. Short regimes suggested by WHO but not included in our program is children below 16 years of age may be given 2 months of 3 drugs or 4 drugs followed by 2 months of 2 or 3 drugs, and that has not been included because problem of this suggests that without suspicion or evidence of MDR, and it is a mild disease. So there is a logistics of problem, that's why it is not included. More than 12 months, this is another regime which is included in the program but not available as of now. And another thing is that if it is a TBM, then you can give 6 months of anti-TB drugs including isoniazid, rifampicin, pyrazinamide, and ethonamide. So drug dosage has been revised. Most of us are aware about it, that from 5 milligram per kilo to 10 milligram, and rifampicin 10 milligram to 15 milligram, and so on. So we should be aware about using the doses. And formulation, as in anti-EP, it is a wet bands, and accordingly you can give the treatment, and with lot of effort we have we were able to convince the anti-EP that once the child gains weight, he should be provided additional doses so that he is not given low doses and creating more problems subsequently. So no intermittent therapy. Category 2, some of you may be aware about it, 10 years ago it has been abolished. Why there is the ethambutol? Because primarily INH resistance is in the tune of 10 to 14%. That's why it is being included in our program, and it is a fixed drug dispersible tablets which are available for us. Follow up the children every 2 to 4 weeks in the beginning, and even after completing, follow them for 3 months, every 3 months for 2 years for relapse, and seeing the morbidity which patient might have acquired due to tuberculosis. Look for clinical resolution, respiratory difficulty, weight gain, and complete or partial or no response to these treatment. Microbiology only if initially it was positive. It is good to do at 2 months by doing a gastric aspirate. X-ray only at the end of treatment. No need for, if child is responding, no need for repeated X-rays. When to suspect drug-resistant TB? So if history of treatment already treated, close contact, if close contact person has died of TB, though he was not known MDR TB, or failure to improve clinically after 1 month, think of DRTB, but not to start the treatment and investigate. And investigations would be same as primary tuberculosis, and send a CB NAT as well as MGIT culture. If child is more than, then decide about the drugs. And drugs are, just to give you a glimpse, that there are 3 groups of drugs. And we are not supposed to know everything. Once you suspect DRTB, investigate. Send a gastric aspirate for the expert as well as MGIT, and refer him to a center where there is a expertise which happens. So these are the 3 group of drugs: Leoflox or Moxiflox, Bedaquiline, and Linezolid. In the second group, it is clofazimine and cycloserine, and rest of the drugs are in C. So your regime would be based on these 2 groups. And just to give you a principle, that now some of you may be aware that we were treating 18 to 24 months with injectables, but now all oral medications for 6 to 9 months are available of different combination. And one of the regime is BPAL regime, which is after 14 years of age. This is just to show you that there are some shorter regime, all oral, So for a general pediatrician, try to suspect, identify, send the investigation, and then send to the concerned person. And for time being, children below 5 years of age, we are not allowed to use bedaquiline and lemonade, and that's why we are still giving them injectables. So you should be aware about it. But we are going towards the all oral shorter courses of 6 to 9 months. So important thing, TPT, preventive therapy. So who should get it? Patient living with HIV, adult and children, and infants less than 12, household contact, all should receive TPT. HSC above 5 years of age in all. So now the latest recommendation is that all household who are in contact with the microbiologically confirmed TB patient should receive TPT. And those who are drug sensitive, then 3-month weekly isoniazid and rifampicin above 2 years of age. And those who are below 2 years or this drug is not available, in that case 6 months of isoniazid is fine. Those who are in contact with a DRTB, and if you know fluoroquinolone sensitivity. So here comes the importance of getting the fluoroquinolone sensitivity, because your regime will depend and your TPT regime will also depend on this. Last problem is that we are least bothered about whether these patients have some problem. We are not bothered about their rehabilitation. So this is the data that suggests that out of 52 patients who were treated for pulmonary TB, their problem was they had a restrictive pattern on spirometry. And ongoing study suggests that at the end of therapy, it is around 50%, but over a period, it may reduce. So it may create a trouble, and that's why this is responsibility of all of us, that instead of just ignoring and that the child has become okay, we should stop it. That is not follow up these patients. That is not desirable. That we should be seeing that yes, these patients may also get some sequelae. So to summarize, we should try to document by various samples. LEM and biomarkers are emerging. Drug dosages have been revised, and pediatric formulations are available. We should try to use them and monitor them by the child specific. And for suspected TB, not to start second line, but investigate. And TPT, we can play an important role for drug sensitive and drug resistant TB. Thank you very much.
Thank you, sir. About the eradication, 25 was the target date for India, and WHO suggested 2030 for eradication. How far are we from that goal? Total eradication by 2025 was the plan India was thinking about, and WHO said 30. So how far are we from the target?
As I had shown in the second or third slide, we are far up from the target, but I am optimistic for this thing that with this call given by WHO and then our Prime Minister, that more importance is being given to the TB. Earlier, they were not listening anything. Now, every other week, there is a meeting in the NTEP. Though, as I said, problem is that they are not listening. They are just speaking. But I am very confident that this has decreased the TB incidence, as well as once we have a more TPT and these facilities are more readily available. Still, if I ask all of you, there may be still significant problem in sending the sample, getting the report, drug supply. All these things require improvement.
Thank you, sir. Any time for question? I don't think.
Thank you very much. Thank you, Dr. Manocha. Thank you, Dr. Roy, for being here. And you can proceed for the mementos outside at the memento stall. Dr. Kabra, please stay back. We need your expert advice and guidance in the next session on deciphering TB diagnostics. Dr. Shubhashish Roy is going to present this along with the panelists who will be Dr. Chetan Trivedi and Dr. Indu Khosla, Dr. Kishan Chugh. So,
Just one small comment in the previous talk. Remember the drugs which are there in tuberculosis.
Hello, hello. Hello, hello.
Please avoid rampant use of these drugs, otherwise we lose them in our TV market.
Change the slide changer. Oh. So, we have a very august panel or very learned panel, and it is like bowling against Sunil Gavaskar, Sachin Tendulkar, Rahul Dravid, and Virat Kohli. And, yeah? It's the Virat Kohli. So basically, Professor Kabra has almost covered the whole topic in a very nice and brief way. Some of the slides may look a bit elementary, but my presentation is intended for the general practitioners or general pediatric practitioners like us, not for Professor Kabra or Chugh or Indu or Chetan Trivedi, who are doing more pulmonology than general pediatrics. So some of the slides may be slightly elementary, but anyway, they all try to give you a specific message. Now, did you know that genus Mycobacterium originated more than 150 million years ago? And 3 million years ago, there is an evidence that the human being were infected by something like Mycobacterium tuberculosis. And few Egyptian mummies carry features of pot spine. Temperature and rainfall can influence the TB epidemiology. And wind opening, wind speed, sun exposure, religious gathering, usage of public transport, all can impact. This picture is a picture, this ceremony was known as King's Evil. This disease was known as a King's Evil. At that time, people used to think that the king had a divine power, and if it touches the child or the adult, then the person will be free from tuberculosis. And this system persisted till 18th century. This picture is taken from the net, and this ceremony was known as King's Evil. Now straight to the case. 6-year-old Giant, 6-year-old Giant, fever, cough since 1 month, weight loss, respiratory distress for 5 days, 12 kg, pallor, breath sound reduced on the right side, occasional bilateral crepitation, hemoglobin slightly low, total count more or less okay. This is the X-ray. What next? So my first question to Chetan. Symptoms that point towards TB in this case.
So as we know that whenever we have a case which is having a long-standing fever, cough and illness, maybe more than say 15 days or 1 month, you usually keep you suspect a tuberculosis. When we suspect tuberculosis, it is not just a fever, but we have to have a fever which has been documented at least once, which has been continuously there, say maybe more than 15 days. Cough also, it is also important, it has to be non-remittent, because many of the viral cough, it initially comes and it takes time to regress. So that is important, it should be more than 15 days, unremitting cough. And weight loss is also many a times it is very significant weight loss to be there, more than 5% in last 3 months, or if you have been giving proper nutrition, still if child is not gaining weight. In malnutrition, we have to take care of that. So these three symptomatology is very important when you precisely suspect. And also, we need to ask for the contact history. And in contact history, we have to show at least if any active tuberculosis case in 2 years. If everything is fitting into that, then you suspect and then you go ahead.
Clinically, you can suspect TB.
Yes.
Now, Indu, which one is more common, cough or fever? In your practice?
Fever is definitely
fever
more common.
Fever is more common than cough.
Yes.
Right, right. So, some features of EPTB, that extrapulmonary TB, that is peripheral painless swelling, meningitis of insidious onset, spinous gibbous or pot spine, and non-specific symptoms in a contact of an infectious TB case. So these are the features. The fever must be documented, the weight loss must be documented, and the cough should be unremitting cough. It is unlikely like a cough for viral infection coming and going, it is not a cough for TB infection. The cough will be unremitting, persistent cough. My next question to Indu, after initiation of therapy, how long the fever can persist?
So once you have confirmed this is tuberculosis and you have initiated the correct treatment, so the fever can be there from 2 to 4 weeks at least.
Right.
So you have to look at all parameters, just not only fever, you have to look at the child's general well-being, weight gain, appetite, everything. So the fever can persist to 2 to 4 weeks even after starting.
And when you can expect a weight gain? Yes. Post initiation of therapy. Weight gain कब से चालू होता है?
So weight gain can start as early as 2 weeks. It depends how quickly the fever abates, but it can. But I think we should counsel the parent that it may take 2 weeks or so for the fever to break and the weight gain to start. It's very important that we have instituted the correct treatment here. We have looked at it as a sensitive TB and it is TB.
So for weight gain, many of us expect that there should be 3-4 kg weight gain. But it depends on how the patient has presented. If patient has presented with weight loss, then they will regain it. If it has not much weight loss, then it will be gaining weight as per his
Slowly.
actual.
And 25% do not gain weight at all. So that thing also can happen. Now coming to the same case, treating doctor did few tests, Mantu 2TU 8 mm in duration, IGRA positive. The treating physician did both. Mantu, IGRA, ESR was 54. My question to Professor Kabra, importance of CBC, ESR, Mantu and IGRA for diagnosis of TB.
As far as CBC is concerned, ESR is concerned, there is no role unless you are suspecting it to be a bacterial infection, and then it may have some soft role.
Right.
Second thing is regarding Mantu test and IGRA, they are also not part of, as you had seen, not part of the algorithm because of various logistics, including non-availability of a standardized PPD. People are doing with 10 TU, 25 TU, 5 TU and so on. That's why I had highlighted that 2 TU or equivalent doses.
Right.
IGRA is an expensive test, and it may only, Mantu test as well as IGRA, they'll tell only the infection, not the confirm the disease, unless either you have done a silver IGRA or golden IGRA or other IGRA. So these do not have much role in diagnosis of TB.
So they are important only for infection identification or latent TB identification, Mantu and IGRA. So my next question to Chetan, what is the relationship between TST, IGRA and CTB, the new chalk on the block?
So I think TST is, we know that is Mantu test, which we are doing a skin test. And we know that it is just, it gives that it is infection, not the disease. And we use this Mantu test very rarely in conditions where suppose you have lymph node.
Now, do you do the Mantu test currently?
I do it in very selective cases. Suppose I get a lymph node tuberculosis and we get a biopsy, typically we get a caseation. We make granulometers and usually MT comes positive in cervical tuberculosis, lymph node tuberculosis, maybe 70% of cases.
But currently the standardized solution is not available.
No.
Chuk sir, will you do the Mantu test?
So actually it is not been advisable to do because the original slot from where the PPD was derived, it is not available, so we cannot derive much. Second thing, so now we are going to other options, that is IGRA. IGRA is a blood test which gives you you take a sample and you see whether the antibodies or the antigen reaction is happening, where interferon has been released in response to antigen, that is tuberculosis antigen. So that is, say, a second test which is a costly, costly test. So we don't use it much. Only when we want to see, suppose people, children are traveling abroad for further studies and you want to see latent TB, then it has been used. And the CTB is again, it is a skin test. It is, modified sort of, because again there is a specific antigen, E-stat and CFP10, against which we have been testing. So again it is same like Mantu test, we give it intradermally, you check it, but the cutoff here is 5 in place of 10. When TST usually BCG, it affects the result, but this CTB, we don't get a BCG affection. Now something which is CTB is not available, I suppose, but it is something like CYTB, which is available from, which has been derived by a Serum Institute by my lab. But I think this is also not for open market. It is maybe taken up for the NTEP, I'm not sure. So that is the difference between these three things. IGRA is a blood test, CTB and Mantoux test, both are the skin test, hypersensitivity. But basically they say that it is an infection. It is not proving that it is disease or it will progress towards the disease or not.
Okay.
There's one thing that there is a slight advantage of CTB and IGRA over TST, BCG as well as non-tuberculous mycobacteria, which will not be interfere in the interference.
Interfering the result. Chugh sir, are you doing Mantoux test nowadays? And what is your experience with CTB?
CTB, of course, we have not done any. IGRA, yes, is a slightly better than Mantoux test. Mantoux and IGRA will both tell us infection and not disease.
Right.
But there will be situations where we want to know whether it's tuberculosis or some other disease. That means, say, lymph nodes, extrapulmonary tuberculosis. In pulmonary only, we are comparatively easily going to get MTB demonstrated by one of the either gene expert or a culture or something like that. In the rest, it is sensitivity and is much poorer. To begin with, yes, it can be an indicator. Let's move on to this pathway of tuberculosis diagnosis.
Okay. So, Professor Kabra, you wanted to add anything?
So, IGRA and CTB both are the same thing. IGRA is in vitro and CTB is in vivo, because they are having both these two specific antigen supposed to be better than the crude extract which we are using in form of a PPD. So it will reduce the false positives. As of now, these can be used for identification of TB infection who needs a TPT. But for logistic reasons, they are not being used for identification of people who should be given TPTs. That's why the government suggests that give it to all after ruling out this thing. But in a high-risk groups, like those who are having steroids and then immunocompromised, you can do these tests to identify, or you are planning that you will start on steroids or chemotherapy. Better to go for a IGRA or CTB, and then identify them and give them TPT.
Is CTB available in the market?
CTB is not available in market, but it is available in the program till age, above the age of 12 years. And it should come early, the permission for use it below 12 years of age should come, and it may be superior to that of a Mantoux test.
So don't do the Mantoux. None of the solutions are standardized. CTB as of now is only approved after 12 years of age, and it is included in the program. So my next question to Dr. Chugh. Now this child, the pleural tap has been done with the ADA level of 66 units. Now what is the importance of ADA in pulmonary and EPTB diagnosis and prognosis and chance of positive CB-NAT in pleural fluid?
Well, ADA is a test that we have never really practiced, and somebody has already done it and patient comes to me, that's a different situation.
So you don't rely upon ADA?
The reason, good reason is that there is no real cutoff for children. We do not know. As it is, there's nothing very specific about it, even in adults. So we don't practice or try to interpret anything in favor or against tuberculosis on the basis of ADA. Yes, as far as CB-NAT is concerned, that is a very specific test.
Yes.
However, the positivity rate in pleural fluid is much lesser. Pleural fluid is very often a hypersensitivity reaction and not really a disease process in the pleura in that sense, and that is why probably the rate by which the positivity is somewhat less. So it is, whether it's a pleural fluid or a ascitic fluid, rate of pickup by CB-NAT is less.
Right. So it is very poor in pleural and ascitic fluid, yes sir.
So ADA is extrapolated from the adult pulmonary or adult medicine. And they are differentiating this, using this test to differentiate between malignancy and TB. And for pediatrics, we are more interested in differentiating whether it is a empyema or whether it is a TB. So you cannot extrapolate it, and that's why it doesn't have any role as for, and these are the institution based, because some biochemist in the medical college has established this test, so all pediatricians as well as physicians were sending these samples, so some institutions are still using it, but possibly we should not be unnecessarily doing this investigation.
So basically, the pleural fluid and ascitic fluid is a poor CB-NAT. The chance of getting positive CB-NAT is less compared to respiratory specimen, lymph node aspirate, sparse and CSF. And ADA is good for the adults, but not so good for the children. And this is from pediatric TB management guideline and what Professor Kabra and Dr. Chug has already said. Now this is a child 3-year-old with cough for 1 month, fever for few days, low grade, not growing well, picky eater, 3 courses of antibiotics. The child has not improved. Weight 11 kg, slightly on the lower side. The child is having anemia, no lymphadenopathy, bilateral crepitations and bronchi. Father has a chronic cough. MAN2 15 with this X-ray. Indu, will you start ATT? This is the X-ray and MAN2 is strongly positive, 15.
I think there are a lot of gaps in the history here. I would like to tease the history a little more, whether it is a recurrent cough versus a persistent cough.
It's a persistent cough.
Okay. Then the second thing is whether it's a documented fever or not. That's another thing I would like to see. And what do they mean by not growing well? As we discussed in the beginning of the lecture, so I think all that needs to be teased out. And obviously there is more of wheeze and creps, which is not very suggestive of tuberculosis, a generalized bilateral creps and wheeze. Father has chronic cough, maybe he's an asthmatic, maybe he's smoking, some trigger may be there in the house. Just a standalone TST of 15 millimeters and what strength?
What about the X-ray? With this
I'll come
X-ray?
there. The TST also, I don't know what strength of strength has been used. So
Yes.
suppose it's like, sir, I didn't know 25 TU is also available. I thought 10 TU, then it may be a false positive. So I would definitely not start ATT. The X-ray, if I look at the X-ray, it's a little bit of an expiratory film that looks a little cardiomegaly.
Yes.
There's a bilateral, bronchovascular markings which are prominent. It is not a TB specific finding where you will say, okay, where you can make a clinico-radiological diagnosis. So it doesn't fit into that
The
spectrum.
mediastinum is slightly widened.
Because-
Actually, this is an AP view.
Yes, yes.
This is
it
an AP view. The mediastinum is widened, but it is not fitting with any characteristic features of the tuberculosis. So it is wiser not to start the tuberculosis. So it is a presumptive TB. We have already discussed the fever, cough, wet loss, etc. The initial screening test nowadays are the chest X-ray. And what the suggestive of TB in the X-ray, one is your lymphadenopathy. It can be paratracheal, it can be subcarinal or hilar. It can be miliary, though miliary is not always confirmatory for tuberculosis. Your sarcoid can produce miliary TB, histoplasmosis, fungal infection as well as some of the hypersensitivity pneumonia and cancers also. But by and large in our country, miliary TB is very much suggestive of, miliary shadows are very much suggestive of tuberculosis and fibrocavitary lesion. These are very specific for tuberculosis. And the primary complex involves a subpleural Gons focus. I am not going into the details of Gons focus is most of the time not visible. Only the hilar nodes are visible, like in this X-ray you can see the hilar node and you can see the lymphangitis, but you cannot see the subpleural Gons focus. On the left hand side X-ray you can see the calcified Gons focus as well as you can see the lymph node is also calcified. There are calcification. Now, Professor Kabra, when to repeat the X-ray?
As I have already said, if you are seeing some X-ray abnormality in the beginning, you do an investigation to identify MTB or complex. If started on treatment, don't know and see response to the fever, weight loss, appetite and respiratory finding, then possibly no need of repeating an X-ray. You repeat it at the end of therapy. Okay. No need for repeating every month or so, which is a habit of some of us.
So if slow resolution or no resolution, any deterioration and at the end of CP, continuation phase. Now a child 10-year, persistent cough for 1 month and fever, this is the X-ray. There is a large paratracheal lymph node. The smear has been done first time, the smear is negative, second smear is also negative, the third smear is also negative, MAN2 is strongly positive. My question to Dr. Chug, what is the place of smear examination in TB diagnosis? Do you do it routinely?
This is a 10-year-old, so I'm assuming that he can produce some sputum which is actually a sputum and not just saliva or something like that being given for testing. Very often that's what happens. So assuming that this is a proper sample, even then the sensitivity of smear examination is very poor, and that is why whenever possible, please do CV0 instead of smears these days.
So smear comes after CV-NAT. Should we do the thing simultaneously, CV-NAT as well as smear? Should we send the sample simultaneously?
Yes, some advantage that suppose we get a smear positive and we want to check the resistance pattern, rifampicin resistance is already coming, we want to do LPA, then it may be useful to pick up this patient as this patient sample and go ahead with further testing. Otherwise, it does not add anything to CV0.
Yes, Indu.
There's only one more thing where I think smear should be done. One is for LPA, as Dr. Chug already mentioned. But suppose your smear is positive and your gene expert negative, it could be a marker of a non-tuberculous mycobacteria. So that's another role why I would do a smear. It will also tell you it's a possibacillary disease or
do we need to send smear for every child or not?
I would definitely make an attempt if we can get. We can also know about the, if it's the contact. So if it's, of course, it's a pulmonary TB, you're going to give TST that they have to do.
Sir,
but if
should we send the smear every case or not?
So as far as whether it should be done in every case, no. Because if you see smear positivity would be 5%, 2 to 5%, and depend on what is the severity of disease. As compared to, say, gene expert, which would be 30 to 35%. So it is 7 times positive and it is more reliable because smear will need an expert person.
Yes.
So that's why it's not required. In a repeated, when you are doing it at a follow-up, you can do it. If you want to have a LPA, then you can do it. Otherwise, LPA can be done on the culture.
So the message is clear, not every child you should send for smear, but it may be helpful in some cases, especially after the treatment or for follow-up or before doing the LPA. So diagnosis of TB, I am not going into the details. There is a strategic shift in the TB diagnosis. Now detection of resistance to key drugs are very important. What is an universal DST? Earlier the old definition was identifying rifampicin resistance. Now it is rifampicin resistance, and if you get rifampicin resistance, then check for fluoroquinolone resistance and other like INH resistance, etc. And UDST is a protocol now under NTAP India. Pulmonary TB sampling, the best sample is the self-expectorated one. If you are not getting, then a gastric aspirate induced sputum, bronchoscopy, EBUS and tissue biopsy, they are all invasive. Professor Kabra has already discussed about that thing. Now coming to the next case, 12-year-old female, low-grade fever, 3 weeks, cough for 2 months, blood in the sputum for 7 days, and this is the chest X-ray. Now this is a recurrent tuberculosis. This child suffered from tuberculosis at the age of 1 year. You can see the fibrosis in the left lung. It is much smaller than the right lung, and this is a pulmonary TB. This is from the NTEP card. It is a pulmonary TB, microbiologically confirmed and previously treated TB. Now the child was treated in March 2024 and the treatment was completed in September 2024. You can see it. Now, last week of April 2025, the child developed a swelling on the right side of the upper dorsal vertebra. The cough was very mild at that point of time. We thought of pot spine, send USG for the swelling. And the USG says the right paraspinal cord abscess and Cox to be excluded. Twice, the child was tested for CV-NAT on 9th of May and 11th of May. Both the CV-NAT tests came negative. So my question to Chetan, strongly suspecting pulmonary TB, CV-NAT is negative. Does it exclude TB?
So that takes us to the question, what is the sensitivity of CV-NAT? In what part of sample? So whenever we talk about CBNAT sensitivity, it is always in smear positive patient or culture positive cases. So culture positivity is a gold standard. Out of that, how many you get positive in? So if you get negative, that doesn't rule out, obviously. Similarly, if you have a blood culture negative, then also it is, culture negative, that also doesn't rule out. So yes, if you have very strong suspicion, you can keep that doubt of tuberculosis in mind. Yes. It doesn't rule out the negative CBNAT.
The message is loud and clear. It does not rule out tuberculosis if it is negative. Now, these are the results you can get in the CBNAT: MTB detected, reef resistant detected, not detected, indeterminate, MTB not detected, error invalid, no results. These are the CBNAT results, and all conclusive results are MTB not detected and MTB detected with reef resistance detected, reef resistance not detected. Rest are all inconclusive and you have to repeat the test. These things Professor Kabra has already discussed. The TrueNat and CBNAT, one is from USA, one is in our country. Basically, they are for the same purpose. Their sensitivity, specificity, all are more or less same. You can use any one of them. Only the advantage of TrueNat, it can be used in the places where there is no electric supply also. It is a battery operated, and turnaround time is also same, sensitivity, specificity is also same. Now,
Sir, just
yes,
one comment on that indeterminate, because when you get an indeterminate, that doesn't mean it is a partially sensitive.
No, you have to retest it.
So yes, so it is the machine is not able to detect it.
Right.
Resistant
so
or non-resistant.
Reject the result. Don't accept the result.
Yeah, repeat the test.
Repeat the test, yes. So 6 months old child, swelling on the left thigh, came to me after a DPT inoculation from a government hospital. The swelling was tender, there was no fever because the child already has received a course of coamoxiclav for 10 days. Now I sent the child to one of the very renowned pediatric surgeon, and this was the USG left mid-thigh anterior compartment 39 into 16 into 25 millimeter size of encysted fluid, and septa and loculation noted in it. Now I do not know why the surgeon sent for a gene expert of the past, because we thought it a post-inoculation abscess. But it came Mycobacterium tuberculosis detected low and rifampicin resistance not detected. Now my question is that MTB detected very low, reef resistance not detected, or MTB detected very low, reef resistance detected. What will be your next step, Indu?
So if MTP detected, and so you cannot comment on reef resistance. So if you say MTB detected very low, that is positive for, you have to treat it as MTB. You cannot not treat it as TB. So this is a new case, you will have to treat it. But MTB detected very low, reef resistance detected, if it is indeterminate, you will definitely repeat it. But here, I would definitely think that this could be reef resistance, but maybe I would want to repeat it.
So you will continue with the result?
Yeah, sorry.
Will you continue your treatment with this result, on the basis of this result?
So what was the result? It was first or second?
No, in both the cases, will you accept the result and continue accordingly?
The first one, reef resistance not detected, and if it is low, I will accept that result. That I would treat.
Professor Kabra.
So regarding the second scenario, just go back, that it was detected very low, and reef resistance detected suggests that it may be a drug-resistant TB. And in the standard algorithm for adults, you will say that repeat a sample, reconfirm it, and then treat it. In pediatric patients, because it's a problem of getting the samples, that's why it is recommended even in the guideline that if you will look for the risk factor for DRTB, including those when to suspect. If there is a contact, if child has been given, or if a child is very sick, you will go for a second line, but it is preferable that we repeat and confirm.
This one is likely to be a BCG which was injected into the thigh. My question is BCG abscess, is that sensitive to INH? Is it sensitive to rifampicin?
Pardon? Nothing.
The pus that we have obtained and it's a BCG which is the cause.
It's in the
Will it
thigh.
be INH sensitive? Will it be rifampicin sensitive on CB naught or let's say LPA?
So,
Was BCG given?
Sir,
on
was the
thigh?
BCG was
if it is a
inoculated?
BCG abscess. No, this was not a BCG
Not-
abscess.
So by
So
mistake,
here-
DPT.
No. So this, I would look at mother, whether the mother had endometrial TB. I've had 2 cases like this where the mother was diagnosed as endometrial TB. Maybe the child was, that may have been one of the risk factors. So
the first question is whether to treat it or not.
Ideally, no, we didn't treat.
You have-
It was probably a contaminant sample. We didn't treat. It was not tuberculosis. We retested it and MTB was negative. We retested it and it was negative.
I have seen several of them. All of them turn out to be BCG wrongly given. Whether
Maybe.
whatever
So we
and
didn't
wherever
start-
my
we
friend or
didn't start
whoever given
antibiotics.
it.
Sir, Professor Kabra, yes.
So just a quick comment that even your bovine TB, which is a BCG strain, that will give a positive result by gene expert because it will include it. Earlier it was 6 bacteria, Mycobacterium, tuberculosis, bovine and African and also on. Now it are 8 bacteria which will give a positive result. So we should be careful in interpreting the result whether it is a BCG wrongly given or whether it is really a TB infection.
Yes. So, Dr. Chug, which one is better, Gene Expert or the Reef Ultra? What
Gene
you are
Expert?
using in your practice?
Oh, we use Gene Expert and not Refultra.
Okay.
I do see some reports from here and there where those have been done. I just take them equal.
Okay. So, Chetan, is it approved in the WHO or NTEP Ultra?
So Ultra is not approved. What is the difference between Gene Expert and Gene Expert Ultra is Ultra will be more sensitive. It picks up the almost 16 bacilli as compared to 131 bacilli of Gene Expert generally. So when the sensitivity is more, then it is going to be a less specificity. That's a problem. So that's why it is to be taken. WHO NTP is not approved this as of now.
Ultra has been approved by WHO for
Not
various...
by NTEP, not in NTEP.
Not by NTEP, and there are various logistic reasons. And it may be more useful where there is a possible bacillary disease, including applying it to the stool sample, applying it to the precious samples. But because of logistic reasons, because we are having thousands of equipment for Gene Expert, so
Yes.
that should be replaced. Second thing is that if you are doing it on the stool sample, then it needs a training of the personnel who will be performing it.
Yes.
So that's why it is not included, but it is in pipeline. Possibly in the near future it will come. WHO has approved it. If you see the 22, 24 and 25 guideline, it is one of the tests which has been approved but not taken up by NTEP because of various logistic reasons.
Thank you. So another test is coming, that is Reef XDR, which will detect 16 resistances, and it can help us because it can be a point of care test, whereas LPA takes 3 to 5 days, it can be a point of care test, but as of now it is not yet approved by NTEP. Now Expert Ultra Trace results, I have Professor Kabra and Chetan already said which one is better. It is a problem with the 2% less specificity. That's why we will be treating some children or adults by Ultra who are not suffering from tuberculosis. That is why NTEP has not approved, and the other reason Professor Kabra already has said. So the next case, swelling of the left paraspinal abscess, the case we were discussing in the end of April. The child first went to the DOT center in the eastern part of Calcutta, referred to Arjikar, sputum, induced sputum, bronchoscopy, everything was done. No MTB detected. The day bronchoscopy was done for bowel fluid, the child came absolutely breathless in my clinic, and probably Amita can recollect, I requested him, the child was having a saturation of 50%. So I said, Amita, can you admit? Then Amita said me, sir, this child may require ventilation, please don't admit in my institution. And the child was admitted in a center where there is PICU. Now admitted and ventilated, the bowel showed MTB positive and reef resistance. Now my question to Dr. Chug, what should be the next step if you detect reef resistance?
Well, in this patient we have got a sample from the bronchodural lavage. which probably is the best sample that you can obtain in a patient who's got pulmonary tuberculosis, parenchymal involvement. So it is to be taken with absolute seriousness. Yes, this is rifampicin resistance, and you will go on to investigating further whether there is INH resistance and whether there are other drugs resistant, and whether it is a full-blown MDR, and you'll choose your treatment plan accordingly.
Okay. So, Indu, what is the first line LPA?
So first line LPA looks at INH resistance, so monoresistance. That is what you would want to look at.
Chetan,
and the first line LPA is if you have a smear positive, you will do first line. Second line, you will also do from the culture. If you do later in the culture, then you would look at other drugs as well. You wouldn't look at INH, arsine, injectables, and fluoroquinolones.
Right. So when should you send the sample for culture DST, Chetan?
I think once you do the first line LPA, second line LPA, and then if you still don't get the results, you should go for the complete drug sensitivity testing. And first line LPA is only for because to know the INH, and second line is particularly for fluoroquinolones, because that is what we want to.
And in the LPA, there comes the importance of smear. If it is smear positive, then only you can do the first line LPA.
Yes.
If it is not smear positive, then you have to do the culture, and then you have to go for the second line LPA.
So if you get culture positivity from that, you can pick up and then you go for LPA.
So it is not a point of care test.
Yes, yes.
Our practice is to send all samples for cultures from the beginning, and not LPA 1, LPA 2, that kind of story, because LPA is not easily available everywhere, and we feel that LPA also tells you only limited things.
Right.
You want to know about 20 drugs or 10 drugs. So from the very beginning, getting a sample for bronchial lavage or anything else in children is not easy. I would send it from the beginning for complete sensitivity.
I would agree with Dr. Chugh. You have to do full cultures.
Right.
But the newer LPAs which are coming in now are at one point of time looking at 16 different mutations and for resistance. So in the future, I think LPA, of course, in a paucibacillary disease, we will have the limitation. You have to have at least a good colony count, then only you can do it. But in the future, I think LPAs would be done more frequent.
That also we'll have to prove that the both are actually equivalent in...
Yeah. So this can be a hypothetical situation where the NAT finds reef resistance, LPA does not find reef resistance, what to do? The thing, it is not a very common situation, but a second NAT to be performed at the CDST center using decontaminated deposit, and microbiologist will provide the final decision. This is the CDST, all of you know that, but it is again only 50% sensitive because TB in children by nature is a paucibacillary disease. And how to collect the samples? Yes, sir, can you tell me? What are the procedures that should be observed while collecting the samples? How many samples and any reagent to be added like this?
Yeah. First and foremost is that it should be appropriate sampling, as if the child is fighting and then you are taking a 2 milliliter sample, that is not acceptable. So it should be appropriate sample. If child is something like this, who is on intubated, ventilated, then endobronchial spread, and you take a sample appropriate and then transport is immediately to the laboratory so that there are no contamination. There is no point of decontaminating it or neutralizing it with the bicarb or other this thing. But it should be transported immediately, and tell the lab that try to do it as early as possible.
Right. So preferably 2 samples to be collected as Dr. Chugh has said, the CDST, when you are suspecting any resistance, CDST must be sent. And for sputum, you need 2 samples, but here also you take 2 samples, one NAT and the other for MGIT, that is a liquid culture. If smear is positive, lab will perform the LPA if the smear is positive. If the smear is negative, do a culture and then you do the second line of LPA. For NAT, single good quality specimen is usually adequate. The newer test perform poorly in culture negative cases. I will take 2 more minutes just. Their sensitivity is less than the culture. The NAT's sensitivity is less than the liquid culture. NAT LP are good, but they are good for rule-in test, not rule-out tests. And NAT negative tests does not rule out TB disease, as approximately 50% of the pediatric TB cases are culture negative due to the very nature of the disease. Now, I will not go into the details of the newer thing. Already Professor Kabra has elaborated, that is NPA is a probability nasopharyngeal aspirate in TB, but their sensitivity is less than the induced sputum. Role of stool sample in TB diagnosis only for Reef Ultra. Bioaerosol sampling, it is a new thing which is coming up. N95 mask coated with a gelatin. Then the child reads something loudly or coughs. The sputum comes out and gets stuck into the gelatin layer. Then the gelatin layer is taken out and tested for the mycobacteria. LAM in urine, it can be done, and AI in TB radiology, that is computer assisted detection protocol, it is coming up. It has already been established for the adults, not for the pediatric protocol. And the USG for detection of mediastinal adenopathy, this is also very important because USG, we know mediastinal structures, it is not good, but USG has a limited role in the diagnosis of pulmonary TB mediastinal adenopathy. But suprasternal and left parasternal approaches to pick up the mediastinal adenopathy are quite encouraging. 67% of the children with TB with normal chest X-ray was picked up by the USG. Now the child, we were talking about, the child suffered at 1 year, then the child was treated in 2024, then developed a swelling in the paraspinal region. This was the first X-ray when admitted in a hospital. This was the second X-ray, this was the third X-ray, and this was the fourth X-ray. And ultimately on 13th June, this child is a next door neighbor of myself, expired on 13th of June. 9th morning I called Professor Kabra when the child was detected with a MTB reef resistance. He helped us by saying few second line drugs which can be empirically to be started because LPA takes 3 to 5 days. The drugs were started, but the child expired. So thank you so much. We need not only the state of art, but we need the state of heart of TB therapy.
Just
Thanks
one
for
quick
the
comment that if a child is getting repeated TB, you are giving the anti-TB drug improving, then always think of whether there is a Mendelian susceptibility for mycobacterial infection. Like in this child, initially improved, then again had the problem, again had the problem. And they are more susceptible for MTB as well as other NTMs. So those should be kept in mind while treating these children.
Thank you so much. Thanks to the panelists.
Thank you for the wonderful session on TB. We will now proceed for the inauguration. For this, I would request the panelists to kindly proceed to the memento. For this, I'd invite Dr. S.S. Rawat, who is the chairperson of the IAP NRC, to kindly take the stage. Dr. S.S. Rawat, chairperson NRC, kindly proceed to the stage. Dr. Arun Manglik, chairperson WB chapter of Pediatric Pulmonology. Dr. Shapon Ray, president WBAP. Dr. Sushil Kabra, chief guest. Dr. Shubhashish Roy, scientific convener, WB chapter of Pediatric Pulmonology, and Dr. Pallab Chatterjee, secretary, West Bengal chapter of Pediatric Pulmonology. I'd request Dr. Shubhashish Roy, scientific convener, to give us the welcome address.
Good afternoon, and thanks to all the delegates and faculties, especially Professor Kabra, Dr. Chug, Chetan, Dr. Rawat, and all of you who have come and assembled in the morning hour to make the program successful. Before going into the other things of the inauguration program, with a very heavy heart, let me tell you, we have lost Dr. Mahesh Babu. And whatever small amount of pediatric pulmonology I have learned from Professor Kabra, Professor Varinder Singh, Dr. Khub Chandani, Dr. Mahesh Babu, and all other doyens of pediatric pulmonology. One very specific help that we got from Mahesh Babu for the Respicon 2023, everybody appreciated the Respicon 2023, not only for the decor or the hall or many other things, or the food, but what was most important was the scientific content. And he was the person who was instrumental in framing the scientific content of Respicon 2023. And it should be a symposia based, what are the topics to be chosen, what should go for the lecture, what should go for the panel discussion. Lot of things, almost 80% was suggested by Dr. Mahesh Babu. And I had a small opportunity to learn the pediatric pulmonology from a conference which was organized by Mahesh Babu in Singapore. Myself and Pallav went there and learned a lot. So he was not only a doyen, but he was a good teacher as well as in the field of pediatric pulmonology. And his slides or his presentation almost 10 miles ahead of our thinking. Everywhere, wherever I have listened his lecture, I was mesmerized. So I request all of you to stand and observe a minute's silence in the memory of the departed soul. Thank you so much.
I'd now request Dr. Arun Manglik, Organizing Chairperson and President, to kindly say a few words.
Thank you. Well, since morning, what I have seen is the excellent gathering, right from 9:30 a.m. onwards. Right now, some chairs may be empty because a lot of people feel that inauguration is something which is beyond academics. Still, we still have a right, if we can count, around 70, 80 odd people inside the hall. And since morning, we had around 250 odd people. So that was very, very gratifying. It shows that how vibrant this chapter is, both at the national level and at the state level. And we've been able to do certain things which probably other chapters may not be doing, but still, it's really gratifying to see all this. We are really grateful to people like Dr. Chug, Dr. Indu, Dr. Chetan, who've come from out of the state, apart from the people on the dais like Dr. Rawat and Dr. Kabra, who have been sources where we got lots to learn. So with these few words, I'd like to thank everybody who's come over here, and particularly the delegates who've been filling these chairs since the morning. Thank you so much.
Thank you, sir. I now request Chairperson, IAP Respiratory Chapter, Dr. S.S. Rawat, to kindly say a few words.
Thank you very much. I think this yearly congregation or gathering of pediatricians for this West Bengal PULMOCON, this is a very good tradition which the West Bengal Academy of Pediatrics and the IAP Respiratory Chapter of West Bengal have started. I think and the gathering which you have right since the inception, the scientific program, the faculty lineup, I think it is really great, and you try to compress a lot of science in a very short time. I think this is very good both for delegates as well as for the faculties. So I think my suggestion, just keep this tradition up. Try to give good science and good learning to delegates who really come for learning pediatric pulmonology. As you all know, IPNRC is very passionate about teaching. We have got a lot of modules, lot of courses going on. You all must have experienced, and quite a lot of you must have attended them. So I think doing a correct, good CME in a compact manner with a good science, I think you are known for that. And my best wishes. My thanks to the organizers, Dr. Pallab, Dr. Subhashish, Dr. Arun Manglik. They are doing a great job, and my best wishes. But again, my request is that please make a second line, because you all are doing this for so many years. But I don't see a second line of people who will take the mantle from you all. So my request is that please prepare a second line who take this tradition forward and do it in a more better way than what we are doing. Thank you very much. Best of luck.
Thank you, sir. I now request our chief guest, Dr. S.K. Kabra, who has graced us with his kind presence since the last, I think, 1.5 decades. So no PULMOCON has been complete without his advice and his knowledge. Sir.
So office bearers and friends, it gives me a great pleasure to say that I have seen so many Respicons for last few decades, and its content, its improvement, and now as it was pointed out, that people are here from the morning 9 o'clock, and they are very interactive, enthusiastic, and that's why the credit goes to both, including the organizers who have made it very vibrant, contents as well as their campaign, but more credit goes to the participants from Kolkata and West Bengal, because they want, I have seen that they want to learn more and more about it. Rarest of rare cases are being seen and discussed, and even I am getting some of the referrals from them, and that's why I run a OPD in these while attending the conference. Best wishes for the program and for the respiratory chapter of West Bengal, and as I said, now I feel I am part of the respiratory chapter of West Bengal. Thank you very much.
Thank you, sir, for your kind words. I'd now request Dr. Shopon Rai, who's the president of the West Bengal Academy of Pediatrics, to kindly say a few words.
Very good afternoon to everybody. It is really very satisfying seeing from the first session the hall is almost full. And the credit goes to the delegates and the organizer, Subhashish, Pallav and Arun Manglik sir. So West Bengal Academy of Pediatrics is always supportive on all the branches, even the respiratory chapter branch, whom I am also a member of it. What Dr. Rawat sir has told, make the second generation ready. So sir, I am following your thing. I have been entrusted with the responsibility of the presidency of West Bengal Academy of Pediatrics. This year on 2nd November, there will be West Bengal 42 Pedicon, and the theme of this conference will be Yuva Empowered. All the panelists, lecturers, speakers, except 2 orations, will be the young generation of the second order. So thank you very much for enjoying. I think there will be a very good learning, and hope you will get the certificate at the end. Thank you very much.
So we will now proceed for the lighting of the lamp.
Ah
So we'll now close the inauguration with the vote of thanks by the organizing secretary, Dr. Pallav Chatterjee.
Thank you very much. As we come to the close of the inauguration of PULMOCON 2025, it's my great honor and privilege to deliver the vote of thanks on behalf of the organizing committee of the West Bengal chapter of pediatric pulmonology. As has been already said, that I express our heartfelt gratitude to the speakers, the faculty who have come from long distances. They agreed on just one phone call. And thank you very much, Dr. Kabra, Dr. Chuk, Dr. Rawat, Dr. Chetan, Dr. Indu, just a phone call and they said yes without thinking. We extend our warm appreciation to all the delegates right from word go, even before the breakfast was served, the halls were full. Your active participation, your curiosity, your engagement has been the soul of this conferences and all our previous conferences, and we expect this to happen in the future also. A big thank you to all our sponsors. Your generous support has been instrumental in making this conference a success. And a word of gratitude to the hotel management and the staff of Taj Bengal. This is one of the first times we are holding a conference at Taj, and we are very, very grateful to the management. Last night we were thinking of some problems with the breakfast and all. I called them up after 12 and just 2 calls they picked up my phone and they arranged the breakfast and everything. So thank you very much. Your dedication, your efficacy, efficiency is great, particularly to the volunteers, the technical team, Rohit, Shomnadda, and your unseen hand that worked behind the scenes. Thank you for your help. Your contribution may often go unspoken, but it certainly won't go unnoticed. So thank you very much, and with this we will continue with our next session. Thank you.
Next session, which is changing landscape of the RSV prevention with nirsevimab for all infants. It will be delivered by none other than Dr. Pallav Chatterjee. For this, the chairpersons will be Dr. Bidhan Bhuiya and Dr. Abhijit Dotto.
I am extremely grateful to the organizing faculty members of this grand occasion, and especially to Dr. Pallab Chatterjee, whose by compelling love I have come here. And now your topic, he needs no introduction because he is a stalwart in pediatric pulmonology. And his topic of discussion today is changing landscape of RSV prevention with nirsevimab for all children, all infants.
Thank you, Bidhanda. You all might be knowing or might not be knowing that I learned majority of my pediatrics from Dr. Bidhan Bhuiya. He was our postgraduate trainee when I was there in medical college. So, and it feels great when you say that I am one of the stalwarts, who I am not. So anyway, so this is a sponsored session, and I've been on the advisory board of most of the companies, but this is something different. This is not a vaccine. So just an overview. I'm not going to tell you a lot about RSV. We all know about it. It's a common and contagious seasonal viral disease, and the problem is it is extremely contagious. So the R naught is around 4.5, means one person infected can infect around 4.5. And you can see the range, it is up to 8.2. So one person can infect up to 8 children. So that is how contagious RSV is. And it's huge. It can be a mild disease, it can be a severe disease, it can cause just a sneeze, a cough, it can go up to apneas, to hypoxias, and severe respiratory diseases. And once hospitalized, the kids can become quite sick. Now, if you look at the burden among infants, it's quite a lot, and there can be documented deaths due to RSV infection. So it is one of the commonest cause and one of the frequent causes of acute respiratory infections, and it's nearly 70% of infants are affected with RSV in the first year of life. So if you see most of the children by the second year of life, they will be affected by RSV infection. So most hospitalizations occur in RSV, and the worrying part is it's not in preterms, it's not in sick children, it's the healthy infants who get infected with RSV. So it's one of the top 5 primary diagnoses of hospitalized children less than 1 year of age. And if you see the mortality, the hospitalization, we are more worried about influenza, but you look at RSV, it's also very, very important, and it's probably more important than influenza. It's a leading cause of mortality, as we said, and it occurs in healthy, full-term infants. That is the problem. So children who are full-term, who are healthy, they are the kids who might be suffering from RSV infections. So that is what we need to remember, and around a lot of them, around 50% of them might need ventilation also. So it is very unpredictable. 1 in 5 will need outpatient treatment, and 1 in 50 might need to be hospitalized. And as I said, that all children less than 2 years of age will probably have RSV infection. So even in our part of the world, in South Asia, it's very, very common. So RSV it's the commonest infection that we see in our part of the country, our part of the world. So the burden, as we said, about the RSV viruses, this is a study by the Institute of Molecular Biology, ICMR, and what they said that in India, it's more or less as what we see in the global part. So both places, it's around 26%, 29%, and in all the parts of our country, so it's nearly the same. It's one of the commonest causes of respiratory infections in all the 4 regions in our country. So again, these studies were done which showed that the mortality and morbidity is very high. This is again a study by Vamshi Venkat, and it also showed that children who are term babies, more than 37 weeks, and good weight, they all have more chances of getting RSV infection. It is seasonal, and it depends on the southern hemisphere where it is around March to September. In the northern, it's between September to January, and thus it varies throughout the world. But in the tropical and the subtropical climates, it's usually throughout the year that we see RSV infections. And particularly in our country, if you look at our country, so Western India, they show around the monsoon, August, September, and again a smaller peak in November and Jan. North India is November to Feb. In Eastern India, it's around June to September, and in Southern India, again, it's very similar to what happens in flu. So it's got an ill-defined seasonal predisposition in the tropical regions. So RSV, people were initially, it was grown from the chimpanzees. It was thought to be a chimpanzee coryza agent, and gradually, like, they understood that it was from the, it is also one of the common causes of viral infection in humans, infants, and this led to the development of palivizumab in 1998. That was there for a long time, and now we have a new approved option, that is nirsevimab. So what is nirsevimab? It is a fully human high potency IgG1 monoclonal antibody derived from human B cells. So it is not a vaccine, it is a monoclonal antibody. Hence, it can be given with any vaccine that we use. It's got an extended half-life using the YTE technology. What it basically means is they have changed the FC portion of this monoclonal antibody, the IgG1, to make it more, the affinity, increase the affinity, and to reduce the lysosomal damage and autophagy of this antibody. So therefore, it gets back into the circulation. So that is why it's got an extended half-life. So one dose suffices. We know palivizumab, we give like one dose and it lasts for a month. We have to give 5 doses to cover up for 5 months. Here you give 1 dose to cover up for the 5 months. So that is the benefit over the previous monoclonal antibody that we had. And it comes in pre-filled syringes, small thin syringes, and it's like, the dose is weight based. So if it is less than 5 kg, you give 50 milligrams. So it comes as the 50 milligram. You give the full thing. If it is above 5 kg, you get the 100 milligram. You give the full thing. The price of both same. So that is important, that you decide on how much to give depending on the weight of the child. Various studies were done. And there was this, the studies on healthy infants were done. So the Melody study, the pivotal study, and then there was a study that was done on preterm infants. So all of these studies, so what they did was they either gave 1 dose of nirsevimab followed by 4 doses of placebo, or they gave 5 doses of palivizumab and they compared. So this was what they had done in the preterm babies. In the term babies, palivizumab is anyways not indicated, so they had given only nirsevimab compared with placebo, and there was the safety and tolerability was very good. The efficacy was excellent, so it was to the tune of around 75 to 80%, and there was a good prevention of hospitalization. So if you compare the two, the anti-RSV antibodies compared with palivizumab throughout the RSV season remained higher with nirsevimab because it had a longer half-life and the protection was quite good. So even with 1 dose, the antibody levels persisted longer and higher compared to the previous monoclonal antibody that we had. And this was the Harmony study that they had this healthy newborns who born more than 29 weeks. So that is the indication where you cannot use palivizumab, but you can give it to. So as we saw, this is an infection which occurs mainly in healthy term infants. So here you can use nirsevimab, and the same intramuscular dose as was planned was given, and what it showed that there was a definite reduction in the RSV related lower respiratory tract infections, reduction in very severe RSV related lower respiratory infections, and also in all cause LRTIs in these infants. So this is the summary slide of all the studies that we said, and all of them show that there is a definite benefit of using monoclonal antibodies in these children. So What about the safety profile? Adverse events, any adverse events, actually those of us who have used, we can say that there are no adverse events, maybe a slight little bit of pain after giving this injection, but nothing much happens with this, even if you give in preterms or in terms. So it has been designed for all infants for protection, and the dose, as we said, is less than 5 kgs is 50, more than 5 kgs is 100, and if you are planning to give it in the season 2, then it's a standard dose of 200. So there you have to use 2 of those. So in healthy preterms and full-term infants also we had a good study and good protection in children with chronic congenital heart disease, chronic lung disease or prematurity. Again, it had shown a very good safety and efficacy. So what about the taste of the pudding? After eating it, this is the real life scenarios. Regulatory approval in 56 countries. Medical scientific societies have recommended in 24 countries. It's been recommended by the national government in 25 countries, and there has been some preferential recommendation in 10 countries. And it has shown that the real world impact on RSV related outcomes with nirsevimab has been very good throughout the globe in all the parts where it's been used. And particularly of mention is Chile, where they had immunized a big cohort of children with nirsevimab compared to some who were not immunized. And what they had seen was there was a reduction in RSV related ICU admissions to the tune of around 85%, RSV related LRTA hospitalization to the tune of around 76%. All-cause LRTA hospitalizations were down by 64%, and all-cause hospitalizations were down by around 48%. And there were around 13 deaths in 2023 related to RSV. In 2024, there was none. So that is a very, very eye-opening data that we have from Chile after they started using nirsevimab in their children. So to summarize, over 6 million infants have been already immunized with nirsevimab worldwide. A large body of real-world evidence is available demonstrating efficacy against RSV-related hospitalization, ICU admissions, and LRTA incidents. There have been more than 40 studies on the uptake, effectiveness, and the public health impact of RSV prevention with nirsevimab. And countries with nirsevimab, around 8 countries have shown a good real-world evidence data spanning around 4 continents and both northern and southern hemispheres. More than 2.5 lakh infants have received nirsevimab, and it definitely supports the effectiveness and has shown that the side effects are much, much less. So we know that it is a leading cause of hospitalization. We know that not only preterms, not only sick infants, but all healthy infants also need protection from RSV. And nirsevimab is one of the modalities that we have that we can protect against RSV to all infants. So that will be all. Thank you very much. Any questions we can take? Yes, because the weight is more, no? Yes. 40,000. The price is 40,000. But when you compare with palivizumab is 1 lakh. So that way it is less. So it is to be like decided and given on a one-to-one basis, definitely. Yeah, basically you schedule it according to the RSV season. So you know where you are practicing and your RSV season. So it should be given before the onset of the RSV season. So it will cover for 5 months. But there is data which shows that it covers for more than around 13 months. So probably 1 dose should suffice for a year. So that is what it is.
What is the higher
Second year, usually you will need it only for sick infants or some. But first year, if they are willing, kids are coming to a rich hospital like SIRS, so might be offered to all children. No issues.
that season, or we should can give given in
It is-
January itself?
It is better to give before the season. So supposing if you see the RSV season in your area, usually it's around around July, then it's better to give in May, so it will cover for the 5 months.
Thank you for a good presentation, Pallab. Mike, so we don't have long-term data on this. So the only thing is there will be some herd immunity even if somebody takes a vaccine. Natural infections will still occur. It's not that it's going to eradicate and other people will have RSV because everybody is not going to take the vaccine. I hope we're not pushing RSV to a later age and getting problems later. You never know with viruses. Chickenpox, adult chickenpox is worse. I don't know what will happen to RSV. So that's something which
Yes, that
does
is something
bother
that
us.
we have to think. But usually, what we have seen in our practice is RSV. We have detected RSV in quite older children also with cold and cough and all that. Usually, they don't get sick. So beyond 2 years of age, RSV is usually is a mild disease.
एक तो वैक्सीन के बारे में तो कुछ बताइए RSV वैक्सीन.
This is not a vaccine. This is a monoclonal antibody. So
just one case, one of my batchmate who is suffering from some heart disease, this year suffered from a severe, in the month of May, suffered from severe breathlessness, admitted in hospital, and the biofire detected RSV. So RSV in adults may be very lethal and very serious. Not always it is mild.
So thank you, Dr.
Thank you very much.
Chatterjee,
Thank you.
Thank you so much, Pallab.
for enlightening us on RSV. And now for the next session, we'd like to invite Dr. Joydeep Chaudhary, who will now enlighten us on the Streptococcus pneumoniae prevention.
Now I invite Professor Joydeep Chaudhary, the renowned professor, great IAPian, very much energetic, and he will talk about the mythbusters decoding PCV realities in Indian healthcare. Dr. Chaudhary.
So good afternoon everybody, from one virus to a bacteria. Now streptopneumonia, as we have been discussing over the years, and the prevention with pneumococcal conjugate vaccine is nothing new. But still it is surrounded with so much myth regarding the serotype, the conjugate protein, and the spectrum and studies. So whenever we talk about pneumococcus, we know there are 100 serotypes. Starting with coverage of 7 serotypes, we have moved to 10, 13, 14, 15, 20, and now we are looking beyond with conjugate vaccine. Some trials on 24 are also on. Serotypes are critical in pneumococcal disease, and fortunately not all the 100 serotypes are pathogenic to human. Most importantly, why people are adding and selecting serotypes and discarding some serotypes, adding new? Because one serotype will not protect the other adequately. So this is a myth. Otherwise, we would have stuck to PCV7 only, but it's not. So it is a serotype specific. Now, right from the PCV7, when it was developed, it was targeted to protect against the most common serotypes, but subsequently it was found that yes, there are other serotypes also which needed to be protected. The 13 serotypes that are included in the PCV13 are based on few rationality, because what we are concerned about pneumococcus are the invasive pneumococcal disease, pneumonia, otitis media, mortality, and antimicrobial resistance. Invasive pneumococcal disease is not synonymous with pneumonia, because most of the pneumonia are non-invasive in nature. Many serotypes are responsible for invasive pneumococcal disease. As we can see, some are responsible for pneumonia, otitis media, Some serotypes are associated with increased mortality, like 6B, 19F, 3, 6A, 19A, and many are associated with antimicrobial resistance. So these are the basis for selecting certain serotypes. If we see the current PCV landscape in India, and that's the moot point of discussion today, there are so many PCVs. Now, we have the age-old player, the PCV13 with CRM197 as conjugate protein. Then we have the old PCV10 GSK, the new PCV10 of Serum Institute, PCV14, and then the new entrant in the block is the new PCV13 with TT as conjugate. And each has selected few of the serotypes and discarded few. So the discussion rests on serotype 3, which is not present in the PCV10, serotype 4 not present in one PCV10, then serotype 6A missing from old PCV10 and 14, and then 18C, 19A and others, and PCV14 has included 22F and 33F. So why this jigsaw puzzle and why we are puzzled? That's the question of today. So this is the gist that I have already told about the composition. Now there are some prevailing myths that confuses us. So what is the myth? That serotype 6B provides adequate cross protection against serotype 6A, and cross protection is equal to direct protection. And it can never be. A virtual mode is never same as than face-to-face mode. So it can never be. Cross protection can never. Because as we know that the serotype 6A, as per various studies, if we collate the various studies, it causes 17% of invasive disease. So we just cannot risk 17% of the candidates receiving the vaccine with some compromise with serotype 6B. And this has been recognized in the last book that we had, the Purple Book of ACVIP. Is it wise to choose a PCV that does not provide protection against serotype 6A? Because serotype 6A is not only associated with invasive disease, but also necrotizing pneumonia, serious mortality, and also drug resistance. And if we see the vaccine effectiveness, now this is the PCV containing the serotype 6A, we can see it is 92%. That is the direct protection offers direct coverage offers protection about 92%. You see the cross protection is about 31% only, or here it is less than 10%. So here is the explanation why direct protection is always what we should go for. And direct protection provides higher immunogenicity versus cross protection. As we can see, this is without booster, and with booster also you can see a 10-fold rise. And if we see the comparison with the PCV10 and PCV13 pre-primary, then after 1 month after the primary, and this is the post-booster, you can see it's a 10-fold difference. So that is why it has been clearly mentioned that direct protection against serotype 6A is superior. Now serotype 22F and 33F has been included in one of the PCVs of late, and there is much hue and cry about 22F and 33F. Now if we go back the existing evidence, these are the various studies about the prevailing serotypes in India, though these are dated, but still that's what we have, because there is hardly any ongoing studies about the serotype map of PCVs, pneumococcus in India. So if we collate all these studies, we see serotype 22F and 33F is 0.8 and 0.6%. So are we justified in adding these serotypes at the expense of other serotypes which are more prevalent. And this is the estimated coverage of pneumococcal conjugate vaccine. These are the various studies which has reflected the serotype map in India, and you can see here this dark blue is the PCV13, and then the other, you can see the difference in the bars that we have. That shows the coverage and dispels the myth, and this is the same one. There are a lot of talks about all PCV13s are same. Well, we have to wait for that. You see, number one, PCV13, the Pfizer PCV13, but the other PCV13s, if you see the approved indication as per the product insert labels that we have, you see PCV13, it is mentioned that it is effective against, it covers against IPD, pneumonia, otitis media, nasopharyngeal carriage, and approved for all age group. And if we see the new PCV13, as per the Chinese level, it's only for IPD, and as per the Indian level, it's not that. So it can never be same. Just think like that. If you are asked that name one iconic cricketer of India, you will never say Karun Nair, because though he scored a triple century early in his career, but he has to walk a few miles, prove his worth in different pitches, like to become a Gavaskar or Tendulkar. So it will take time. Now, here if you see the indications also in the product insert, in the label, if you see, the PCV13 CRM conjugate, it is licensed from 6 weeks up to the adult age, that is beyond 18 as per our purview, but you know that even in the older age group it can be taken. All the other PCVs have limitation, and PCV13, the TT conjugate, is only up to licensed up to 1 year. Still, you cannot use it as a booster dose in the second year of life. Next comes the conjugation. This old PCV13 is conjugated with CRM 197 and the new is TT. So what's that? Should we be at all bothered about the conjugation? See, this conjugation means there is a sugar moiety and a protein moiety. The sugar moiety attaches to the B cell, then it activates the T cell to form the major histocompatibility complex, and there is an epitope and anchor which is facilitated by the protein component. So this is the whole immunologic mechanism. Now, if we see the PCV13, which is a CRM conjugate, here as the conjugate is CRM, so it does not compete at the site of the epitope attachment at this site. But a TT conjugate, because we are co-administering it with other tetanus containing vaccines, so there is a competition at the epitope level for attachment. So there lies the crux of the mechanism of attachment of this protein to form the major histocompatibility complex, because there are many other vaccines that we are giving which contains TT, but CRM is not there with the other co-administered vaccine. This is the basis of understanding the carrier-induced epitope suppression. Thus, this epitope is suppressed by the similar carrier. Now, this is the co-administration of the PCV13 with CRM conjugate. As we have, the key finding was there. The antibody response was same when it was co-administered with the DTAP vaccines, and this is the non-inferiority has been compared also as per this study. And if we see the OPA analysis, because we know the opsonophagocytic antigen, that's the proof for the effectiveness of the vaccine, we see this is the GMT percentage only for serotype 14, the new PCV13 TT conjugate matches with the older PCV13. All other, you see the orange bars are much inferior. If you take 100 as the PCV13 CRM conjugate, you can see the TT conjugate, all the serotypes GMT are much lower. And of course, as you know, that PCV13 CRM conjugate is licensed for 3+1 booster, whereas the TT conjugate is still licensed only for the primary 3 doses. And over the last 2 years, we haven't come across the booster data that we are still waiting for. WHO pre-qualification is a process when a vaccine can be acquired by other countries for their national immunization program, and the CRM conjugate is WHO pre-qualified. Then we come to the nasopharyngeal carriage, antimicrobial resistance, and real-world evidence. There is, of course, data which shows that the CRM conjugate has significant reduction in nasopharyngeal carriage. Also, it is effective for antimicrobial resistance, and there are real-world evidence data also. Serotype 3, the controversy and the myth is existing since the beginning. But again, we know that though, yes, serotype 3 is the naughty child in the class, but we just cannot leave that child out, expecting that the child will correct himself on his own. We have to include that. So whatever the performance of the child, serotype 3, if it's included, efficacy is around 51%, but if it's not included, then the efficacy will be 0. So serotype 3, though an atypical, but it should be included. 4 and 18C, the myth is that are clinically non-significant and non-important. Now, since PCV7, if we see, here you see the 4 and 18C. Now, 4 and 18C are known among the outbreak serotypes. So it has been there since PCV7. And both are highly invasive and frequently found in carriage surveys. So 4 and 18C, you just cannot ignore, and it has been there. PCV, should it be for invasive pneumococcal disease only? Well, pneumococcus is transmitted invasive way to cause septicemia and meningitis, but most of the pneumonia are non-invasive by mucosal spread. So if we prevent only invasive disease, then we are not preventing otitis media or pneumonia adequately. So PCV is not only for invasive disease. See, the invasive disease is just at the tip of the pyramid. The base are otitis media and pneumonia, which are mucosal disease.
Jayadipda, your time.
Though the incidence is less, more of the mucosal disease, so mucosal disease has to be prevented also. And if we see the comparison, you can see the coverage of invasive pneumococcal disease is uniform, but for the other, there is definitely compromise. And nasopharyngeal carriage, definitely it precedes invasive disease. It's a cause of major reservoir and requires higher level of antibodies. The invasive disease requires a lower level, but for the mucosal secretion of the antibodies must be higher for adequate protection. And catch-up vaccination, and for older, we know the recommendation, it is licensed till the adult age group. So I think we have dispelled the myth surrounded with the PCV and the current PCV controversy. Well, 6A we have discussed, 22F and 33F we have discussed, serotype 3, yes, it is an important serotype, 4 and 18C are outbreak serotypes, so we just cannot miss them. And pediatric pneumococcal infections vary in severity, and the CRM conjugate protects against both invasive and non-invasive, as we have found. So whenever you choose PCV, choose wisely. Thank you.
Thank
Thank you so much, Professor
thank you for the
Jaydeep
wonderful
Chaudhary,
talk.
for your lucid presentation.
We will leave it for the next Respicon, PULMOCON. So managing chronic otitis media and allergic rhinitis. So this is going to be dealt with by Dr. Shantanu Bhakta, sir.
Now I invite Dr. Santanu Bhakta. His topic is managing chronic otitis media in allergic rhinitis. He is also an energetic IEPN. Thank you.
Thank you, Chairperson, and my colleagues and seniors. Last in queue in this sponsored lecture session is myself standing between you and the lunch. My topic is managing chronic otitis media in allergic rhinitis. So this is a disease. First came virus, then bacteria. Now we are dealing with a disease. Now, why I chose this, why this topic has been chosen, because there is IgE-mediated allergy is linked in 33% cases of chronic otitis media. Now, one thing I should tell you, that chronic otitis media, acute otitis media, and otitis media with effusion is being taken as a unit here and is discussed in a broader aspect, taking children, adolescents, and adults. According to the guidelines of diagnosing respiratory allergy, common allergic diseases are asthma and allergic rhinitis, you all know. Estimated prevalence of the allergic rhinitis is 10 to 30% in general population worldwide, while 20 to 30% in Indian population. And responsible aeroallergens are, from the morning session you all know, it's the pollens, fungal spores, house dust mite, animal antigens, and insect allergens. Now the allergic diseases has got significant impact on quality of life, social life, and economy. Only the history and clinical examination are the primary modalities to diagnose an allergic disease and its causative agents, allergens. And this is being confirmed by demonstrating the antigen-specific IgE in vivo or in vitro. With this background knowledge, we go to the next slide. As I told you, the otitis media is commonly associated with allergic rhinitis due to eustachian tube dysfunction, leading to conditions like OME or AME. Okay. So how it comes? Inhalant allergens cause nasopharyngeal edema leading to eustachian tube dysfunction and serous fluid accumulation, allergic inflammation of the middle layer mucosa, and in long-standing cases, chronic allergies can scar or perforate tympanic membranes, ultimately causing atopic dermatitis, and itching can cause recurrent otitis externa. Now, this association between the allergic rhinitis and otitis media with effusion in Indian population is not well studied. In this study, they have tried to show the nasal smear cytology has got any role on the allergic rhinitis symptomatology or not. It is a single center observational study in 2021 which evaluated mid-layer pathologies in 126 allergic rhinitis patients under 18 years. The findings were 49.2% had mid-layer pathology, that is 62 patients. Among the pathologies, common pathology were ET tube dysfunction, ET tube dysfunction in the last there, and then chronic otitis media with effusion, and acute otitis media. They did the absolute eosinophil count and found that 392.42 was the mean absolute eosinophil count in AR patient. Around 32 patients were having this Around 32 patients were having this high absolute eosinophil count. Of those, 31.25%, that is around 10 patients had blood eosinophilia, Among those 10 patients, about 7 were having a middle ear pathology. So the conclusion is allergic rhinitis triggers ET tube dysfunction leading to middle ear pathologies. These are the types of otitis media. As I told you, acute otitis media with effusion and chronic otitis media. The challenge is where it's difficult to treat chronic otitis media may impact hearing loss. Causes are develops from acute middle ear infection, ear injuries or eustachian tube blockage. Risk factors are smoking, second-hand smoke, seasonal or year-round allergies, and regular exposure to air pollution. Symptoms are flare-ups from respiratory tract infection or water entering the ear, pus like ear drainage, sore throat, poor or muffled hearing, trouble in sleeping, and sometimes fever. This impact of bilateral CSOM on quality of life is huge, especially in case of bilateral CSOM. The anxiety and depression is much higher than unilateral CSOM. So this is the preliminary investigations and diagnosis according to the ENT parameters, but you should not forget to ask the immune deficiency or the history of recurrent infections pointing towards immune deficiency in case of chronic otitis media. These are the other diagnostic assessment, not to forget the simple otoscopy. There are many according to the ENT parameters, but simple otoscopy that we can do where the accuracy is 60 to 70%, and the bulging of the tympanic membrane is highly predictive of acute otitis media. Now, this is a real-life management of rhinitis. International survey on the management of allergic rhinitis was done around 11 countries with 2,776 patients over 6 years of age with rhinitis diagnosed over a year, where the median age was 29 years, male-female equality. Common comorbidities were sinusitis, conjunctivitis, otitis media, and nasal polyposis. Two things were very constant and very encouraging. One is 93.4% received a recommendation to avoid allergens, though now in GINA they say particularly allergen avoidance is not necessary, but still. And the second one is 91.4% of patients were primarily on treatment, some amount of treatment, either oral antihistamines or intranasal corticosteroids. Some treatment were being given in those patients primarily. Now, this is the comprehensive management of otitis media. From the morning session, you have all learned. First line is amoxicillin, recurrence cases or resistant pathogens, amoxiclav, penicillin resistant. And after starting the antibiotic, the important thing is you re-examine 3 to 4 weeks later to find out whether the resolution of effusion or inflammation has been done. Early re-examination needed if symptom persists to ensure appropriate antibiotic use. The dose may be increased. And in case where allergic rhinitis is associated, you have to treat with antihistamines and intranasal corticosteroids wherever is necessary. Now, this is a fluticasone treatment. Pediatric patient caregivers often ask for medical management of eustachian tube dysfunction, though tympanostomy is the primary management. There, in this case, in the study, they have assessed the intranasal fluticasone efficacy in preventing tympanostomy tube placement in children with ETD, including differences in response to cleft lip palate and Down syndrome. There, 676 pediatric ETD patients were treated with INF in central USA. It is a retrospective case series at a tertiary hospital in USA, where he found that tympanostomy tube placement has got, with INF, there is a delay or avoid tympanostomy tube placement by giving intranasal fluticasone in pediatric patients. Safety profile of fluticasone for otitis media with effusion in children. This is a comparative interventional study on 70 children. They were treated for 12 weeks with two groups. One is fluticasone group, one is nasal saline drops. They have shown that with fluticasone group, the percentage improvement in hearing loss is much more than normal saline group. So the conclusion is fluticasone nasal spray is both effective and safe for treating OME. Now the efficacy of agilestin and fluticasone for ETD in children. We know that adenoidal hypertrophy is one of the cause for eustachian tube dysfunction. In those cases, they have given a combination of Agiflu for 3 months intranasal, and they found that Agiflu effectively regresses the adenoid tissue and improves the eustachian tube function, making it a suitable initial therapy for adenoidal hypertrophy and eustachian tube dysfunction in children. The effectiveness of LTRA with antibiotics in short-term OME resolution. The aim was to assess the effect of combining montelukast and levocetirizine on reducing the duration of mid-ilear effusion in children with OME. They have made 4 groups, only montelukast, only levocetirizine, a combination and a placebo, and the conclusion were treatment with montelukast combined with levocetirizine may effectively improve clinical outcomes for mid-ilear fluid in children with OME. Now this is antihistamines and decongestants. The role of antihistamines, you know, second generation H1 antihistamines may help reduce this inflammation, and the decongestant reduces mucous membrane swelling via adrenergic receptor mediated vasoconstriction. Now, drugs with antihistamine action is one of the most prescribed drugs in children. According to international medical statistics, in 2006 in Spain, there are 2 million units of antihistamine in liquid, in bottles, were sold at a cost of around 6 million euros. Among these, 34% pertain to the first generation antihistamines, which has got no study for its safety and efficacy in pediatric age group. So we go for the second generation antihistamines, which relieve from all air symptoms, including nasal congestion, though I doubt this with this comment, but might be better for treating otitis media. It is a non-sedative drug, well documented, tolerance for long-term use, both pediatric and in adult, no reported cardiotoxicity and anticholinergic activity, no impact on cognitive and academic performance. If we go for montelukast with its anti-leukotriene effect, it may benefit otitis media with effusion and recurrent acute otitis media patient. So the key takeaway is that air with IgE allergy worsen respiratory and ear condition, with IgE allergy linked to 33% of recurrent OME cases, emphasizing the need for timely diagnosis and management. Fluticasone is both safe and effective for treating OME. Intranasal fluticasone in pediatric otolaryngology delays or avoids tympanostomy tube placement. Agiflu effectively reduces adenoid tissue and improves ET function, making it a suitable initial therapy for adenoidal hypertrophy and eustachian tube dysfunction in children. Non-sedating second generation H1 antihistamines reduce otitis media inflammation, while addition of LTRA target leukotrienes to relieve air symptoms. And last but not the least, allergic rhinitis is an important comorbid condition in chronic otitis media and should be looked for. Thank you very much.
Thank you, Shantanuda, for your lucid presentation, and thank you all the members of this August gathering.
Three
350, it was 350. Thank you, Shantanuda and Dr. Bhuya. And I would request all the speakers of this session, Dr. Joydeep probably is not there, to visit the Memento Center for the memento. And now let's disperse for the lunch. And we'll gather again exactly after 30 minutes for the post-lunch session. Thank you.
I would request Dr. Shati Chakravarti and Dr. Shantanu Bhakto to please come on the dais. And this is on recent updates in GINA 2025. And none other than our chairperson, Dr. Arun Manglik, is going to talk on recent updates in GINA 2025.
Good afternoon, and thanks to the PULMOCON team for giving me this chance to chair this session. And the topic is, as already as told, and the speaker is Dr. Manglik, but I just want to say a few words about Dr. Manglik, other than the CV showing his achievements, his accolades, and his portfolios he is holding. But he is an erudite teacher, a good organizer, and a thinker, a visionary. And the most surprising thing that he just moves with equal ease from neonatology to pulmonology to PICU matters to the quiz master and ultimately to the medical legal issues. Over to Dr. Manglik.
Thank you, ma'am, for those kind words. And I must say, it is all with the blessings of people like you, some seniors like you, and another senior sitting and holding his phone, Bhupida. There are others who are not here. They have all blessed me, and not only them, I must not forget to mention Atul, who's my batchmate, but he's taught me a lot, and Gautam also. I think he's not here right now. Now we'll come to the topic, recent updates in GINA guidelines or GINA 2025. As we all know, GINA tends to periodically update its recommendations, and this is, I think, done every year, and sometimes in May it comes up. And we have several areas of interest, and thankfully this year GINA has made it fairly comfortable for us practitioners. The areas of diagnosis of asthma in under 5s, in adolescents and adults, and above 5 years, the newer aspect is the role of biomarkers which has come up, phenotypes. We have also had certain additions on allergens which I will not touch up because Dr. Rawat had given a detailed discussion on it in the morning. So we'll come to exactly, this is how it looks like. If you go to GINA, this is how it looks like. It's almost in sort of microphone, but you can always increase it or zoom it so that you can get a glimpse of what is actually going on. So we'll come to the topic wheezing under 5, because this is one area where it's very difficult for us to diagnose whether it's asthma or not, and the parents have this big question, particularly if they have a child or an adult who's got asthma in the family and is suffering and is using inhalers and blah blah blah. They come with the question that, is this my child having asthma or not? So we'll come to a little bit of a child, a patient. 2-year-old Digant has come with recurrent wheeze, has had 4 episodes in the last 8 months, each episode lasting for about, preceded by fever, running nose, followed by cough and all that. There are no internal symptoms, no activity limitation or any weight loss. The parents refused MDIs, so had to be given oral medications, given oral steroids also at one point of time. Father has got allergic rhinitis, mama has asthma in childhood. So anybody from the audience, how many would say this will be asthma or not? Honestly, we don't know. Okay, we can't predict. Okay, so now we have another child, and we'll come to these certain issues later on also again. Pinaki, has had 3 episodes of cough in the last 6 months. Each time it subsided with cough medications, and this time the episode is persisting for about a month. Afebrile, there's a lot of wheeze, no activity limitation or weight loss. Cough responds a bit to short-acting beta agonists, so SABA, as they say, chest X is normal. Child received antibiotics and SABA and some relief. The previous pediatrician has written asthma. They have come to any of us and they want a clarification whether this child has got asthma or not. We still don't know the answer because we are still in the previous guidelines. I'll come to the new ones which have made things easier for us. Now another child, Jayant, who has had 3 episodes of acute wheeze, plays football and coughs while playing. Okay? Cough responds to 2 or 3 puffs of SABA within a short period of time. No family history, no atopic markers, no alternative diagnosis, no atopia. So is it asthma? We had this previous guideline which had in, if you remember, this one. This would suggest that this child, some of these or rather many of these would have asthma later on with this sort of a finding. Okay, so the parents we come up with a lot of these nomenclatures. Preschool wheeze, transient wheeze, persistent wheeze, and all blah 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 and all those. But the parent just wants to know the answer to this question. Is my child suffering from asthma? Okay, and thankfully Gina has made it easier for us. What was the previous thing which was till last year? We had this, because wheezing can interchange. We can have one group, very few would have asthma, like symptoms of cough, wheeze, breathlessness lasting for less than 10 days, about less than 2-3 episodes a year and no symptoms in between. On the other extreme we could have, which we just talked about in the previous patient, cough, wheeze lasting for 10 days each time, more than 3 episodes per year, severe episodes or night worsening, and between episodes the child is not happy. Child has got interval symptoms, and addition to that, if there is atopic dermatitis, allergic sensitization, etc., it suggested most have asthma. But there was not a clear-cut answer. Could you tell them, is your child asthmatic or going to get asthma with some degree of surety? Well, yes, you could, but not fully. So, did this classification really help me? Imagine this. We are talking of prediction tools. GINA 2025 has come up that there were 3 prediction tools which had been externally validated. They were Asthma Prediction Index by Tucson, which many of us have quoted, PIAMA from Netherlands, and Leicester from UK. All 3 showed poor predictive accuracy in clinical work. So practically all of them have been now thrown out of the window. Probability, we talked about probabilities. Nah? That's a statistician's job. We can't talk about probabilities because a parent wants to know a clear-cut thing. Yes, sometimes if they are educated, you talk to them, they may be able to understand, but what they want is clear-cut answers. And imagine this is from GINA itself, about 60% of preschool wheezes is absolutely free of wheeze at 6 years. About 15% of persistent wheezes at 9 years would still be not have asthma in adulthood. So this is what the data tells us. What is what the evidence is? So the probability-based diagnosis is okay, but the parents are not happy. They want clear-cut answers. They don't want statistics. They don't want percentages. My child has got this or not. Unfortunately, medicine is not such a clear-cut box. It's not a watertight compartment where I could clarify with 100% surety. Sometimes parents come up with real bangages. Why are you telling us percentages? You tell me clear cut whether this child has got this or not. We are not able to get clear cut answers. Imagine this. We had wheezing phenotypes in the past. This was 2 wheezing phenotypes were proposed. One was symptom based, wherein we had those episodic wheezers, transient wheezers and all that. And we had a time based classification. And so these were the nomenclatures which were there earlier on. But this is not a one-point issue. The parent wants a clear-cut answer at that particular point whether the child has got asthma or not. And that's why GINA has clearly said predicting diagnosis is a difficult job at a later stage. It is difficult to apply these classifications to an individual patient. Research is still underway. And with these few words, what GINA has now proposed. They have come up with clear-cut 3 criteria, and all 3 criteria have to be met. 1, if there is recurrent episodic wheezing episodes, or there has been one wheezing episode with asthma-like symptoms in between. So it could be one of the 2 over here, recurrent episodes or one episode with interval symptoms. Alternative diagnosis ruled out after thorough testing or examination or whatever. And Finally, any of the three things over here. One, a response to SABA, a short-term response within minutes. Okay, a short-term response to SABA either in a hospital setting or at home, and it could be even few hours with OD if it is a severe episode. And after you started a trial of daily inhaled corticosteroids, whether the severity is reduced, whether the attacks are coming down or the acute episodes are coming down. So if any of these are three present, and this and this and this, all three are there, then it is you can label it safely as asthma. Okay. So the criteria would be all three must be fulfilled. If only one or two are fulfilled, you can call it suspected asthma. Now when we say confirmed, that means wheezing or a response to treatment has been documented by a trained healthcare provider or convincingly described or imitated by a parent. Now these are clear cut mentioned over there. At the same time, they've also clarified what do we mean by an acute wheezing episode, which is a symptom such as wheezing on expiration, accessory muscle use, difficult or fast breathing, heavy breathing, lasting for over 24 hours. And asthma-like symptoms means having dry cough, wheezing after running, laughing, coughing, or during sleep that occur in between episodes. So these are the interval symptoms. Again, if one or two criteria are fulfilled, then you call it suspected asthma. If all three are fulfilled, you can label it as asthma. So the diagnosis of asthma under 5 has become easier and straightforward. We don't have any glitches, we don't have gray areas. Yes, some of these may turn up to be healthy adults because medicine, as they say, is always an incomplete science. So we don't know the definite answer for everyone. Now we come to that patient, 3-year-old, 3 episodes of cough in the last one, afebrile, wheeze, no activity limitation, persist, all that. As of now, from this, we could say that yes, there is no activity limitation or weight loss, but the child has got wheeze, child responds to SABA, and just all that, this you could label it as asthma. On the other hand, you can see this is fulfilled, but nothing is mentioned in the history about any investigation or any other alternative diagnosis having been ruled out. Again, the child is only 3 years old, so we still could not be so sure you could or could not live. Now we come to the next patient. We had 3 episodes of acute wheeze, one febrile, others are febrile, plays football and coughs while playing and all that. No family history. Here again, I think we can go back. All 3 criteria are almost fulfilled. So it's easier for us. Life has been made easy. But again, despite all that, not talking of percentages, not talking of likely or unlikely, at the end of the day, medicine being an incomplete science, we still have this question of likely or unlikely. Where if the child is having, if the first time episode is less than a year old infant, if there's poor response and there are atypical symptoms, the likelihood of asthma would be reduced. So medicine, as we say, is an incomplete science, and likelihood, unlikelihood do creep in. Next we come to the next aspect. So the first part was diagnosis of asthma, particularly in under 5s have come improved. Do we need to give a trial of inhaled corticosteroid therapy? Because parents are very, very wary of allowing the child to be given steroids. So what is very clear, a 2 to 3 month trial of maintenance in inhaled corticosteroids plus SABA as needed should be considered for child with history of 1 or more acute asthma-like episodes requiring an acute care visit, oral steroids or hospitalization. And second point could be child with asthma-like symptoms occurring very frequently, more than twice a week. So these are 2 situations where you could, or rather you should try a trial of oral corticosteroids. So the trial of oral corticosteroids, there have been many studies, several studies, some studies, many of studies have used high doses, fluticasone propranolol above 200s. So now the GINA is suggesting try to reduce the dose as much as possible and try to find out a minimal effective dose for a child. And these are the doses which could be low doses for ICS in under 5s. Now we have this Amit child. I've got only 7 minutes. So Amit has cough 5 episodes in the last 12 months and what has happened, during the last episode he was admitted, treated on discharge and given budesonide for 3 months. Mom got worried and she was severely criticizing the previous doctor. And we had this Dr. joysting. The next doctor probably joisted out and said that your doctor didn't give a lot of steroids which were not warranted. Well, this is something which we should learn, that we should not do it, and if you are following the guidelines, it's perfectly fine. So under 5s, for step 1, as needed, inhale short-acting beta agonist, but for symptoms persisting for more than twice a week, which we talked about in the previous slide, a trial of low-dose inhaled corticosteroids could be done. Second step would be a regular low-dose steroid, and that is the trial which we were talking about, which will last for about 2 to 3 months. So this is from GIA straight away, and you can see they have mentioned that you can use inhaled corticosteroids, and here they are mentioning inhaled corticosteroids at the onset of the viral illness, and that may be a short course. But step 2, if the things are more frequent, we can go into daily low dose inhaled corticosteroids. As MART therapy, it's still under research. Now we have this child has got recurrent cough and shortness of breath, needs SABA 2 to 3 times a week, given oral corticosteroids 4 months back. Peds did many tests, no alternative diagnosis found. Mother says he catches cold. Does he warrant? Well, yes. These were the criteria mentioned by Gina, and we have these things well documented. So, treatment of asthma under 5s, day-to-day episodes, we can give SABA or inhaled corticosteroids as required. If the symptoms are worse, or step 2, we can give daily inhaled corticosteroids. Good response, you can cut down or reduce. You'll need to obviously monitor and make sure that the compliance, the adherence to therapy, and exclude comorbidities, because that will exclude other things also. You got to take care of the comorbidities, particularly say asthmatic rhinitis or GERD. Device, they made it very clear, mask only up to 3 years. Beyond 3 years, use a mouthpiece, because mask is much less effective, but under 3 years you can't use a mouthpiece. So in acute episodes, another change which has come up is Maxsulf. In severe episodes, you can give single dose of Maxsulf, but IV. Nebulized Maxsulf is now out. So asthma, beyond that, they have made a change in nomenclature. Variable expiratory airflow limitation was previously done. Now they say variable expiratory airflow. Well, why they have done away with this limitation factor is, in a given naive patient, a lung function may be variable. And when the patient comes for your testing, the patient may be absolutely normal, and then you may not get anything on your tests. So you may not get the limitation at that point of time. So they change the nomenclature. The diagnosis depends again on wheeze, shortness of breath, chest tightness, and which is worse at night or on awakening, triggered by all these factors. Symptoms may vary, but the more the variations are, the more likelihood you are going with asthma. Peak expiratory flow rate, diurnal variability of more than 13%, bronchodilator response, increase in FEV1 by more than 12% or PEF by 15%. Now, a high blood eosinophil level and a FeNO supports the diagnosis, and I'll come to that very shortly. So this is what is there from the GINA, and I've just tried to make it in the next slide a bit more easier for everybody. If the child comes with chronic recurrent symptoms typical of asthma, what do? You take a detailed history, and that supports asthma. Then you go for the test, the spirometry, and before and after bronchodilators. If there's a variable airflow confirmed, you treat for asthma with inhaled corticosteroids. If this is not available, you can try the biomarkers, which one of them is fairly easy available, that is the blood eosinophil count and IgEs. If other diagnosis is unlikely, treat empirically as asthma. If that is negative, then you got to repeat during symptoms, because the child might not have the symptoms at that point of time. Now, if the history is not suggestive, you take a detailed history, look for alternative diagnosis, and if the alternative diagnosis are suggestive, then you definitely treat for that. So this is what is mentioned in GINA, and you can see step 1, they have mentioned low dose inhaled corticosteroids whenever you take SABA, so short courses. In step 2, they take daily low dose inhaled corticosteroids. Okay, and this is the low dose chart for this age group of about 6 to 11 years. Okay, and this is a chart for above 12 years. Okay, there are differences in them. And we'll come to the last part. I've got 2 minutes issue of biomarkers that has helped. And what are those biomarkers? They are blood eosinophils, pheno, total IgE and allergen specific IgE. Why they have come up with that? We'll come in the next slide. They tell us about the type 2 inflammation which may be happening. They are blood, we talked about that. If the blood eosinophils are more than 150, it suggests type 2. If more than 300, try type 2 targeted biologics. In mornings, the eosinophils may be high compared to nights, worse in smokers and when the patient is on steroids. Pheno, more than 50, kids for more than 35. If on steroids, we make sure the cutoff is lower, and if the steroids are of high dose, the cutoff is much lower. The diurnal variation is reverse to that of eosinophils. So the suggestion is you can use T2 directed targeted bioclonics like monoclonal antibodies like umaneklumab, mupilumab, benalelizumab. Sometimes I find difficulty in taking these names. It helps us in categorizing the asthma. A high blood eosinophil count suggests eosinophilic asthma, a high FNO may suggest type 2, and a high total serum Ig and allergen or allergen specific Ig could suggest an allergic asthma. So it helps us in cutting down and trying to give specific therapies like an anti-Ig, like omalizumab, or anti-IL-6 in situations where if they are eligible for that, you can, where there is eosinophilic asthma, severe eosinophilic asthma, you can get dupilumab, and in severe asthma, you could try telespizumab. Of course, these are all within the realm of true pulmonologists. Maybe I and many of us may not be able to use them. Extremes of weather is another situation, more hospitalization during heat waves, because we are experiencing these extremes of weathers nowadays. So more hospitalization, more emergency visits during the heat waves and cold spells. And finally, so these are the recent additions. We can now tell the parent with fair degree of confidence, yes, your child has asthma. We have to gather objective proof for obstructive airway disease. We can try magnesium sulfate IV, not nebulization. A trial of inhaled corticosteroids, better to try with as low a dose as possible. And in difficult cases, we need to try phenotyping. High biomarkers, try specifics. Okay, I think, can I run this? Eta run hobe na na? Koche? That video has been given by a colleague. Eta run kora jabe? Just one question, is this asthma? Okay. So, on the good. So finally we have patients who tell us when a nurse is putting in an IV line, say, you don't have cordless treatment? And what happens? Doctors are like God, but I would like to put off seeing them till I'm really in a crisis, until it's time to die. So that is the two extremes. One wants cordless and the other doesn't want to see a doctor. So God does bite. God bites, but here the dog has bitten and I've forgotten. And when God bites really hard. Thanks a lot for all your patience.
Thank you very much, Dr. Manglik.
Ache to. You look up the Gina, ache to.
Poranish, Gina to Poranish. 30 minutes is too less a time for updating Gina 2025. In this small time period, he has done his job. Thank you, Dr. Manglik, and thank you, all the listeners.
Thank you, sir, for the lucid presentation. We'll now proceed to the next session, which is a very interesting quiz. What is new in GINA 2025? The moderator is Dr. Parthopratim Haldar, and the participants are, the panelists are Dr. Lokesh Pandey, Dr. Chandray Bhattacharya, Dr. Nandini Sinha Rai, and Dr. Shomik Ghosh. For the previous session, I'd request the panelists and moderator to kindly go for the memento.
So, good afternoon. So, after what Dr. Mangolik has discussed, it is very difficult for me to discuss anything new. So, this session will be quiz based, Mentimeter based. So, we'll have around 12 questions for the audience. You can join the link. It has been shared in the WhatsApp group. Just enter the link and enter the password. This is the code 33715613. Yes, people have started joining. Link in the WhatsApp group. Faculty group, I think they are nahi. Faculty group, just Mentimeter type kore, join a quiz and you put the code. Faculty group, Rohit dite parbe. Just type Mentimeter, enter, and you just need to enter the code. So I have my panelists here, Dr. Lokesh Pandey, Dr. Chandri Bhattacharya, Dr. Nandini Sinharai, and Dr. Shomik Ghosh. So we are moving on quickly. So first we will have a case-based scenario. Now this slide, this is just a recapitulation what's new in GINA compared to 2024. So continued emphasis on ICS formoterol for all severities, and it reinforces the abandonment of SABA-only treatment. Yes, I'll show. Personalized asthma management with stronger emphasis on individualized treatment plans, and treatment is based on clinical phenotypes. More practical pediatric guideline that has been already discussed, clearer recommendation for diagnosis in children less than 5 years, new step 2 option for children 6 to 11 years, that is the MART therapy, maintenance and reliever, single low dose ICS formoterol. The step down approach has been refined, and there is clear-cut guideline how to step down and what are the options for step down. Updated risk factor for poor outcomes, and GINA is emphasizing on digital tools and self-management, environmental control, and obviously they have stressed on biologics and severe asthma. So this is in a nutshell. So we'll try to analyze some case scenarios to have a better idea. Okay. 33715613. Around 70 people have joined. 33715613. Okay. So coming to our first case, 12-year-old male, recurrent wheezing and cough, no past severe exacerbation, no known allergy, weight and growth normal, baseline vital stable. And this child comes, the initial presentation is daytime wheezing and cough 2 times per week, nighttime symptoms once every 2 weeks, and uses SABA once or twice a week. No exercise limitation. Now, what should be the most appropriate initial treatment? This is not for Menti. Menti quizzes are different. This is case scenario. So, my question to Dr. Pandey, so what is the most appropriate initial treatment you will choose here? As needed SABA, daily low dose ICS, daily LTRA, or as needed low dose ICS formoterol?
See, as this child is beyond 6 years of age, the preferred treatment would be D, as needed low dose ICS plus formoterol.
Okay. So this child more than 6 years, so initial treatment should be as needed low dose ICS formoterol. Now, this child comes to us on 6 weeks follow-up. What is the status? Still needs the inhaler 3 to 4 times a week. Initially using SABA, now using ICS formoterol combination, but still needing the inhaler 3 to 4 times, no nighttime symptoms, no school absenteeism, inhaler technique correct, adherence is good, feels mostly okay, but parents feel that the child is not back to normal. So what is the most appropriate next step? Dr. Chandri.
Well, among the options given, those are that the suggestions are to continue SEM therapy, then step up to low-dose ICS and as-needed SABA, step up to maintenance low-dose ICS formoterol plus, yes, formoterol plus as-needed use, and to add daily Montelukast to current as-needed ICS formoterol. So among these options, the answer should be number C, that is step up to maintenance low dose ICS formoterol plus as needed use, that is MART, maintenance and reliever.
So initially the child was taking SOS therapy, frequency is more, so we should step up to maintenance low dose. Now what happens next? 3 months later, the child is doing well, no daytime symptoms, no nighttime symptoms, no exacerbation. Now the parents ask, can we stop the inhaler now? They are happy with the treatment, but they want to stop. So the options, you stop controller, you step down, you switch to SABA only as reliever, like the child was doing from very beginning, or you continue maintenance for another 3 months. So what should be the...
so since this child is improving now, and of course, Gina says that if the child is well for 3 months, you should step down. But since this child is now doing well, we should go back to SOS. When needed, ICS formoterol combination when the child needs it.
Okay, so now as the child is controlled, we should step down. So the outcome, if a child presenting with initial mild asthma, you start with as needed ICS formoterol. Obviously the child should be more than 6 years. Incomplete control, it was stepped up to maintenance plus reliever. Control is sustained, step down to as needed ICS formoterol. Okay, so next case. Now this is less than 6 years. 3.5 years, 3 episodes of wheezing in last 12 months. First evaluation, each episode occurs with viral cold, no symptoms between illness, no eczema, but family history of asthma is there. Development, weight gain normal, no hospitalization or steroid use. Previous episodes responded well to salbutamol via MDI and spacer. So my question to Dr. Nandini, what is the best initial strategy here as per Gina? Daily low dose ICS throughout the year, intermittent ICS at the onset of viral illness, daily Montelukast or as needed ICS formoterol. 3.5 years.
Thank you. So as per the GINA 2025 guidelines for this child, I'll like to start intermittent high dose inhaled corticosteroid at the onset of viral illness.
Okay. So this is probably the most controversial recommendation. Why this is controversial? I'll show later. This is very gray zone. Why, which child should be subjected to regular therapy, which child should be subjected to only therapy during cold. Okay. So now what happens, the child comes back after 3 months, 3 more viral episodes in 3 months, both treated early with high dose ICS, symptoms were milder, recovered faster. Still no wheezing between colds. Started going to daycare 2 months back. Parents report she is active, doing well, but they are concerned with the frequent recurrent episodes, 3 episodes in 3 months. So now, what should be the most appropriate response we should do here? My question to Dr. Shomik Ghosh. So switch to daily low dose ICS to avoid exacerbation, continue intermittent high dose ICS strategy during cold, start daily Montelukast instead of ICS, or stop all medication and observe.
So thank you, Partho. So over here, what we are seeing is that there are interval symptoms. There are quite a few multiple exacerbations. So I would switch to daily low dose inhaled corticosteroids to avoid the exacerbations.
Okay. So though the child is responding, symptoms milder, resolving faster, but there are some risk factors, like started going to daycare and also had 3 episodes in 3 months. So in this case, daily low dose ICS to avoid exacerbation. So preschool child with viral wheeze can be managed using intermittent high dose ICS at the onset of URI. Now this is the controversial recommendation I have mentioned. Gina neither mentions what should be the dose, neither mentions the duration. But they only mention if the clinician feels it is beneficial, then it can be tried. So I searched over the internet and other guidelines. So there are some guidelines And I got a definite chart from up to date that is based on most of the UK guidelines. They are saying you give steroid for 10 days at the beginning of upper respiratory infection if the symptoms are infrequent and if you feel regular ICS is not required. Now, inhaled steroid, ICS. ICS, inhaled corticosteroid, ICS. 10 days, yes. At the beginning of, so next is, so infrequent wheeze less than 3 episodes per year with no interval symptoms. This patient can be managed with intermittent SABA, but in this patient, in this specific group of patient, you can try at the beginning of upper respiratory infection, short course inhaled corticosteroid. But if the child is having more than 3 episodes per year, along with interval symptoms, you should consider daily low-dose ICS. And as per GINA, ICS is particularly recommended if wheezing episodes are moderate to severe, like patient is requiring oral steroid to manage the wheeze. There are interval symptoms like cough and wheezing in between the episodes, or there are risk factors for asthma like family history of asthma or history of atopy in the child. Okay, but this recommendation, this is the most controversial part of GINA, and they doesn't make clear-cut recommendation based on that.
Partho, I think so. One of the reasons this has been proposed that at the beginning of an episode for 10 to 14 days you can give is that smaller children, they have more propensity to go into severe acute exacerbations and invite a course of short oral corticosteroids. This is probably a attempt to prevent that oral corticosteroid use.
That is not exactly the situation now. Okay, we'll proceed and we'll have a question on based on this. So now we'll start the quiz. Okay, so if I think around 70 people have joined, so you just put the code 33715613. So as per GINA 2025, what is the preferred initial treatment for a child more than 6 years with mild asthma symptoms, less than 2 months, no risk factor for exacerbation? So timer is there. Okay. So the answer is as needed low dose ICS formoterol. Many people have answered. So as needed SABA is not the preferred option now, more than 6 years, because no, not 12 years. The recommendation is 6 years now. I am showing. I am just coming to that. Recommendation is 6 years. I am coming.
This is AIR only. This is not MART. AIR only. This is anti-inflammatory reliever.
SABA with ICS.
Okay. So see. So what is the
step 1?
Yes.
Use step 1.
Yes. No. See, the step 1, low dose ICS taken whenever SABA is taken.
Yes. So
yes, and you see the reliever as needed SABA or ICS formoterol reliever in MART.
That is step 3 or 4, not step 1. That is step 3 or 4.
Okay. No, that's.
Your correct answer is SABA SOS with ICS. It's not MART. MART is only used about 12. This, what you're telling it is for step 3 and 4.
Okay. So, I think this. Yes. mild asthma symptoms less than 2 per month and no risk factor for exacerbation.
Yes, there is no doubt about it.
Okay,
You use
point
Sava
well
only.
taken.
No doubt
Okay.
about it.
So, okay, so, okay. So,
no,
it should be,
Sava with
it should
ICS.
be whenever the child is taking Sava, it should take some ICS along with. Okay. Okay. So what is the rationale for using ICS formoterol both controller and reliever therapy in GINA 2025? Okay. So timer, I think I have on the timer before. Okay, I'll take care of. So now my question to Dr. Chandri, just explain this. What is the rationale behind the recommendation? So our options were, it is cheaper than ICS alone, improves lung development, reduces exacerbation more effectively than SABA, eliminates the need for maintenance therapy. So what are the key points behind the recommendation?
The answer that Dr. Partho has already showed is that ICS must be used when reliever is used. Formoterol can be used despite being a LABA because its onset of action is quite fast, that is 2 to 3 minutes, and its action can last up to 12 hours. So combining it with inhaled corticosteroids, what it does is every time a dose of reliever is received by the patient, an anti-inflammatory reliever is also received, that is the steroid is received, because evidence nowadays shows that using only SABA can risk the child going into a severe exacerbation, and it actually causes worsening, and it is a risk factor for severe asthma. So that is why not only just using SABA, every time a bronchodilator is used, a steroid inhaled dose must be received. Whether it is a SABA with an ICS or it is a LABA which is quick acting like formoterol. It is based on the age cutoff, but the anti-inflammatory component has to be there. It cannot be only beta-2 agonist.
Okay. So other options are definitely incorrect. So I'm not going into the details to. So next question. As per GINA 25, when should stepping up of asthma treatment should be considered? When should stepping up should be considered? After one mild exacerbation, symptoms twice per week, 6 weeks after starting treatment, or 8 weeks after starting treatment? Okay. So this is the answer. So if symptoms occur twice per week or more, you should consider step up. So I would request Dr. Nandini to explain this, when to consider step up and step down as per GINA.
Yeah, so you can see it's beautifully shown on this table as per GINA 2025, when to step up. Like when daytime symptoms are more than equal to 2 times per week, and as it is, it's reliever use more than 2 times per week. And any nighttime symptoms, okay, any nighttime symptoms. Activity limitation, like going to school, any daily activities, playfulness, this kind of things. Then again, exacerbation requiring oral steroid, at least once. Yeah. Then worsening control despite adherence. So every time before stepping up, we need to check whether they're adhering to the protocol they are given, how they're using the device, and the compliance. Again, during the seasonal exacerbation, we should be careful. Before we are expecting some triggers, we do this.
Okay. So just opposite, you need to consider step down, like well controlled for 3 months with no past exacerbation, no activity limitation, patient and caregiver able to monitor, no upcoming risk factors, like that. So what are the options? You can have sustained step up if the child is in poor control for weeks or months, low dose to medium dose. You can have short-term step-up in form of viral infection, increase the ICS dose, and you can have day-to-day step-up with MART regimen where you can add extra reliever dose. But important note, step down must be monitored for 4 to 6 weeks, recheck inhaler technique, and always we should have written asthma action plan. So next is, as per GINA 25, how should asthma be diagnosed in children less than 5 years? I think this is a very easy question because Dr. Mangolik has already discussed this. This is the most important change that GINA has done. So almost everybody is answering. So this is the right answer. So it should be clinical symptom based. So I would request Dr. Shomik Ghosh to explain this chart quickly. I think Dr. Mangolik has already shown this, just to have a brush up. Already done. Oh, okay. Yeah. We can skip. Okay.
Now, the important, just one line is that now we can actually label them as asthma below 5 years, which we couldn't earlier, but you must satisfy all the 3 criterion.
Okay. So moving on. So 5-year-old girl, recurrent wheezing episodes only during cold, no interval symptoms, no known allergy. She has been treated with SABA as needed. What is the next management option? Start daily ICS, add LABA, continue as needed SABA, or consider trial of intermittent short course ICS during cold. I think this question we have already discussed. So here, as the child is having episodes only during cold, along with no interval symptoms or no known allergy, already treated with SOS SABA, here we can consider trial of intermittent short course ICS. Now, this is for Dr. Pandey. Now, okay. So this question is similar. So I will take this question also. 4-year-old boy, recurrent viral wheeze, 6 episodes in last 9 months. No atopy, but some interval symptoms like cough and occasional night awakening. This child is taking SOS SABA for each episode. Now, what is the recommendation here? Daily low dose ICS, daily Montelukast, short course ICS, or as needed ICS formoterol at the first sign of wheeze. So here, what should be the answer? Four years, many people are using as needed ICS formoterol, but 4 years it is not recommended till now. Okay, this child is already on. So, I think many people have responded. I can stop. So, daily low dose ICS, because this child, this situation is little different from the previous. This child is having interval symptoms along with very frequent symptoms, 6 episodes in last 9 months, along with occasional night awakening. So this is for Dr. Chandri. See, you just explain this chart. I would like you to stress on this part, consider intermittent short course ICS at the onset of viral illness. Rest of the chart I think we have already discussed, low dose, then double the dose. So this part requires special attention. They have mentioned intermittent short course ICS at the onset of viral illness, and consider this step, infrequent acute viral wheezing episodes, no or minimal interval symptoms. So the first question, the child was not having any interval symptoms. Here this child is having interval symptoms in the form of residual cough and occasional sleep disturbance. So here only high dose ICS at the beginning will not suffice. So you need to go for a low dose maintenance therapy.
This they have considered as step 1 for under 5s.
Yes.
Focus on the word infrequent.
Infrequent.
Okay.
So
that has to be less than 3. It cannot be that every month the child is having viral induced wheeze. Even if they don't have interval symptoms, yes, that means the frequency is very high. So the infrequent word is very important. Maybe this child had 2 viral induced wheeze in last year. This time what you may consider is giving a short 10 to 14 days course of inhaled corticosteroids at the beginning of the cold. This is the step 1 that Gina wants us to consider for under 5 children. The step 2 is where the episodes are frequent and or the symptoms in between 2 episodes, they are either having exercise-induced cough, or the child is coughing after laughing, or having nighttime awakening, going on having chronic symptoms off and on, then to consider low dose continuous ICS. So that is the difference between the step 1 and step 2.
Yes.
Also, if the child has had one episode of oral corticosteroids given.
Yes.
Yes, or a severe episode.
Recurring oral corticosteroid. So the 2024 guideline, they had a term multi-trigger wheeze, like wheeze triggered by cough, laughing. Now this term is not being stressed on 2025 guideline. So they are focusing more on interval symptoms, night symptoms, whether the child require oral steroid, severe exacerbation. So they are focusing more on that. Okay. 9 minutes, okay. So next question. 10-year-old boy with cough and wheezing once or twice a week for the last month. He is otherwise active and well, no nighttime symptoms, no exacerbation. So what is the most appropriate initial controller therapy according to GINA 25? Sorry. Very less symptoms, wheezing once or twice a week, less than twice a week for last month, otherwise active well, no nighttime symptoms. Okay. So this is the, sorry.
Again, this is wrong.
Yeah, it should be.
Okay, so I think the interpretation of chart has been made wrongly by me, and I have discussed with panelists. So this should be for more than 12 years, as Sarah has mentioned. So I'm skipping this question. The learning point is
no, it
here.
should be same, no? It should be ICS with
short action. Separately, 2 inhalers, one in the form of steroid and one in the form of SABA. Whenever SABA is taken, one along with.
Yeah.
Okay. So 7-year-old boy with asthma, well controlled on low dose ICS for 6 months. He has not needed a reliever inhaler in last 2 months. Well controlled on low dose ICS. Okay. So, low dose ICS for 6 months, has not needed a reliever for 2 months.
Again wrong. Again wrong statement.
Okay, now.
All wrong.
Yes. Sorry. So, step down by all this thing is due to the wrong interpretation of the chart. So, step down by reducing ICS dose, that should be the answer. If the child is on very low dose ICS, then the last step, that is SOS SABA along with SOS.
No, you have to just decrease the dose of ICS. If you have B doses, you can come up to once a day. You should not stop ICS.
No, it's a very low dose ICS. So if the child is in twice, we'll move on to next step once. If the child is in once, then we need to step down to next step.
Where did you say that he is on once?
Okay. 9-year-old girl, low dose ICS formoterol, maintenance reliever, presents with 2 courses of oral steroid in last 4 months. Reports missing doses twice weekly and poor inhaler technique. Beyond optimizing adherence and technique, which adjustment is next? So escalation, adding Montelukast, step down to intermittent high dose ICS only during symptoms, or switch to medium dose ICS plus separate SABA reliever. Low dose ICS formoterol maintenance reliever, 2 courses of oral steroid in last 4 months. So escalate to medium dose ICS formoterol maintenance. So I would request Dr. Pandey to explain this. This chart, yes. So just please explain this chart. When low dose ICS SABA, then just step 1, step 2, followed by step 3. Just
See, this child is already on step 3. He's already on.
So child is on
plus
very low dose
combination.
MART already.
If the child is not improving, and in fact the first line was very important, that adherence and compliance has to be reascertained, and then we increase the dose to a medium dose for this patient.
So in this child particularly now this child is going towards uncontrolled because already child is on step
Yes,
4.
the child is already on step 3.
Step 4.
Yes. So low dose receiving, not controlled, requiring oral steroids. So we can move on to step 4, and even the child may not get controlled. So
Already on step 4 because you are telling he is on low dose mark.
no, low dose. Low dose present with 2 courses oral steroid in last 4 months.
You are telling he is already on step low dose mark. It is step 4.
See, in fact, all the options are possible. According to Gina, all the options are possible. You can add.
I mean, low dose means I should have mentioned very low dose. Step 3, I think. I wanted to mean step 3, very low dose. Now moving on to step 4, as the child is not getting controlled. Okay. So this is for 6 to 11 years. I think this chart we don't need to discuss again. Low dose ICS whenever SABA taken, for daily low dose ICS, then low dose ICS LABA or medium dose ICS, then medium dose ICS, then moving to step 5, where you need to consider the biologics.
In fact, according to this, all the possibilities which are given are possible. You could have increased only the dose of ICS with SABA separately.
Yes.
You could have added a leukotriene. Of course, that is not a very good option.
That is secondary option.
A secondary option, and you can have gone to that as well.
Okay. So 12-year-old boy with obesity and moderate persistent asthma on medium dose ICS LABA still has daytime symptoms more than 3 times per week and 1 emergency visit in past 6 months. Blood eosinophil count is 150, total IG is normal. So what are our options? Increase ICS dose, add LTRA, refer for biologics, switch to as needed ICS formoterol.
Please on track 2 or track 1. आपने ये बताया नहीं. लावा दे रहे हो क्या दे रहे हो?
No, track.
You don't track 2 or track 1.
Medium dose ICS LABA only. Track 2, track 1, a patient that depends on who.
You go on track. You go on.
Yes, I am coming to that. I will show the chart.
आप ये बता नहीं रहे हो कि ये लावा कौन सा ले रहा है. You don't track 2 or track 1.
Okay, I will show the next chart. So people are saying, most of the people are saying initiate biologics.
It's not true.
Sorry, this is the question. So
এবার হয়েছে
most of the people are saying increase ICS to high dose only. Now, this child on medium dose ICS LABA already, so increase ICS to high dose is not an option because the child is already on combination therapy. And as needed ICS formoterol is also not an option because child is on maintenance, not getting controlled. Now, biologics or LTRA. What should be the option?
Age 12 years.
12 years.
Focusing on the factor that the child is obese. Also focusing on the factor that the eosinophil is not particularly very high. Keeping these options in mind, I would like to add a leukotriene receptor antagonist because this is a low Th2 type of asthma, most likely.
Okay. So now coming to the phenotype-directed therapy, obesity-related asthma often has non-eosinophilic airway inflammation and they respond less to ICS dose escalation. They may have leukotriene-driven inflammation. So LTRA can be an useful option. And specifically in these children, where the child is very obese, more than 97, already on good amount of steroid, we can try with LTRA here.
So it's important also to take note of the LTRA recommendations. I think so in practice it gets used very randomly, but there are two specific indications. One is obesity, another is exercise induced. These are the two areas where we should be considering it. There are plenty of formulations which are using it randomly. We have to be careful about that.
Okay. So the phenotype, there are two types of asthma. One is type 2 asthma, that is predominant biomarkers, elevated eosinophil, pheno and Ig along with sputum eosinophilia. This group, allergic asthma or eosinophilic asthma, they have good response to inhaled corticosteroid, and if they does not respond to step up, then we need to move up to biologics. And another group is the non-type 2 asthma, where it is not driven by Th2 cells and biomarkers usually have normal eosinophil along with normal Ig or low pheno, like obese, smoking, occupational asthma or late onset adult asthma. And this patient, they usually doesn't respond very well to corticosteroid dose escalation. So I am skipping this I think already discussed, and this chart also I should skip. I am running out of time. Now 14-year-old girl with documented adherence to high-dose ICS LABA montelukast has persistent eosinophilic asthma, more than 3 exacerbation along with high pheno. So what is the most appropriate next step? Tiotropium, initiate biologics, switch to oral theophylline or replace ICS? Already many people have answered.
You have to be fast.
Yes, last question. So this is the time to start biologics. I'll take pardon from the panelists as I am not moving to them to finish this. So severe asthma with type 2 inflammation, elevated blood eosinophil, elevated pheno. Here, frequent exacerbation despite high dose ICS and other controllers, you can consider the option biologics. So this is the chart, what Sir was telling, track 1 and track 2. So in track 1, we can use AIR, that is the anti-inflammatory reliever, ICS formoterol, or in track 2, you use separately ICS and SABA. So this question I will skip because this is the last question, but I will skip because I am already, huh? Okay, so an 11-year-old athlete, low-dose ICS formoterol still develops wheezing and chest tightness when sprinting, despite correct inhaler use. So which add-on therapy can be tried specifically for exercise-induced bronchospasm? Daily LABA, inhaled cromolyn, increased ICS, or daily oral beta agonist? Now, this is a very specific indication where cromolyn can be tried because this child is otherwise well controlled. Doubling the dose is not required here because the child is not having any other symptom apart from wheezing and chest tightness. Another option, tell them to take extra dose before going into.
It's not available.
No. No. GINA guideline is for the whole world. This is as per guideline. The GINA guideline is for the whole world. So that's why I mentioned. So one option, you take extra dose of the MART therapy before going, or as per GINA, here it can be tried.
So we stick to extra doses of SABA just before the exercise.
Yes. So that's why the persistent EIB on optimized background activity, GINA recommends pre-exercise inhaled master stabilizer.
So I think our outstation faculties are going to miss their flights.
So I'll stop here. Thank you.
Yeah, so thank you for a very interesting session. And I'd request the panelists to go and go to the memento corner, and we'll now move on to the next session, which is difficult asthma. The moderator is Dr. Indu Khosla, and the panelists, Dr. Ashok Modi, Dr. Devjani Gupta, Dr. S.K. Kabra, and Dr. S.S. Rawat.
I will manage, don't worry. I welcome my faculty who need really no introduction, Dr. Kabra, Dr. Devjani, Dr. Kaustubh, and Dr. Rawat. I think without much ado, I will start because we all are on flight mode. Okay. So asthma, we know we've been talking all day long since yesterday about asthma, but it's the most common chronic pediatric respiratory disease. And it is estimated that 1 in 10 children would experience some kind of asthma symptoms. The highest prevalence is seen in the higher income group, higher income countries, and the highest morbidity and mortality is seen more in the low and the middle income countries for reasons that it may be not diagnosed or not treated, and it causes a significant impact, both physical, psychological burden on parents and the patients, socioeconomic costs, absenteeism from school, lost productivity amongst caregivers, lost educational opportunities for children, and decreased quality of life. So is difficult asthma severe asthma? So we can actually classify, and I would use this expert faculty here to tease these 3 differences, that difficult asthma can be divided into 3 groups. It is untreated severe asthma, or it is difficult to treat asthma for a variety of reasons, or a small subsegment of severe therapy resistant asthma. And we know there are a lot of causes which we have discussed in the last 2 days, which could be difficult to treat asthma. So your diagnosis can be wrong, allergen exposure, obesity, gastroesophageal reflux disease, all the comorbidities, psychological factors, and adherence. So all these factors can cause asthma to be difficult to be under control or difficult to treat. Okay? So, but when you talk about severe asthma, this is by definition an asthma which requires high dose ICS plus a second controller and or systemic corticosteroids to control the asthma to prevent it from being uncontrolled, or it remains uncontrolled despite this therapy. So this is the small subsegment of severe therapy resistant asthma. So most children fortunately fall into the category of mild to moderate, and they would require ICS, they would require low to mild to moderate doses of ICS for control depending on their age group. We've discussed in the previous quiz, and most of them would settle with that. So with this I start my first case. Now this is a 6-year-old girl who came with cough, wheezing, breathlessness since the age of 4 years. Initially, the episodes were once in 2 to 3 months. But for the last 4 months, when she presented to us, she had 1 episode every month. She landed up in the ER multiple times, and on 2 of the occasions, she had to be given oral corticosteroids to control these episodes. Her episodes were afebrile. There was a dry nocturnal cough. It was relieved with nebulizations. There was no family history of asthma or atopy. And she was started on budesonide, 200 micrograms twice daily, with spacer and salbutamol as required since the last 2 months when she started coming frequently. But the parents felt that the child was still not better with this therapy. Now, Dr. Devjani, how will you approach this child? What are the pointers in history would you ask for such a child who has been uncontrolled in the last 4 months and is on budesonide 200 micrograms twice daily with the spacer?
Thank you. I think we've discussed a lot of it throughout the day. So can we go back to the question, please? So in the history, as we all do it in our office practice, we need to explore more on symptomology. So you've given the onset and frequency. We need to know more about compliance, adherence, the technique, and the technique. Apart from that, the impact on daily living in as much as, are there any sleep disturbance? Is there any school absenteeism? Are there any pets at home? Trying to tease out exposure triggers. So is the house damp? Is there any smoking in the house? Are there pets or the birds in the house? Any form of exposure in school? It may be school bullying as well. So you need to know about the environmental history, the social history, history at home, compliance, adherence, and the way the child takes the inhalers. So that's in short about history. points on examination. I know we would do a head-to-toe exam, but we would definitely focus on the respiratory respiratory system. But if we are to exclude mimics and comorbidities, we would need to kind of look for any allergic manifestations in terms of eczema or shiners or Denny Morgan's lines, constant rubbing the nose. So I think that needs to be in effect. You might wish to do an ENT refer to look at the adenoids.
So we'll stop there. We'll stop for the management, just the points on history and examination.
Okay, so to rule out respiratory system, rule out mimics and comorbidities. So you need to do a thorough assessment of your cardiac status. You need to do a good going ENT exam. You need to see for any allergic manifestations, be it in the skin or elsewhere on the face.
Yeah. Anybody wants to add anything to what she said?
Yes, so like point history, what Madam has told, that is absolutely fine. We have to try to find comorbidities in this child. So any system like for example, allergic rhinitis, or the child is obese, or OSA, psychological factor, then various triggers, whether the child is exposed to any trigger like congenital tobacco smokes, pets and house. Yes. Then what is this SABA use? If he's using SABA very frequently, that is the risk factor. Then point of examination, we have to rule out alternative cause in this child to any history of some cardiac disease or upper respiratory symptom, like indicating of something like inducible laryngeal obstruction. Then see for typical allergic markers, what Madam has told. See whether there are any focal signs, something like clubbing or failure to thrive. All these things, they indicate some alternative diagnosis. So we'll try to see for some systemic signs of some alternative diagnosis, see for any focal signs and allergic markers.
Okay, thank you.
Because the exam should include growth at the top.
Yes.
You
Awesome.
have to have the
Excellent.
child
Very
on the
good point.
centiles.
Yes.
Have the child on the centiles.
Perfect. So as per what you all wanted, we went back to the patient to take a detailed history, and we found that the patient was taking budesonide only during episodes of wheezing for the fear of steroids, as the parents had a lot of fear. But the father was merrily smoking at home. He was not scared of that. And there was history of some nose block and early morning sneezing as well. The child had cough and the child exerted like running. And on examination had some Demi Morgan lines, allergic shiners, he had some turbinate hypertrophy. The chest examination showed a prolonged expiration, and there were no other foreign sounds. So Dr. Kaustubh, what next would you do? You have got this, what would you think?
Right. As you can see...
So this thing was given to me. Sorry, my bad.
Sorry.
The name was given to me was Kaustubh.
So basically, as you can see, this is one of these difficult to treat child. And so we have to rule out factors like adherence. So basically, as you know, there is a problem.
Mike.
Hello. Yeah. So problem with adherence. So obviously this child is not taking the medicine because of whatever reasons, because of their thought, fear of steroids, and also perceptions, and maybe the cost and everything. So that is, adherence is very important. They need to take the steroids regularly and properly. The second thing obviously is the trigger, smoking in father. So we have to rule that out. We have to explain it to the father that this is not acceptable and this will obviously precipitate further attacks. Sorry, can you go back? And see, obviously, she has got these allergic manifestations. So and turbinate hypertrophy. So we have to treat her for allergic rhinitis as well, for her symptoms to be controlled.
Sure.
So unless we do that, then her asthma will be difficult to treat.
Yeah, so we had adherence issues, we had comorbid conditions, we had atopy allergy. So all these were factors, and these are the standard features that you will see in any child who has allergic rhinitis. You may have allergic shiners, the salute, the Demi Morgan lines, etc. And
so one important thing is that don't step up. This child has got a lot of factors which are causing uncontrol. So first, control all those contributing factors, and then only think of stepping up.
Yes.
So this is a message you want to give.
Yes. And we have a whole lot of comorbid conditions. What we had read, allergic rhinosinusitis, adenoidal hypertrophy, GERD, obesity. But today, there are 4 more conditions which are added as comorbid conditions: obstructive sleep apnea, in an older kid, depression and which might prevent the child from taking medications regularly. Vocal cord dysfunction becomes like an asthma mimic. It is also added as a comorbid condition. And drugs like NSAID, beta-2 blockers, which or even say captopril, antihypertensives, can also be comorbid conditions. So we need to take a history of all these things before deciding to step up. Okay? So the child here was started on nasal corticosteroids. Parents were counseled regarding the need for regularity. Father was also counseled about smoking, and hence the compliance of this child and adherence was ascertained. But the child still persisted to cough. Dr. Kabra, sir, what would you think would be the reason now for this child?
Clinically looks like classical asthma and not responding. Again, check that the adherence, technique of inhalation, technique of nasal steroids, and some environmental issues.
Yes.
Before going for a further investigation. If everything is normal, then you can think of stepping up.
Yeah. So what my esteemed faculty here is trying to tell you is look at all these conditions before putting the trigger on stepping up. No one over here has told you to step up therapy. So you need to look at all these conditions and the big Ds, the drug, the delivery, the device, the diagnosis. Sometimes here, of course, we are quite sure that it looks like asthma because the child was responding to nebulizations and was all the classical features were there. But look at all these Ds before deciding to step up. And if I were to show you this video. This is what he was doing. And this is true story, not made up. Okay, and you must also select the right device for the age. Below age 3 years, you will use a face mask with the spacer. Above 4 years, it has to become mouthpiece. Many a times children come to your clinic, they're uncontrolled just by changing the device, and even looking at the device whether it is faulty, the things will change. And of course, in older child, you can, but MDI with spacer stays a versatile universal device, but you can look at breath actuated inhalers or DPIs for older kids. So it has to be age.
Can I just add one thing, Indu,
Please.
Often we get it in our clinic. The mom comes and says, "Nee, doctor, ma'am, isme to dawai hai," and she pumps it, and the propellant comes out. So it's important the drug dosing counter, and empty canisters without the medication would just have a propellant. So they need to understand that as well.
Absolutely, point well taken. So exclude all these factors, and before you call it that this child has got severe asthma or difficult to control asthma. So misdiagnosis of non-asthmatic conditions as uncontrolled asthma, as per literature, could be as high as 12 to 30%. Okay, so the big 5 is here. What are the factors in difficult to treat asthma? It's adherence, 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 adherence. Okay, let's go to the second case. Now this is a 5-year-old male child born of a full-term LSCS delivery. He has dry cough since the last 6 months. So at the age of 4.5, he started coughing. Now cough persisted for 2 to 3 weeks, more in the winter, and it reduced in the summer months. The parents said maximum cough is in the winter. Current episode when he came to us was for 3 weeks. Initially they said that cough was dry, but now it has become wet. And he has occasional fast breathing. He also has post-tussive vomiting. He had mild fever. There was no weight loss, no decreased appetite, no other upper airway symptoms in the form of snoring, blocked nose. There was no family history of asthma, and there were no obvious environmental triggers. With these complaints of frequent cough in the last 6 months, he visited OPDs, and he was referred to me from somewhere in Gujarat. He would receive nebulization, beta-2 agonist. He had received oral corticosteroids, 3 courses of corticosteroids in the last 3 months. And he was also put on inhalers. He was put on salmeterol with fluticasone, 250 micrograms twice daily with a spacer and a mouthpiece. This is a 5-year-old child. The parents said the only medicine which worked on this child was steroids. Dr. Kabra, do you think this is severe asthma? Or
Madam,
Dr.
first of all, how the child is in between, like he has got cough since 6 months continuously, or he gets all right and he gets cough in between?
So he used to get better. It used to be worse in the winter months, but he used to still have cough on and off.
Okay,
Winters were the worst.
So the two things which are worrying to me, that he is getting a wet cough now, that is bit worrying.
So
sign,
now it
and-
has become wet because he was coughing since 3 weeks. Otherwise, it was always a dry cough.
Okay, and then subsequently he is also having episodes of fast breathing, indicating that there is some parenchymal disease also, because isolated fast breathing in asthma I don't find. So two things are worrying. This child is having symptoms since past 6 months, still undiagnosed, no test done to confirm that child is having asthma. He is having some wet cough and he is having fast breathing without cough. So I'll confirm the diagnosis, so that whether child is having asthma first, and then whether he's having some complication, something like persistent infection going on, something alternate diagnosis. So I'll not straight away label the child as asthma. I'll work him up and then only I'll proceed.
So are there any pointers in this case that this could not be asthma?
Yes, because we don't have sufficient information as yet. Like it is, you need to confirm the diagnosis of asthma, number one. So we do not have a confirmation of the diagnosis of asthma. Number two, we do not have in this history we haven't teased out the modifiable factors. So you need to confirm your diagnosis, you need to tease out your modifiable factors, you need to work on the modifiable factors and then reassess. And only then you go and label it. So till then it is difficult to treat asthma.
Sure. Dr. Ashok, this child was well grown. His height was 105 for a 5-year-old, weight of 15.7. So he was in the less than 25th centile, but he was growing as per his centiles. No pallor, cyanosis, clubbing, maintaining saturation room air, no allergic markers, upper airway was normal. He had bilateral creps and V's. Other systems were normal. How would you like to investigate him?
Obviously, this child doesn't fit with a clear-cut case of asthma. So we have to look for alternative diagnosis. So we have to do some blood counts like CBC, immunoglobulins. We have to do a chest X-ray, and if required, maybe a CT scan to make sure what is the diagnosis before we start treatment.
Dr. Kabra, would you like to add something?
Salient finding in history is recent onset illness of last 6 months, dry, intermittent, now wet, with crackles as well as wheezing, and it is responding to steroids, not to the inhaled this one. So it suggests that you should think of asthma mimicker, including hypersensitivity, pneumonitis, or something similar, and he already elaborated that it needs investigation. If it is classical, you'll not do anything including CBC, X-ray. Here, he needs some investigation, including reversibility, documentation, because he is 5-year-old, X-ray and other investigation, and history, whether there is an exposure which is causing this problem, and that is responsible for crackles and wheezing.
Sure. So these were his investigations. His counts were essentially normal, excepting that he had an eosinophil count of 10%, CRP was negative, IgE was 256 IU, ESR was normal. Trial of inhalers were given to him by the referring doctor, and we checked the adherence, technique, compliance. There was hardly any response. So our initial working diagnosis was whether inadequate compliance, adherence, all that was ruled out. Alternative diagnoses were looked at and it was kept in mind. We thought there could be some trigger, as you mentioned, and we thought, is there something like a persistent infection, a PBB, or a completely alternative diagnosis? Yes, Dr.
We could have done iOS also, because if I were a child, sometimes they cannot do spirometry. If you think of asthma, at least try to do some reversibility by iOS. iOS is available almost in all cities. So we should at least try to do iOS and confirm whether there is evidence of asthma or not.
Yeah, this was a smart 5-year-old. He did a spirometry for us, and the spirometry was normal. I don't know if you can see it properly. Yeah, it was normal. It didn't show any obstructive or restrictive disease, and therefore we thought we should investigate him further. So Dr. Kabra, we did a CT scan on him, and this was a CT. I'll show you both the views. This one. This was his CT scans.
So now this scan, sagittal scans, this is a post contrast view almost on the lower zones. I am finding dilated airways, stagnant ring, diffuse nodules, constitutional thickening. So, and plus cheese in glove appearance also. So this is bronchiectasis with some interaction. Since the child is growing well, it could be NTM, because the child could have NTM and all these symptoms, they
So
would be there.
this was what was reported by a radiologist, and you can see there is some interstitial pattern of lung disease here. There are tiny scattered discrete nodules in random distribution. There is some amount of peribronchial thickening, suggestive of some kind of acute or a subacute hypersensitivity pneumonia.
Important thing here is to see that eosinophils are 10%, IgE is raised. There are several points against asthma, and it is showing an interstitial with some shadows. So think of parasitic diseases, including whether it is in the filarial zone or whether it is something like a Ascaris which is going and then it is causing some problem like a Loeffler's. So this would be the finding that interstitial problems then and with some shadows then think of parasitic.
Okay, so we had done a bronchoscopy bowel. The bowel showed a neutrophilic predominance. There was no much eosinophils on the bowel. The culture, PCR culture was sterile, but it showed a mycoplasma, which we were wondering whether it is significant or not. Okay, so what is important in this case that we need to look at diagnosis. We need to look at the case history-wise, look at with investigations, confirm the diagnosis before stepping up therapy. So here we are all talking to you that be careful when you step up therapy, be sure when you step up therapy, because there are a lot of differential diagnoses of asthma. And carefully each and every one of them have to be ruled out. Say for instance, you have to look at atypical causes. If you have a wet cough, you're going to look at the mucociliary disorders, immunodeficiency, look at if there is malacia, you may have something like an expiratory kind of a stridor, so-called wheeze. So there are a lot of differentials which you need to rule out before thinking that this is asthma. We went back to the drawing board for this child. He started developing cough when he had started going to school. His school was 20 kilometers from his home. He went by an open bus. He passed a 17-kilometer long stretch of a black stone quarry, and there were no other environmental exposures. But when we asked history, we asked in and around his house, and we couldn't get any such history. But later on, just by chance, this topic came out, and he was and this was a continuously crushing quarry. And the moment we got this history, we changed his route to his school. He was treated with corticosteroids. Trigger avoidance was advised. He's following up with us. In fact, he has come last time also, and he's very well. He was on inhalers, which we have tapered off, and he's doing well. So it's very important to take a complete history. Quickly going to the last case. Now, a 13-year-old boy, he was referred for uncontrolled asthma. He was on formoterol and budesonide, initially 200 micrograms twice daily, but since he was not better, he was stepped up to 400 micrograms twice daily for the last 6 months, and he was also on a MART protocol where he was using formoterol and budesonide as and when he had an exacerbation. Now, which was at the low dose when he used it as a MART protocol. Despite taking 400 micrograms of formoterol budesonide twice daily, he still needed relievers twice weekly and at least sometimes once or twice at night as well. There were no upper airway symptoms. There were no obvious triggers. He was compliant. Technique was appropriate. There was history of severe eczema since childhood, but there was no family history of asthma. So when we examined him, he had widespread eczema all over his body, and I'll show you a picture. No pallor, icterus, cyanosis, clubbing. He had bilateral wheeze. There was no respiratory distress when we saw him, and all his other systems were normal. So this was the child. He had eczema all over his body, and he was itching. He was most concerned with the eczema. It was affecting his sleep. He was so badly off, and that was bothering him more. The wheeze was bothering him, but this was bothering him more. Okay, we did his basic tests. CBC showed an eosinophil count of 16%. His IgE was high. It was at 4,792. IgA was normal. IgM was normal. A specific IgE for aspergillus was positive. We did his lung function test, which showed significant bronchodilator reversibility, confirming the diagnosis of asthma, and this was his X-ray. Anybody would like to comment on the X-ray?
So this is obviously a child with asthma, uncontrolled, the X-ray showing a right upper zone infiltration along with bit of hyperinflation. There is evidence of positive criteria for ABPA. So this is a child with uncontrolled asthma, uncontrolled comorbidity in form of severe atopic dermatitis, and a complication in form of ABPA. So there are three various factors are there in the child.
How commonly, Dr. Kabra, do you see ABPA in your practice?
See, in uncontrolled asthma, it may be around 10 to 15%, and it depends which definition you are using, whether you are using the Peterson's and Harrison's or whether the recent one.
Yeah.
But it may be 10 to 15% in our country where it is uncontrolled asthma.
Yeah. So whenever you see an ABPA, think of an underlying uncontrolled asthma or cystic fibrosis would be your second diagnosis, right? So these are the classical guideline criteria for diagnosing ABPA. Now, this child was treated with steroids for ABPA, but it did not settle. Then itraconazole was added as symptoms are still there. Formoterol budesonide inhalers continued. MART protocol was in place for exacerbations. He was advised avoidance of triggers, flu vaccine, etc. He was taken, a skin reference was taken and he was treated for his eczema, which he was on treatment for eczema since childhood, and multiple things were changed up and down. 8 weeks later, he was partly controlled with steroids and itraconazole, daytime and was partly controlled with daytime and nighttime symptoms, and that now those symptoms became once in 2 weeks. Dr. Ashok, what would you like to do next with this child?
So obviously this child, as we know, we have proved the diagnosis of asthma. We have ruled out the other comorbidity. I mean, we have added or treated the comorbidities. We have confirmed the compliance and the adherence and the dose. Now this obviously is a case of severe asthma. So now we have to think of upping the dose. So first we can try with non-pharmacological treatment like getting the eczema better, and then if it's still required, then we have to up the treatment of, we are giving inhaled corticosteroid, maximize the inhaled corticosteroids, highest dose possible, and if it's still not possible, then we have to think of biologicals.
Yeah. Dr. Rawat, would you like to add something to this treatment, or you would agree with what Dr. Ashok has said?
We can add in this child tiotropium, because obviously this child is on step 4 and now we can go on step 5. So definitely tiotropium we have added, and now even if it doesn't get better by tiotropium, now it is the time for phenotyping and then finding out his phenotype, and probably his skin problem requires more treatment because skin is not getting better. So biologics in form of dupilumab, they work beautifully for atopic dermatitis along with asthma. So in this child, probably a good treatment of skin by dupilumab would take care of both asthma part as well as skin part.
Yeah. So we added tiotropium to him, and steroids were tapered off as per the treatment of ABPA. Eczema treatment was quite severe still, and this is the standard thing which I think we have seen all in the last. We did a skin prick test also for him, for his eczema, and he was very significantly sensitized to dust mites. Okay, though we had a little less place for him where we had to do his skin prick test. On the back we had clean area of skin, so that's where we did. And we started immunotherapy for him for his eczema and his, so we started immunotherapy. His skin became worse and immunotherapy had to be stopped, all right? And so now, Dr. Kapra, now is this severe asthma? Now will we call him severe asthma? Is it important to phenotype him?
Yeah, it's obviously appropriate treatment with the inhaled steroids, long-acting beta agonist, and environmental and comorbidity. Despite that he is not controlled, then it is a severe asthma. And we have to see whether this ABPA is well treated, because it may be of various steps.
Yes.
And for that you can see whether the IgE is coming down, not the specific IgE that will persist, but if the total IgE is coming down and his pulmonary functions are improving, then we can say that it is improved, and then you have to decide about some biological agents.
Yeah, so he was followed up exactly like how you said. His IgE did come down and his ABPA was under control, but what was bothering him was his eczema. And this was a classical, the Th2 pathway. We know that we have Th2 high and Th2 low varieties of asthma. And this was a classical, probably the Th2, the eosinophilic pathway, which is like manifest because of IL-4, IL-13 and IL-5 and the mast cells and the histamine release and the eosinophils which cause it. And I'm not going to go into the endotypes, the subendotypes of the different phenotypes of asthma because that's a lecture by itself. And we know today we have biologicals at every step which can be used, but the problem is still we need lot of data before we can really use biologicals in children because most of the data that we have is maximally on omalizumab and rest of the data is more in adult patients and very small data in children. So this is the list of the drugs that is available today. In our country today, we have omalizumab, we have dupilumab available, and mepolizumab available. So we have 3 biologicals available, and very soon you will have the other ones too.
But I told you, madam, in this child, dupilumab will work the best because he's having an uncontrolled skin disease and you cannot use immunotherapy. So
yes.
Dupilumab will work best.
So we thought that we would give him dupilumab, but we took a reference to, before we come to that, I will come, that will be my last slide. Just one line answer, our time is up. Which biological and when? One question each of us can take and finish it off.
Oh, we can use omalizumab, we can use mepolizumab, we can use dupilumab, all about 12 years, about the age of 6 years. About 12 years, we can use pendalizumab. About 18 years, you can use resilizumab. Then tezepelumab, we can use about 12 years in both severe asthma, which is non-T2 as well as T2.
Yeah. Dr. Kabra, any adverse effects? Should we worry about biologicals?
Say for biologicals, 3 things are to be kept, whether they are really indicated. Say in this child, his asthma is uncontrolled despite appropriate treatment. Look for eosinophil, peripheral eosinophil, look for IgE and comorbid condition.
Absolutely.
So if the IgE is raised but eosinophils are modest, omalizumab is the good. If IgE is raised, eosinophilia is raised, then anti-IL-5, mepolizumab and others. If there is a comorbidity in form of a dermatology or upper airway sinusitis and chronic rhinosinusitis, then dupilumab. As of now, this is the indication.
Perfect. Okay. So I'm going to skip all this. This child was started on JAK1 inhibitors for his eczema because that is a drug which is well defined, plays a crucial role for inflammation and autoimmune disease. And we were actually contemplating to start him on dupilumab, but we took a reference to a skin person. He said his asthma is reasonably under control now, with ABP under control, with iotropium in place, but it was the skin which was bothering him, and he's doing very well with the JAK1 inhibitor. So currently we have not put him on biologicals. So this is what the case is. So take home message that most difficult asthma is actually inadequately treated asthma. Severe therapy-resistant asthma is a diagnosis that must be entertained after all other causes of difficult to treat asthma have been ruled out. Most common causes include adherence, compliance, technique, dose, delivery, comorbid conditions and triggers. Keep in mind an alternative diagnosis if asthma is uncontrolled, and spirometry is a very important tool to at least differentiate an obstructive from a restrictive disease. And biologicals and severe therapy resistant form a very small subset, and you really need an expert advice of panels like this to take you there and give that treatment. So when you reach that stage, that is a patient for a tertiary care referral. Thank you so much.
Thank you for the
And I think I need a loud applause for my panelists. I think they've done a wonderful job.
Thank you for the wonderful session. We will now go to the last session of the day, and that is deciphering the images. The moderator is Dr. Atul Gupta. For the first session on chest X-ray, Dr. Shapan Rai.
Thank you, sir.
Thanks to the audience which is staying still now, and and thanks to the organizers for giving me this opportunity to moderate this session. And I will be the person holding the fort, and I am the oldest surviving member of this chapter of West Bengal, started in 1994. So I am probably placed here to hold the fortress. Now I have 4 panelists here. Will they come here only? Dr. Shopon Rai, Dr. Mihir Sarkar, Dr. Kaustubh Choudhury, and Dr. Pallab Chatterjee. As this topic is on deciphering the images that we were first used to was a plain X-ray. Then came digital X-ray, where you can have some modification in the exposure all. And then came the CT scan, and now the ultrasound is proving a very useful tool, especially in the emergency room, for diagnosis and management of pulmonology cases. And for this, we have first 4 jewels in the crown of our this chapter. And first one is Dr. Shopon Rai. He is now at Kishanganj as professor. Dr. Mihir Sarkar, professor at Medical College. Dr. Kaustubh Choudhury at Apollo. And Dr. Pallab as bronchoscopist, as we all know. We first start with Dr. Shopon Rai, which is images. Dr. Shopon Rai.
Good evening. So, Otullah, I was also your companion during your early days of asthma awareness program. Even in Bagnan, we went there. So, next couple of minutes, I'll just take you to the world of black and white. Actually, Shubhashish has told me, Shopon, you have to tell something, that diagnosis is something else by the history, but when you got the chest X-ray, that diagnosis totally changed. So, whenever you will feel bored, you tell me, because I have got almost 60 slides. So, whenever you feel bored, I'll stop. Okay. So, a 5-year-old girl came to our OPD for recurrent fever. The examination revealed acrolysis of the terminal phalanges, and which were bulbous in appearance. The child had very short nose. So this is the child. I have not blocked the eyes, because if I block it, you will not be able to appreciate what is the disease is. And this is the child, 5-year-old child. This is the hand, both sides, the bulbous and the acrolysis. So what is the diagnosis? I want introduction. I may show less, 3 or 4 slides. So what is the diagnosis? What? Ellis-Van-Creveld syndrome. So this is the X-ray. Now the diagnosis. Look carefully. So the lateral half of the clavicle are absent. So diagnosis is the lateral half of the clavicles are absent. So diagnosis is Hutchinson-Gilford disease. By diagnosis this, by seeing this, we can easily diagnose this is the child of Hutchinson-Gilford disease. The common name is progeria. So you have all seen the PA. And this is the X-ray of the ectramula. I have still there. You can see the lateral half is not present. An 8-month-old baby having fever and incessant cry came to our OPD, and he was a son of a physician. no lymphadenopathy. He was crying, particularly on touching the right side of the chest. Any guess, Basudev da? অনেক কোশ্চেন করেছে সকাল থেকে, এবার আমার কোশ্চেন করার পালা। নাও বলো। So forgotten trauma or any trauma. So there was no trauma. Platelet count was 6,50,000. So diagnosis? The audience. ICH এর লোক হলে হবে না, ICH এর লোক। So echocardiography, no coronary disease. আমি তো X-ray দেখালাম না। Now what is the X-ray? What is the X-ray showing? So some madam told there's the thickening of the ribs. These are the lamellar depositions of the ribs. There is the infantile cortical hyperostosis or Caffey's disease. Shubinita has given the answer. Actually, she was there when we got this patient, no? So, a 9-month-old baby was admitted in the IPD with altered sensorium. Eta bolte parle chocolate. No history of fever, trauma, scanty urination, or excessive urination. Means not diabetes insipidus also. Hematological investigations were all normal. CSA was also done. It was inconclusive. So any diagnosis in your mind? Now, bolo na, please. Please, bolo na. So I am showing you the X-ray. এটা আমাদের মডিউলেও আছে। So, বল। Yes? No. Osteoporosis দেখাবো পরে। So, look at the anterior ends of the ribs. The ribs sclerosed. Actually, the age, 9 months, I have not obscured it. So, the baby started crawling, and at that time, there was battery, they used to use lead, and the child swallowed the battery cells. And it was diagnosed not by me. It was diagnosed none other than late Professor Joyanta Bose. And he said, look, this is the X-ray, and we are not finding anything else. It might be the lead toxicity. So X-ray can give you a picture which you cannot guess. Lead encephalopathy. So 1-year girl child was admitted for fever for 15 days, associated with cough. Her mother was a known patient of abdominal tuberculosis. She was on ATD for last 1 month. No developmental delay, and the child got this rifampicin, ethambutol, and pyrazinamide and isoniazid from outside. After a few days, the grandmother, in our round, the grandmother told that the girl has weakness of the both lower limbs, and when I examined, I found there was ankylosing. So what can be the diagnosis? Shomodip, tui chili. What can be the diagnosis? So this is the X-ray. You can see on the left upper lobe there is a homogeneous opacity or pneumonia-like thing, and the lateral view you can see a globular shadow. So what is the diagnosis? না ঠিকই আছে, এই তো ঠিকই আছে, এই তো rib, 12 rib. So this is a case of neuroblastoma. Actually, the nystagmus or pendular obstructionous myoclonus, they come much more later. So this was a child of neuroblastoma. So metastasis in the spine? I'm getting you the MRI of the spine. You can see it. Okay, satisfied? A 2-year, 3-month-old girl presented with pallor and occasional cough. The sputum was not profuse, but bit rusty. And CBC revealed that hemoglobin was 7 grams %. Total leukocyte count is 31,300. and the neutrophil 56, the eosinophil was not high, hyperchromic microcytic anemia, iron profile serum iron was low, and the total iron binding capacity was increased. Reticulocyte count was high, and the direct Coombs test was negative. HPLC was also done. Malaria parasites was negative, HPLC was non-contributed, it was normal. Stool for occult blood test was positive. Diagnosis? So that was a clue, rusty sputum, and we did the X-ray. There was homogeneous opacities throughout the lung fields, and we have done a CT and lung biopsy also. There's a hemosiderin-laden macrophage. So the chest X-ray can tell you many more things along with obviously the history. This is the patient of Kishanganj. The RC Parveen, a 3-year-old girl child, presented with the abdominal distension, pallor, delayed developmental milestone. So the pallor was noticed for last 5 months, and the abdominal swelling was for 1 year. And the developmental milestone started delayed after first half of the infancy. Means after 6 months, the child couldn't achieve the developmental milestone. No fever, non-consanguineous parents, and the generalized pallor and the coarse faces, depressed nasal bridge. Height was less than 3 standard deviation. So was the weight. Medium circumference was 11. Head circumference was long. So you can see the child. This is the face. Birth weight was low. And developmental milestone, you can see the circuit sheet with support after 11 months, without support 15 months, and the child started walking with support at 3 years. So we have done the USG, the moderate splenomegaly, massive hepatosplenomegaly, umbilical hernia. WBC was low, RBC was low, platelet was low, reticulocyte was low. It means the marrow is not functioning properly. So what is the differential diagnosis? So we also thought Gaussian, the liposomal storage disease, chronic liver disease, or malignancy. So this is the chest X-ray. This is the better view. Now you can see, what is this? This is the spatula shaped. If you have used spatula, this is the spatula shaped ribs. So we went for this thing. You can see, this is the globular, these pelvic bones, and the acetabula is slanted flat. The coxa vara deformity. Diagnosis, there is a bit, beaking was also there. So, yes, MPS. So MPS, I'm showing you that X-ray. If you just look carefully, see these tips of the ulna and radii was not looking towards each other. So it was not a case of mucopolysaccharidosis. No, this was not a case of mucopolysaccharidosis. We have done this genetic testing, and this genetic testing has revealed this is a case of sialidosis or mucolipidosis type 1 with Fanconi anemia. আমি বলছি পরে আমার টাইম শেষ হয়ে গেছে and this is the book from where it supported our evidence. Now look at the first morphological photo we have seen. This matches with this one. So this is the mucolipidosis type 1. Subhasita, should I stop? Thank you. Thank you.
Thank you, Dr. Rai, for his very nice demonstration. And next we have Dr. Mihir Sarkar.
Okay. So, a very good afternoon. So, briefly, I will try to cover up the lung ECG that we practice in day-to-day practice in our, maybe in the ICU or in the emergency, maybe also applicable in wards. So, it is now rapidly being utilized in all setups, starting from the emergency ward and the ICU, because it has a lot of good advantages like immediately bedside availability, you can do it repeatedly, cost is less, radiation exposure is less, so there are a lot of advantages. So what is the basic principle of lung USG? So actually the radiologist says that lung USG is not possible because it is the only air, so the ultrasound beam will directly go through it, there will be no reflection of the ultrasound, so it is not possible. But the only part that is visible is or seen is the pleural line, because the visceral and the parietal pleura, they have the fluid inside it, the pleural fluid, that's why the ultrasound beam reflects from it, so that can be seen. And actually, the lung ultrasound is basically the study of artifact. So if the lung is diseased, that is the air, or it is pushed by the air or fluid, or there is a disease process and the artifact that is being produced by the movement of the pleura, so we study these artifacts and we come to some signs and some lines and some signs. So these are the main things of the lung ultrasound. So how do we do it? The main basic technique is that you have to put it we do it in the 6 places, left side and the 6 sides on the right side. So this is the upper anterior and the lower anterior, upper axillary, lower axillary, in the back, the infrascapular and the interscapular. And we can use both the phased array probe and the linear probe. The phased array probe allows the better penetration, so we get to the deeper structure, and the linear probe better resolution, but the penetration will be less. And we use the 2D mode and the M mode. So if you look at these normal findings, you can see these are you can put the probe in the horizontal or vertically. These are the ribs, so these black ones are the ribs, and these are the normal lungs. So you can see that this is the glistening white line, horizontal line is the pleura, and these are the horizontal, this is the reflection or reverberation of the pleural line, we call the A line. And if you look at it, that is the fluid accumulation in the interstitial space, that is the interstitial edema, you will get these laser-like lines starting from the pleura and going throughout the ultrasound screen, and these are called the B line that indicates the interstitial edema. And if you look at here, if it is the alveoli is filled with the fluid and the debris, what is happening there, and there is some inside that the consolidated process, there are some air bronchogram are present, then the ultrasound beam is reflecting, and that gives the reflection of the consolidation. So the lungs looks like a liver, so it calls the hepatization, and where the bronchogram are present, that the ultrasound beam reflects and they look like these white dots, it is called the thread shine. So how does it look like? If you look at the video, you can see how the normal lungs look like. So you can see this movement is very important to look at this movement of the pleura. This is called the lung slide. So this is the indication of the normal lung. Along with, you can see the A lines, and if you can put the M mode, you will see there is called if you look at remember the waves of the sea, and this is the sand. So this is why it is called the M mode, the seesaw sign. But you have to remember is that this seesaw sign can be, or the normal lung can be also be found where the lungs are hyperinflated, like the asthma patient, or the bronchiolitis with the pure hyperinflation, in the children with the mild viral illness, or the pulmonary embolism without infarct. So the normal, so this is the disadvantage of the ultrasound. There's even with the hyperinflated lung looks like a normal lung. So how the look like the interstitial thickening or the edema or the fibrosis. So you will see the B line. So you can see here in this video. So this is the pleural line. It is this is the pleural line. And from the pleura, there's the white, the laser-like lines are coming down. So these are called the B lines. And they are the distinct B lines. But if you look at here, the B lines are many B lines are there. They are coalesced with each other, and they are called the confluent B line. And along with that, so this indicates the B lines are the artifacts, this replaces the normal A lines. So these are the laser-like line coming from the vertically from the pleura throughout the screen, and there are different scoring system that how it indicates the severity of more the B lines confluent, the more is the extravascular lung water or more the interstitial edema. So how the pneumothorax look like? So suddenly if you have got the patient on the ventilator or if I put a line, the suddenly patient develop hypoxia. The X-ray will take time to develop the signs. But if you look at here, this video, you can see here, so this is the normal part of the lung. It is sliding very well. But if you look at this part, here there is the absent lung sliding, so it is not moving. And if you put the M mode here, you will give this the barcode-like sign of the stratosphere's line. So even before doing the X-ray and the patient is deteriorating or desaturating, you can put the ultrasound probe and you can easily identify that the patient has developed pneumothorax and give the immediate intervention. So similarly pleural effusion, you will see there's the sinusoidal sign. So this is the fluid collected. If you put the M mode, you will see that the visceral pleura is moving during inspiration and expiration. This is called the sinusoidal sign. You get the patient with the dengue or the nephrotic syndrome where there is a huge pleural effusion. If it is increasing day by day, so you can assess the patient who is having the amount of the capillary leak in this patient. So these are the very important tools in the bedside. So how the infection look like? So already I have told you. So this is the video of one of our patient. You can see. So it is you can see the cardiac pulsation is just forwarded, just traversing through it, and you can see the hepatization liver-like structure and this white dots called the thread sign. And if you look at this, give the color, you can say the increased vascularity. So vascularity is maintained, and this hepatization of the liver along with the thread sign that indicates the pneumonia and the consolidation. So you can corresponding X-ray you can see. So before patient is coming in emergency with the respiratory symptom, cough and respiratory distress, before going doing the X-ray, you can identify what is the problem there. So now, how the viral pneumonia looks like, this is the lobar pneumonia. So if you look at the viral pneumonia, what you see in this, you can look at this video. This pleural line, you can see these pleural lines are not very smooth. It is being ragged, and that is the breakage of the pleural line, and you can see the subpleural consolidation. So this is the thread sign, there is a scattered thread sign in the different areas. So and along with, you can see this the B profile, that is the laser-like lines. So thus in a patient coming with the signs of pneumonia, with this ultrasound in the emergency, you can identify if it is the lobar pneumonia, the consolidation that is most suggestive of the bacterial pneumonia, or it is the interstitial pneumonia that is most suggestive of the viral pneumonia. So the presence of the B line, irregular pleural line, and the subpleural consolidations and the scatter subpleural consolidation are indications of the viral pneumonia. So this is one of the study we did during the COVID. So how the COVID lungs, the USD looks like. Again, this interstitial syndrome, fragmented pleural lines, and the subpleural microconsolidation were the main features how we can diagnose or identify the patient with the COVID pneumonia. So now the patient, this patient with unresolving pneumonia. So if you do the ultrasound, now what are you seeing here? Can anyone say what we can see here? So this is the pleural space. You can see that is the septate empyema, and what you can see here, you can see the lung abscess. So the unresolving pneumonia, so this is against the organized cavity, along with there's the air, and there's some this transute that is floating here. So this is, and if you give this color Doppler, you will get the increased vascularity. So the unresolved pneumonia, if it is going to empyema or it is the lung abscess, then you can take the decision what intervention you can do, because this type of this septate empyema, only the chest drain will not suffice. The VATS will be the ideal, or the chest drain placement followed by streptokinase or the urokinase should be the given to break this septa and the adequate drainage. So overall, what is the sensitivity and specificity? There is the over the comparison of the lung USG and the chest radiography. There are very chest radiography has a very good sensitivity in comparison to the chest radiography, and far better in case of pleural effusion and case of pneumothorax. And the specificity is also the similar. So it is a very good important bedside tool. Now to this patient just came a few days back, the 7-month-old progressive respiratory distress, fever and cough for 2 days. This is the chest X-ray, and our resident is ready with the chest drain to put this patient as the chest drain. Will you give the chest drain here in this patient? What is the lateral view shows? And now look at this lung ultrasound. So what is showing that it is not of any fluid. It is the liver-like structure with variegated appearance with the fluid and the solid structure. So do the CT scan against this variegated appearance and the collection in the anterior mediastinus, possibly hematoma or teratoma, and the surgery was done and the biopsy was done which showed that the teratoma grade 1. Again this patient present here now against a similar type of X-rays, again the 7-month-old, this type of whole opacity in the left side of the lung, and if you put the ultrasound here, what you can see, look at this ultrasound. So lung is very thinned out. So this is the lung tissue, and this is the whole pericardial sac. So this is the huge pericardial effusion, and if you look at the heart, you can see there is the huge mass in the right ventricle. So this is the right ventricular rhabdomyoma presenting like this white out opacity. This. So that's how our bedside ultrasound can help you out, definitely to take decision. So lung ultrasound is a holistic discipline and represents a relevant alternative or addition to our traditional radiological examination, and it is useful tool for follow-up the patient with pneumonia and monitoring the effectiveness of therapy. Thank you.
Hello.
Last case, this is the right ventricular rhabdomyoma. The two options are there. Now the iberelumab is the monoclonal antibody that can reduce the size or the surgery. The surgery at present is not possible according to the CTB, so we have started the iberelumab that will gradually reduce the mass, and later on we have to do the surgery.
Thank you, Mihir, for presenting POCUS, the point of care ultrasonography, which is very much helpful now in the emergency room. And now we have Kaustubh. We will be presenting the CT scan.
Where is the pointer? Pointer. Our pointer. Okay, before I start, I think I should acknowledge two persons. One is the organizer for giving me this opportunity to talk about CT chest in pulmonology, and second is Dr. Sanjeev Mojumdar, who is actually a radiologist, who actually give me all these different slides and the different presentations, and I think CT chest of our patients. So the disclaimer is another one, that I am not a radiologist, I am a pediatric intensivist, so I am taking only those focused CT scan findings, those which can be useful for our practice. So moving on to the case, it's now in our PICU, 6 months old, severe respiratory distress. In our PICU, chest X-ray was done by, which is suggestive of right-sided consolidation. UHS lungs has been done, which is suggestive of necrotizing pneumonia. CT chest I will show, and bronchoscopy already done by Dr. Pallab Chatterjee, which shows human rhinoenterovirus, and rest of the diagnostic reports are awaited. This child is responding to anti-staph coverage, and CRP is decreased from 18 to 3, and we are planning for surgical intervention. Let's see the CT scan. Just go through the CT. The cursor is going down from above below, and accordingly the CT scan in the coronal section we are getting the marker. Can you identify the structures? Similarly, it's going up, and you can see that in the right side, in the chest, right side, you can see that the mass is visible. So looking at the CT, what has been shown is that basically X-ray and CT, the difference is that X-ray is basically a two-dimensional figure where structures can superimpose. But CT gives us a three-dimensional picture, as well as the structures can be separately isolated and identified accordingly. So if we go through the basic principles of CT scan, so CT scan, when we are talking about, this actually, as per the cut, as I have shown, is giving us the window of different parts. And the Hounsfield unit, which has been unit of the CT scan, where water is taken as the base, which is 0, from which if the structures are more dense, then it gives a positive Hounsfield unit, like bones, then muscle, then soft tissues. Whereas if it is low in Hounsfield unit, it is below water, which is basically negative Hounsfield unit, which usually gives like air or like adipose tissue. So here, if you are getting that this air, it is basically less Hounsfield unit. And these are the structures, and this is a long window where you can see the different structures, and the bones are obviously of dense structure. So similarly, as per the cart, you can get different types of structures in CT scan. So you need to identify where the cart is, and accordingly you just identify in the corner section what is the CT finding. So usually we take it like a upper part, that is where upper airway cart has been taken in CT chest, followed by the bronchus part, then subsequently comes that of that blood vessels, and lastly the cardiac. So these are the usual 4 scenarios where we can get the different parts of the CT chest. So this is the basically the portion of the cardiac chamber where you can see all the chambers also. This is the cardiac, the below down cursor where you can get the last portion of the CT. In all window, you can get the different layers of the chest in CT scan. So when we are talking about this chest CT, which we have seen that there is a different lobes of the lungs. It's from the, the cursor is, obviously you can see the trachea is visible. So visible trachea means it's on the upper cut. So obviously the lobes which has been visible in cases of upper part of the CT chest is that basically, if we just compare this to in the color code, it basically shows in the right, left, upper and lower is the usual dictum. So right, this is the right upper lobe, which is the right major fissure, and the right lower lobe depending on the cut can be visible. And similarly, in the left side, you can get the left upper lobe, which is a blue one, and then left major fissure is there, and the left lower lobe is visible like this. So similarly, if we are taking this view, this is typically, again, the trachea is visible, and as well as you can see the different parts of the bronchioles in this cut. So this is a typical lung window where it's in the middle portion of the CT part. So this is in the opposite direction we are going. So if you see the CT chest, and this is the window where you can see basically the cardiac chamber, and these are the different lobes is color coded. Like this is the right upper lobe, this is the right middle lobe, and this is the right lower lobe, and these are the middle fissure. This is a minor fissure and the right major fissure which has been demarcated, the right middle lobe and the right lower lobe. Having said that, again, there is a bifurcation of the this bronchus is also there. So you can see the right bronchus and lower bronchus also can be visible. Similarly, in the left side, you can see this color is basically the left lower bronchus, and as well as the left upper lobe and the right left lower lobe can be visible in the different color. When we just depict it into the CT scan, this looks like this. What is more important when you demarcate these structures, it is more to see in the concave, because you can change the contrast, and accordingly you can see that what are the different lobes. So here you can see that right upper lobe and the right lower lobe, here left lower lobe and the left upper lobe. So this is the bronchus where you can see the bronchus bifurcation. The right lower lobe is there and the right lower bronchus, compared to there is a right middle lobe is there, and as well as similar to this picture, the cardiac chambers you can visualize, and the chest findings also there. So this just gives us a sagittal view where you can see the mediastinal structure. So if you are taking a sagittal structure, then this yellow portion is basically the posterior mediastinum, whereas the blue one is basically the middle mediastinum, and this pink color is basically the anterior mediastinum, because you know the masses originating from the mediastinum also differentiate between these 3 structures. So what are the usual structures we can see in anteriorly? So anterior mediastinum, mostly we are getting lymphoma or hyperplasia, mostly fat related like germ cell tumor or thymolipoma. then it may be, if it is water-like container, then it is a lymphangioma. Similarly, if it is a middle one, then foregut duplication cyst, lymph nodes can be there, like granulomatous or metastatic or lymphoma, leukemia, or maybe tuberculosis, or fungal can be a possibility. And you can get calcified lymph nodes also. If it is posteriorly, virtually, it is basically regarded as neuroendocrine in origin. And most of the time it is neuroblastoma, as Dr. Shopan Roy already shown one picture of neuroblastoma in the MRI, and second decade usually benign ganglio neuromas. So this, when we are taking in a coronal view, similar color code. So the red one is basically the anterior, this is the medial mediastinum, and this is the posterior mediastinum. So looking at that anatomical position of the mass, you can identify whether it's anterior, middle, or posterior mediastinum. This is called hilum overlay sign. So that's how you can differentiate between whether it's a lung mass or whether it's a basically mediastinal mass. So lung mass usually evade, and it usually doesn't change the blood vascular structure. Whereas if it is a mediastinal mass, it usually just pushes the vascular structure towards opposite direction. So that unit, this is known as hilum overlay sign. So by looking at this thing, you can jolly well understand this is a mediastinal mass to origin with. And if you have to identify that where the location is, whether it's anterior, posterior, or medial, so obviously if you do an coronal section, then you will get a clear location of the mediastinal mass, which is a basically anterior mediastinal as well. Similarly, mass in middle mediastinum also can be picked up by this coronal view, and this is a mass in the anterior mediastinal. We all can understand by this time. This is a tumor which is again showing hilum overlay sign. So obviously it's from the mediastinum because it's overlaying and it's actually not pushing the vascular structure. But when we are taking the coronal section, it is in the posterior part. So it is a posterior mediastinal to origin with, most commonly neuroblastoma. So now I am going to some typical feature of the CT scan. So here you can see in this typical picture there is a pneumonic consolidation, along with there is some area which is basically with that air structure also. So basically it's nothing but a possibility of abscess can be kept in our mind. So when we are talking about whether it's the mass, again the collection is from pleural origin or it is from the lungs origin or pulmonary origin, is again if it is like producing an obtuse angle, then possibly it is coming from the extrapulmonary, that is from the pleural origin. Whereas if it is an acute origin, so possibility of it is a parenchymal or lung pulmonary origin. So looking at this mass, you can all jolly well understand that this is an obtuse angle, so possibly this is a mass originating from the extrapulmonary. So similarly, if you see this structure, obviously you can identify this is the empyema which is air fluid level, and there is a collection in the pleural space. This is our case, almost similar to that of that CT scan I have already shown. Here you can see there is a necrosed mass along with that air fluid level, and air shadows are also there. So it is an infective origin. So nothing but it's a lung abscess. So this is a fluffy opacity in bilaterally both the sides it is present, and just parahilar, so it is more commonly towards pulmonary edema. So these are the ground glass opacities, these are the differentials. Keep in mind PCB as a possibility. We get cases of lots of post-adeno, PBO, post-infectious bronchiolitis obliterans, and these are the usually variegated appearance and lots of patchy opacities all over the lungs. So this is basically cryptogenic organizing pneumonia. Having said that, this is a very dangerous lung conditions that we have encountered during the epidemics of the adeno, but we always look for the better lungs, and we always look for this pathology should go into the physiological state. That is this one. That's what all we want. Thank you. Thank you, sir.
CT scan has helped us a lot to get into the pathologies inside the lungs. And we have now our friend Paul for bronchoscopy.
Good evening. It's very heartening to see so many people still around. So thank you very much. And now we've been talking about all these modalities of investigation, but what we always want to say is none of these investigations come in single part. So you have the history, you have the examination, you have the X-ray, you have the CT, you have the ultrasound, you have the bronchoscopy, and you have other parts of examination also coming in. So it is always a multidisciplinary approach. And now we have a lot of children who we are saving at a very young age, a lot of premature babies, and they come with other problems also. So the use of bronchoscopy is not only in the chest, we also have a lot of aerodigestive problems. So children having problems in feeding, children having problems in swallowing. So it's a combination of a multiple interrelated congenital or acquired conditions. That is what is an aerodigestive patient. It's somewhat a newer terminology. It affects the breathing, it affects the airway, affects the swallowing, and therefore the growth. And it requires a interdisciplinary diagnostic and therapeutic approach. So it includes the structural functional airways, the upper GI tract, the lung disease due to congenital or developmental anomalies. They have these genetic problems, they can have neurodisabilities, and they have feeding issues. So this is something very, very common nowadays. So all of us who are seeing premature babies surviving lead up to these problems, and we don't know how to tackle these. Common conditions that we see for these swallowing issues and all are choanal atrachas, laryngomalacias, various glossoptosis, vocal cord palsies, laryngotracheal clefts, laryngotracheoesophageal clefts, various stenosis, tracheobronchomalacias, tracheoesophageal fistulas, and children who are becoming dependent more and more on tracheostomy. So this was a child who was born like this with a huge mass in the neck, and the child had a very blue colored tongue. So that made us think that whether we are dealing with a child who's got a hemangioma which is there. So, and this is how the child was breathing. This is right at birth. This is how the child was breathing. So we thought we are dealing with a child with a hemangioma, a big hemangioma, and this was when we did the ultrasound and the Doppler, which showed that yes, there was a big hemangioma which is sitting there and which is obstructing. So they said that there is a large hemangiomatous mass which is there. So a child with a problem, we did an ultrasound, found something, and then we did the bronchoscopy. So why did we do the bronchoscopy? Just because we wanted to do it and just because everybody said that let us do something about it? No. We wanted to do the bronchoscopy to actually delineate what the child had, because it was difficult to tackle this child and feed this child. One thing that is very important is when you do a bronchoscopy, as the tongue looks, blue, everything looks, the skin looks red, the mucosa looks the color of the mucosa. So when you do a bronchoscopy, if there is a hemangioma, the color of the mucosa is the same color. So there is no difference in the color. Why we did the bronchoscopy was to find out where the problem was. And we found a huge mass. So you can see that everything is sort of collapsing inside and it is sort of closing the airways. So we wanted to delineate how is the situation. The airway was patent. The trachea was good. So we were confident that there was nothing inside. But what we had was that there was this mass, and if you can see, the mass was actually on the left side compressing. So here you can see the mass that was compressing the epiglottis from the left side. So there was a huge supraglottic cystic mass. The color was different. So that made us think that probably we are not dealing with a hemangioma alone. There could be something else along with it, and the pressure was coming from the left. So this was the reason why we tried to do the bronchoscopy, to try to feed the child. And if you see this child who was having so much of distress, when we put the child on one side and started feeding, the child was swallowing so well. So this child started feeding. We tried feeding this child on a lateral position, and this child started feeding well. And this is called the elevated side-lying feeding. So elevated side-lying feeding is the rib cage movement is eased, the work of breathing is reduced, you maintain the head and the trunk alignment, and the chances of aspiration becomes less. Which side you put the child, we understood by doing the scopy and seeing how the pressure was coming on the airways. So since the pressure was coming from the left side, we put the left side down so that the child could swallow well and the child started feeding well. Then we did a MRI scan of the bronchoscopy. Once everybody was comfortable doing the MRI, the child was around 2 months of age. And what was found was there was a huge mass, not only of the hemangiomatous mass, but also a lymphangiomatous mass. So it was a huge mass which showed lobulated cystic lesions, which was extending right into the mediastinum. So, and this was causing, and this was encasing the airways and causing luminal narrowing. But that luminal narrowing, which the MRI showed, was not physiologically significant, because when we did the bronchoscopy, we saw the airway normal, patent. So there was no issues with the airway physiologically, but anatomically, yes, there was this lymphangioma. So the areas that we were seeing, which was compressing the epiglottis on day 2 of life, was corroborated at 2 months of life by lymphangioma, which is sitting and compressing on the epiglottis. Now the surgeons felt scared to do anything. Previously they were saying that they will go ahead, they will give some bleomycin, they will do some surgeries or whatever. They said that with such a huge mass, most of it being lymphangioma, let us wait. And the child started feeding well, and currently off all support, the child was feeding well orally, gaining weight, developmentally normal, and this is the condition of the child at present. Nobody really wants to touch the child at the present moment. Let the child grow up, let the child gain weight, and then we will see. That is the current situation. So thank you very much, and thanks a lot for your support that we had throughout the day. Thank you.
তোমার এটা এয়ারওয়ে ম্যানেজ করা মুশকিল হতো যদি ব্রঙ্কোস্কোপি কোনো কারণে ক্র্যাশ করতো পেশেন্ট বেশি মতো
Let's give a applaud the speakers.
Just to one added
for a nice deliberation.
I think added thing.
Thank you.
One added thing is that bronchoscopy can be useful for intubation also. In a difficult intubation, bronchoscopy guided intubation is much more warranted.